Anurag, you let us know when to start.
I'm fine. I can start anytime.
I'm just wondering whether Siddharth will let us know. Someone has to let us know when to get off, I guess. Siddharth, are you there? Amit?
Yeah, Mr. Mitra, myself Pratik is there as a Siddharth. So we can start, sir. It's already in live.
Okay.
Okay. All right. So what I'll do is I'll do the opening remarks and hand it over to you, Anurag. Is that okay?
Yes, that sounds great, Jagdish.
Okay. Good morning, and I'm assuming good night, not good evening or very late night in the Europe, but I'm assuming there's a global audience that has caught up to this event, AI India. This is our second year, but it's an amazing mechanism in which we have delivering AI India. AI India will be primarily, obviously, virtual. And in that case, it's important that we all sort of recognize the fact that it's an opportunity to bring in some stellar leaders around the world to participate in it. And today, as we kick off the session today, it's an example of such similar leaders that have come on to play. And I think it will be a great experience as we start to move together, which is one of our biggest topics, most conversational in every conversation, whether it's work or home or outside, the health tech world. And no year could have been more relevant than the one gone by for the importance of health tech. And CII and India and AI India program group has done an excellent job of putting together this team of experts. I just thought I was looking for it and said, what is common? Oxford does a regular annual assessment called Word of the Year, where their academics get together to decide on what is that one word that impacted, influenced, or described the public during the specific year. That specific year in 2013 was selfie, or 2016 was post-truth, and in 2019 was climate emergency. The one word I think we didn't need Oxford to tell us what happened, but it obviously was the most important word in 2020 was pandemic. While the pandemic has completely upset our way of life, but the challenges there are also great opportunities. And that's what this panel is going to talk about. Most critically, COVID has also brought to the interest of the masses the miracles of cutting edge technology. What used to take 10 years was subsumed in a year and a half or so, and we were vaccines being discussed in this whole period, which is amazing work by folks that you will hear and during this. Artificial intelligence and machine learning are witnessing amazing adoption, just worldwide, but in the Indian healthcare setting. Surge of non-communicable diseases, aging population, and increased focus from the government on making sure healthcare for all is an amazing opportunity for technology to play a larger role. Studies have shown that deep learning algorithms have given better insights to clinicians. You'll hear that from some of our guys about stuff that even some of our companies, my company did around research around molecules. I'm sure lots and lots of those guys will come and talk about it today. Just an exhilarating session around artificial intelligence, making it possible to access the learning and data from hundreds of thousands of patient cases. But there are so many examples. You'll hear it from Dr. Anurag, you'll hear it from Manish from Google, you'll hear it from Pankaj. It's just amazing set of research work that has happened in this. And the thing that I think defines the health tech world today is speed at scale. So it's not just speed for the sake of speed, or it's not scale for something that was old, but speed at scale. And with topics related to building a global standard healthcare workforce, disease and affection amongst the underprivileged, healthcare delivery in rural India, and to global healthcare AI business from India, which is an absolute important area because you have such much data, so much of modeling that it's amazing what we can do with the work at CI. So let us sit back, let the experts take over, and thanks guys again for turning in. And this, we've all said, is a month-long event that we put together. The CII has put together for AI India. So it's a festival of AI that we are celebrating rather than a day of event. Thank you. And at that, I'm going to hand it over to Anurag. Anurag, all yours. Thanks for joining us.
Thank you very much, Jagdish. I'm going to share my slides. Give me 1 second. If all goes well, you should be seeing my screen right about now. Fantastic. So what I thought about today in this very interesting times of COVID that Jagdish mentioned.
Only thing, Anurag, your slides are coming in the display mode, so it's got your next slide also, which is okay. It takes a little bit of the excitement away, but I think you can.
Is this better now?
This is better. Thanks.
All right. So what we're going to talk about today is how AI is transforming healthcare. And we'll use some examples from COVID, although I will stay from the start. That if we look at what changed our response to COVID was probably tech that came out a few years before the most cutting edge one, like mRNA vaccines as an example. I think there's a lot more that is going to happen in time to come. And when we look back, we will see this year, 2020 and 21, as transformative years for the uptake of AI in health. Now, when we talk about AI in health, one thing I always like to make very clear, we are by far the laggards, by far. If you look at other parts, you look at finance, you look at operations, you look at almost anything, they have been using AI and big data far, far before we did in health. In fact, today, if you're using a smartphone taking photographs, you're using a huge amount of AI without even thinking about it. And I like to show this cartoon that if you take somebody born after 2000 and you were to show them film, they honestly would not know how we functioned in those days. And it's only been 2 decades. I mean, it's not that far ago for those of us of my age. But honestly, kids of today would not even recognize a film camera. Yet most of health, most of what we do would be very, very recognizable to a doctor trained in the 1960s and 70s without any problem whatsoever. Just as a point of contrast. Now, India happens to be one of those countries which, in my belief, have got it right. We started with simple things. We started with a digital national ID. We started with UPI. We were able to make presence-less, cashless transactions as a first goal. So what we did is we built a digital economy, a digital governance. Before, in 2020, during the pandemic, we finally finalized something that had been brewing over multiple years, the National Digital Health Mission. Now, this envisions something that is just unique. Every person to have access to all their medical records. Now, I'm not telling you this is going to happen tomorrow. But the point is, we first built what is called the India stack. Allows us to have multiple cross-functional systems. And on top of the India stack, we are now planning to build a health stack. Now, this is the right way to go about doing things. And I think India's vision will be one that many people in the world will look at in time to come. Now, the other warning I always like to give is whenever you take any new development, there's always going to be the Gartner's 5-step hype cycle. There'll be the tech trigger. In the beginning, there'll be a peak, then there'll be a trough, and then you'll be on the slope of enlightenment. And of course, there is no guarantee in this world that all things come with only one peak. Sometimes things come with two peaks. It can even be 3 or 4, but I can't find camels that look like that. In health, let me say this. The first peak came in the 1980s, in AI in general. But computers and medicine, the first peak is long over. And this time around, we are working on tech that has been grossly deployed in other fields. So I think we are in far better shape than we were in years past. So what are the fundamentals of AI health to me? First, unlike many other things where AI itself is the focus, in AI health, health is the better half. The purpose of AI is not to advance AI in itself, but to improve access, quality, affordability, and these last two words, very important, equity and justice. And this is why I'll make my first statement that AI is not the only way there, but will be a very important part of a full holistic vision. Now, in the developing world, India is one of them. We have limited health infrastructure, and we need to improve our health services beyond the skilled manpower. We simply don't have enough of it. On the other hand, the developed world may have enough manpower. It may have enough health services. It may have even achieved UHC, but it needs to keep improving them, particularly when faced by a rapidly growing population. If you look at the average age of Taiwan versus the average age of India, the average age of Western Europe versus average age of Africa, the difference is just enormous. When you look towards the future, you look for a manpower intensive industry. Look for the amount of needs of aging people. None of us anywhere in this world is anywhere near ready, and all of us will need AI to some degree or the other. It may not yet be autonomous services, but there will certainly be decision assists. And if you think of them as amplifiers, services that make a limited amount of high quality manpower or even medium or even less skilled manpower function better and more effectively, that is going to be the main point of AI. The second fundamental I will say right up front is that IA also has II and IA. So AI comes well after you have intelligence augmentation and well after you have intelligent infrastructure. Now, if you don't have these two, you don't have the web of physical entities that makes everything operate, you're not going to be able to suddenly deploy AI. And that's the part I mentioned, how India is getting the entire system right, where we are building the infrastructure, we are doing the simple things, computation, data, digital platforms, presence-less, cashless services, allowing people to function better. In fact, once you add on to it, simple things like digital guidelines, you will find that most of the definable tasks in healthcare and governance can be done without we get into the domain of pure AI. Fundamental 3, and this is just a purely personal one because there are many ways in which one can define AI. For the purpose of what I will talk about, we'll be talking about machine learning. And I will not get into the details of it, but very briefly, there will be 4 kinds. Supervised, the humans have learned to label things. We want the machines to do it. The humans know the task, machines learn to do it. Unsupervised, we don't necessarily know what we are doing. We have a bunch of things. We may have a new disease. We may have people who have a different type of COVID compared to others. We want the machine to find it. Semi-supervised, a mixture of the two. And reinforcement, we want to make a policy, a decision policy. That policy will have an effect. We want to make the best policies. It's going to go round and round until we get it right. I'm going to use just this one slide to talk about the power of AI. I really do not wish to spend a huge time on that. And I like to call this slide from Verily truly eye-opening. Verily, as you know, is Google's health company. And all of us have heard about their ability to diagnose diabetic retinopathy. Now that example is old, but this part that I'm telling you will never get old. Not only were they able to diagnose diabetic retinopathy, which ophthalmologists can do quite well, from the picture of the retina, they could tell the age, they could tell the gender, they could tell whether the person was a smoker, they could estimate the mean blood pressure, and they could estimate cardiovascular risk. All this from a photograph of the retina. Now, if you were to ask a human, can you tell the gender from the picture of the retina? They will say, well, we can tell the gender well before we start looking into people's eyes, but there is no way that an ophthalmologist, even the most well-trained one, can tell you gender from a retinal photograph. And the idea that a retinal snapshot will tell you CV risk is okay now that I think about it. I mean, after all, there are blood vessels, microvasculature. We know that microvessels going bad is how all these problems occur. But if somebody had told me beforehand that this would occur, I would have been disbelieving as a medical doctor. Then comes the challenge of data, right? I mean, you could say, if you're not going to see this, who has the time to annotate 40, 50,000 retinal images? That's what it took to get this done. That problem also is getting crossed. Now AIs train each other, with one AI creating synthetic images, the other AI differentiating them from real images, in the process going round and round until the second AI and the first AI are having difficulty fooling each other. At this point, the machine knows what an echocardiogram, the type of picture I'm showing here, looks like, even though it may have no idea what an echocardiogram really does. But really speaking, from this point onwards, transferring the learning of what that type of medical image is, only in a few hundreds to few thousand images, differentiation and labeling and classification can become much faster. So we are getting into what India needs. Ability to use few annotated images to get advanced label classification, because we don't have the type of ecosystem in which doing all these things at scale is presently possible. But this brings me to something that I talked about during the COVID pandemic, that in India we need to focus a lot on the digital health divides. When we talk about AI for health, we have to consider that we will be using it in pictures at the top, looking at hospitals that look like this, as well as hospitals that look like this. We'll have to go through the three important stages. The important stages of digitization, digitalization, and digital transformation. People think of them as the same words, they aren't. When your work is analog and you're trying to simply maintain digital copies of it for efficiency, you're only at the first stage, digitization. If your working has become fundamentally digital, and you're generating like a top quality hospital of India, you're digitalized. When you're tying everything together into a digital health mission, where your universal ID will allow you to fetch your own records, where everybody will have a health stack identity, where every process of the healthcare system will be connected to each other. That is digital transformation. And like almost all of you who must be listening, if somebody told me that digital transformation was coming anytime soon, I would have said, no, it's at least a decade away. But COVID-19, I think, is the wrecking ball that has changed all our previous perceptions. To understand how fast we are moving today, let's quickly look at the history of telemedicine in India. As far back as 2000, ISRO, Apollo, villages in Kerala, South India were implementing telemedicine. We had our first telemedicine task force in 2005, but it never really took off. In fact, there was a high court case in which there were certain judgments, which I will not comment on, which made many people very, very worried about using telemedicine or even teleradiology. Recently, the government came out during COVID of the new telemedicine policy, making it completely legal. But it took 20 years to get a system that in the hindsight seems very obvious for a country like India going, because there are always challenges when you implement something new. And those of you who know the story of Arogya Setu Mitra will also realize what I'm talking about. So when Arogya Setu Mitra came in, the motto was, we step in so you do not have to step out. Through it, you could get free online consultations from the government and from private players. You could get not free home lab tests. You could get not free home online medicines. It was tied into the Arogya Setu app so that after you have found out your status, you could immediately link out and go towards these services. But it's down. So many companies invested in it, but the minute the initial scare went away, people asked, can you use a government portal to create a link to e-presence services that may disadvantage real brick and mortar systems? And I do not know what the legal answer to that question is, but I do know that Arogya Setu Mitra that I wrote about in the science article as a very important development for India, showing the speed at which we responded, was taken down by the time my article even got published. So I had to add an addendum that these are the challenges of a new digital world shaped in the face of the pressures of a pandemic, which haven't fully navigated the real challenges of deploying AI and digital health into the real world. Why it normally takes years for digital health products is because first they undergo technical validation, then evidence, then regulatory clearance. I will come very specifically to regulatory clearance of AI, then awareness and credibility, and then effective commercial models. Now, we have shortcut a few of these things in the time of COVID. For example, digital symptom checkers, pretty well used, remote patient monitoring, got implemented pretty fast, regulatory clearance is done, credibility is there, effective commercial models yet to come. Digital pharmacies, today I order more stuff even after the initial threat has gone away, the city is back open. I'll probably never going back to actually standing in a pharmacy, at least I'm speaking for myself. And that's going to be true for many of you. And for many of you, how you manage your orders, how you operate the back end of your health portal will have more AI than the front end of your health portal. Digital disease management is, of course, where you would really want to see front end AI as well as back end AI. But that I think is still going to be some time to come. I will give you some examples of what I think is coming. So where I see the impact of healthcare in coming years for digital health and AI combined, face-to-face care, analog will remain. Telemedicine care is fundamentally just digital as an intermediate to two analogs. Medical chatbots, I think, are going to grow very fast. Most routine queries, the front door of your access to the healthcare system, might become medical chatbots. And I think within this decade, before 2030, we will see what will be called digital twins, where all of us, well, not necessarily all of us, but many of us who are early technology adopters will have a version of us in the real world and a version of us in the digital world. This digital world could have our genomes, it could have our wearable device data. It will be continuously acted upon by algorithms. This data will be private to us. Algorithms will come and work on it. They will take back not our data. They will take back only the learnings from the data. And if those learnings are actionable, it will cross over into the real world. And an alert might come to us from our healthcare systems saying we need to visit a physical doctor. So for every 1 hour we spend with a physical doctor, there will be thousands and thousands of hours of digital twin medical care happening in the background. That I think will be the real vision that I see over the next decade. And to those of you who are my age who remember the book To Serve with Love, may have seen this book by Judith Newman, To Siri with Love, where she talks about her son who was autistic, who had trouble communicating with humans, in the end had a very, very strong bond with Siri, who with infinite patience could interact with a young child, providing information. For many of us who have questions, who have doubts, who want to know more about their medical care, may want to prefer the digital system. In fact, if you look at what people want out of healthcare and their top complaints, my doctor is never available, my doctor keeps me waiting, my doctor is not up to date. Think of what I said about To Siri with Love and think about what people want out of doctors. And you will see why Eric Topper, in his book, The Patient Will See You Now, is not too far away from the future. I think there will be resistance. I think there will be difficulties. Health is a much more regulated model for good reasons. After all, lives are at stake, but these things are going to change. I will also point out that when patients usually see, on the behalf of my fraternity, when patients usually mean my doctor is not up to date, they often mean the Doctor does not read what I read in Google. Sometimes good, sometimes not so good. So this is the first symptom reasoning engine that I think is of decent quality. There are many more on the way. It's called ADA. I encourage those of you who have not seen it to look it up. It operates in multiple countries. At the back end of it is a symptom reasoning engine. You enter your symptoms. It can help you understand whether you are unwell enough to require medical care or can be simply triaged. And even if you decide to go to medical care, it might give you some ideas of what you might actually be suffering from. So you can have a reasoned conversation with the healthcare system. So NHS was using it in UK to reduce the burden on general practices. And I think if there is one thing India will need a digital triage system in which routine healthcare decisions that don't really require a doctor do not unnecessarily end up clogging our limited healthcare infrastructure. And I have personally used it a few times, tried feeding in questions for simulated patients. I find it does reasonably well. Nothing is perfect. And I could tell many stories of how a simple thing like a swollen leg could mean something entirely different for a jet setting traveler, where it could mean a clot in your legs that would go to your lungs, a medical emergency, versus a situation that I have faced personally, where a domestic worker of a friend had a swollen leg. I went through my usual things, having trained a lot of my life in America. In the end, a fruit seller who was visiting the house diagnosed the patient better than I could, because in the village where the fruit seller and the domestic worker came from, filariasis was rampant. A single red swollen leg meant filariasis in that part of the world. It's a worm, and treatment for that worm took care of the problem. I'm going to start making a very important point about AI and health. AI is not new. I mean, this has been around forever. Jan LeCun, by the standards of what we are talking about, years being important, the critical work of Jan LeCun was done in 1988. We have been through one major hype cycle in AI and medicine. We used to see articles like this, and this article is from 1970. Medicine and the computer, the promises and problems of change. You can see the last line. In some cases, largely replacing the intellectual functions of physicians. This is what people thought in 1970. This is an actual transcript of work from this paper in which a computer and a doctor are discussing acid-base balance. It was a problem taken to be suited for computers more than doctors, but these kinds of conversations you find from 1970 papers of the New England Journal. All of you know Gary Kasparov, the second fight, the rematch with Deep Blue, the brain's last stand. It was not probably real AI. I would not call it that, because it was programmed to do only one thing, to play chess. And you know that even your smartphone, if you have a latest version, has more, at least mathematical processing power than Deep Blue. The one that you see on the right-hand side, All Systems Go, where you can see Demis Hammabis company, fundamentally DeepMind, started to do stuff that was truly machine learning, computers learning from watching humans play and becoming better than at least the second best human of that time in AlphaGo. So I mean, what DeepMind does, and DeepMind is now part of Google, is now to the point that given only the rules of chess, never watching humans play, after just 4 hours of self-training, AlphaZero beat the most powerful computer program in the world that grandmasters cannot get a game out of. That's 2017. You go one step further. DeepMind, AlphaGo, AlphaZero. Now you have AlphaFold. AlphaFold can, almost in the same way that you play a game, as long as it's a reward for being right and you have enough examples of being right, given enough amount of data, DeepMind's fundamental approach can transform anything. And solving protein structures is absolutely critical to drug discovery. It's critical to medicine. It's critical to the future of medicine. And this is going to be a gamer growing up to becoming a scientist. And this from 30 November 2020. I completely agree with the title in Nature. It will change everything. Already we are seeing the first AI antibiotic, again last year, Helicin, named after Hell, for those of you who are Arthur C. Clarke fans. You'll recognize it, a deep learning approach to a new class of antibiotics, the first one in a very long time. I'm going to start winding up. About a decade ago, we saw this paper, A Glimpse of the Next 100 Years in Medicine. It talked about analytic algorithmic formulas useful for clinical purposes, although they can't even be put in English. And I think that's going to be a reality. Many of us who are medical will fail to understand how a given AI system is working. We simply cannot. In fact, I doubt even the computer programmers will fully understand how the system is working, because no matter how transparent you make them, how open you make them, how understandable you make them, there is a black box element. We are in the zone of P4 medicine, predict, prevent, personalize, participate, now also precision public health. There's a multi-omic precision health characteristic. You will basically be looking at them as mathematical things. You'll be thinking sometimes as people, sometimes as populations, moving through health spaces. And I think we have reached the limits of the human mind when you look at the futures of medicine. Not only do I think it, this is from the New England Journal of Medicine, our Bible. Not everything is as good. AI will do a lot, but AI will also have bias. More than anything, you'll need bridges. Digital is not a solution by itself, just a bridge to solving real problems. I mean, this book by N. Chandra Shekharan, MD Tata, and Rupa Purushottam is worth looking at. And we must always be careful about the data. Without adequate data, biases will remain. To those of you interested in this area, you must look at the paper by Obermeyer in Science 2019, where, because they used healthcare expenditure as a proxy to sickness, Black people had to become much sicker before an AI algorithm recognized them as being sick enough to require more care. So the wrong surrogate measure, expenditure on healthcare being used as an equivalent to severity of disease, led to this much trouble. Imagine what's going to happen when you start putting in genomics and AI together. Most of the genomes are from white Europeans. The greatest genetic diversity in this world is in Africa and Asia. India is right behind Africa. With AI acting on those genomes to give you personalized health advices, what I told you about, without adequate Indian data, imagine how many wrong things and racial bias can occur. We have to be very clear that we must have our own genomic agendas, our own AI agendas in a country as diverse as ours. I'll end now by talking about the 3 questions important for AI products in health. What was the data? Has the program been trained for what it is supposed to do? Was the data ethically obtained? We do not want data colonialism for India. What was the machine learning? Was it appropriate? Is there understandability? What's the performance? What are the failure plans? What are the accountability? Currently, no self-learning autonomous AI for health is on the horizon. I'll be very clear. FDA has made it explicit in many discussions. We hope all these things will change, but so far, that's where we stand. I'll end by talking about this commission that I co-chair, Governing Health Futures 2030, Growing Up in a Digital World. I think all the topics we talked about are absolutely critical going forward. AI will transform health, but both positive and negative possibilities remain. We must embrace change while being cautious that we guide it in the right direction. And to end, it's only the species most adaptable to change who survive. Healthcare systems who learn to use AI will displace the ones who don't, but humans will still remain central. Thank you.
Thank you, Dr. Agarwal, for an insight presentation. And
Thank you.
And very interesting to know your views and points, how AI can change the future in healthcare sector. So we thank you for this particular presentation and look forward for you in the future for other endeavors. I would also like to thank Mr. Mitra for starting up this wonderful session. So now we move to the next session, which is basically an industry remark, and from Mr. Pankaj Kakkar. Mr. Kakkar, good morning.
Good morning, Amit, and good day to everyone. I'd like to thank the opportunity to kind of, for having me out here and be able to kind of, share the thoughts and views on this topic. I think before I start, I'd like to thank Jagdish, Mr. Jagdish Mitra as well, who actually set the context very well. AI is here, and we need to make sure that we are able to capitalize it in as well as possible. Dr. Agarwal had set the stage, very patiently explaining the basics and how the impact of it is already kind of impacting us in many ways. Obviously, the pandemic was a big one. With that, maybe let me share the presentation, which I'd like to kind of talk through. So I hope you're able to see my presentation. Just, Amit, if you can just do a thumbs up. Thank you.
Yes,
So I like to call this possibilities, and this is really about how we in India can be able to kind of utilize the firepower which we have built up over technology and on artificial intelligence to be able to capitalize opportunities in the global world. I'd like to keep the presentation short, maybe about 15 to 20 minutes, and then maybe have some time for the Q&A if that's possible as part of the agenda. I don't profess myself to be an expert, so this would be more of a dialogue, and we can have a common dialogue with everyone in case there are questions as we move to that particular stage. So let's talk about what's the potential opportunities, and want to emphasize on the word potential. I think various reports, and I've listed down over here one of the reports coming in from Accenture, which talks about AI has the potential to add close to about $1 trillion to Indian economy in 2035, and that's a massive potential, both coming in from what we can kind of look at it from a domestic market, as well as what we contribute to the overall global world. When you look at more closer between 2021 to 2025, we expect the CAGR for the entire artificial intelligence market to be close to about 14%. And this number is probably understated with what we know right now. We are well aware that, as we move into this particular field, the deep learning ends up accelerating much faster towards the end of the curve. Let's step back a little bit and talk about the challenges which we have in the healthcare. I think some of it Dr. Agarwal had talked about, but very clearly, we see there's a shortage of qualified healthcare professionals. There's non-uniform accessibility to healthcare. Healthcare is expanding very fast. For a human being to be able to kind of really take a specific set of conditions and be able to diagnose it very appropriately is becoming almost next to impossible. And that's where ADA, which was just referenced, and many other symptom checkers are kind of coming out there, both in terms of assisting patients as well as assisting clinicians to move forward. The private facilities tend to be kind of centered around where there is big urban cities. The affordability and the democratization of the care remains same. The quality of life remains same, irrespective of where the individual is in the economic strata, and that's really the key for us as we move forward in terms of how do we make sure that uniformity on the care which comes through. As we look into this, the elements I think which are coming out for us, for example, the foster prognosis for cancer detection. In fact, in a limited way, we ourselves have already kind of started putting together a group which has looked at one of the breast cancer diagnosis and be able to diagnose it through the slides very quickly and more accurately out here. This is under the research phase right now, and we are evaluating as we move forward on that front. Automating the processes is obviously the key. The chatbots, which again, we talked about in the previous talks, is something which will help kind of, have individuals be able to kind of, have the patient will see you, as Dr. Topol's book talked about, becomes an easier aspect for individuals to get the care, to be able to answer their questions effectively. The personalized healthcare plans are an absolute necessity as we move forward with the data. I think, again, the genomics, which is coming in a big way, and the data which is kind of be available to us, there is no other way for us to resolve this, to be able to kind of, move forward besides using the artificial intelligence. Just 1 second. If you talk about the care delivery and some of the work which is happening already in this particular field, and this is things which are already in motion, some of it has already out in the market, whether it is detecting skin cancer, whether it is looking at the coma victims and figuring out what is the probability for us, or when would they kind of wake up to be able to have the care being given in the right fashion. We talked about Google's diabetic retinopathy and analyzing eye scans, and that's a reality. It's FDA approved, the first AI algorithm which has been approved by FDA and is already in practice, which is out there. The drug development is being speeded up with big data and machine learning, and is also becoming easier for people to do the clinical trials as we move forward. We are at a stage where analyzing person's speech, there is a possibility for us to kind of predict whether an individual has a certain kind of depression, and that is fairly critical. The percentage of population across the world which is having some sort of challenges with depression is going up, and for us to be able to detect it just from the verbal thing is very important, and that's where detecting can lead to the care at the right time. We already talked about tools like ADA and others, which will become both assistants to start with and potentially be able to kind of diagnose it more effectively. And then, of course, the population health in terms of spotting outbreaks of diseases. So this is reality as we speak right now, and much of this is already in motion. It is already happening across the world. There is contribution which is happening globally for development of each one of these 7 areas. And parts of it have been supported very aptly from India as well. But expanding further and look at, what are the potential use cases which can kind of, come in and be able to kind of help us move forward. So obviously if you look at it from a funnel point of view, we talked about optimizing the resources, the pharma resources in terms of drug discovery, early cancer detection, and we all know that if we detect cancer at an earlier stage, it becomes easier for us and easier for the doctors to kind of save the patient, be able to have a better quality of life post the treatment of those particular patients. Medical imaging and diagnostics, I think images tend to become more easily being analyzed by AI rather than by humans to kind of detect the possible challenges or possible issues around that. And that's an area which is already moving forward in a big way. The improving operational room utilizations, the entire space out there for us to be able to effectively use the resources we have and be able to kind of provide this care is a easier thing. On the administration aspect of it, as much of healthcare in most countries is insurance driven from a democratization point of view, also a need to kind of make sure that the administration of it, whether it is a claim fraud detection or be able to provide the care through the right resources, is easier. We already have regulations in United States where when people would like to kind of make sure that you are reducing the length of the stay. Readmission sometimes is not being kind of compensated back to the hospitals and providers, and there is a particular need for hospitals to make sure that as they discharge the patient doesn't kind of the quality of life remains high. So these use cases basically tell us, and this is only a subset of the use cases which we have in healthcare, that we have an opportunity where we start to kind of, look into the specific data elements and be able to expand our R&D and be able to have new organizations, new startups focus in these areas and provide a solution to the world. This is in our own way, from a Tech Mahindra's perspective, what we have done in AI. Obviously, with respect to the healthcare, we have worked on the computational drug discovery, on the digital pathology, antimicrobial. Jagdish also referenced right in the introductory remarks about the work which we have done on COVID as part of pandemic, where we were able to kind of, really demystify the molecule and, share this with the broader industry for the work on the drugs for COVID. Our leadership, whether it is coming from the Prime Minister's office or from industry, has been fairly vocal about how we can use the AI to develop the tools to be able to kind of develop new solutions as we move forward. It's really important. But as we look into the nuts and bolts of how we can kind of do this, one critical element is access to data, because without data, it's not easier for us to be able to kind of execute, be able to kind of use the algorithms which we have and provide the solutions. So as we move forward, some thoughts which I have, which is really to make this possibility a dream to reality, is the regulatory alignment. Much of the structured data, much of the digitization of the healthcare data we have today is present in the West. And how do we kind of make sure that as we work through these particular areas, we are able to have a regulatory alignment on data compliances? Most countries already have stringent rules on the data storage. For us to be able to utilize those specific data elements, be able to test the hypothesis, be able to validate what is really right and what's not, we need to make sure that we are able to use our algorithms on that specific thing. So having that alignment is extremely important for us. Whatever we do out there in the global world, we also need to be able to make sure that we are able to do this in Indian healthcare space. I think what has happened in the recent years with Aadhaar, with the creation of an Indian ID, creation of a national ID, with in the financial transactions with the UPI, and now the base, now forming the base for the healthcare, it's really critical that we kind of move forward on this as quickly as possible, and that becomes our accelerator to be able to utilize what we develop out here for global world also. Equally important for us is to celebrate, recognize, and initiatives from the member companies and the startups. There is a lot of good work which is going on. How do we bring that to the bear? How do we really talk about those particular things? How do we co-collaborate and co-create across the enterprises? And industry forums like this is a great initiative for us to kind of bring this. And this is another area which we need to work on. Lastly, I would like to talk a little bit about something which is coming up from a previous experience. I used to work for a multinational, and we were setting up a R&D center, and we were scouting for places across the world. And one of the countries which we went into was Ireland, and they actually really laid out the red carpet from the government side, talked about everything. Apart from the specific awards, it's really a choreographed set of visit in terms of how beneficial it would be for the organization to be able to set up a center out there. And that's really the reason as to why Ireland does have so many companies, R&D centers out there. And maybe this is something which we'll need to build as we move forward on that front. I'll pause here and possibly look up for the questions. The idea is to primarily kind of open up in terms of what are the possibilities, what work is already being done, and see how we can move forward. So Amit, back to you. If there is a way we can have a dialogue right now, it'll be really helpful. And I'd request rest of the panel members to also participate in the Q&A as we move.
Thanks, Mr. Kakkar. I think you, any question from the panel?
I think we are good, Amit.
Yeah, I think you continue with the presentation. I think let me because this is basically a discussion kind of thing. So
Yeah, so I think
yeah.
that's pretty much I really wanted to kind of share and talk about in terms of the opportunities and possibilities. We are aiming for $1 trillion gross value add by 2035, and that's, I believe, we have the potential as a country. We have the potential to be able to contribute this globally, and also use the same for our own domestic consumption. Amit, you want to move with the next agenda now?
Yeah, I want if there's any question from the panelist. So if there's anything, otherwise we'll move to the next session. So thank you, Mr. Kakal, for sharing us the use cases and your views on the same. So I thank you for joining us this wonderful session on AI in healthcare. Thanks a lot, sir. Am I audible?
Yes, Amit,
Yes,
we can hear you.
Yeah. So if there's no question from the panelists, then we can move to the next panel session. And thank you, Mr. Kakar, for giving us a use case presentation. And then we look forward to seeing to your we look forward to continue work with you. Thanks a lot, sir.
It's my pleasure.
We have a we have next panel discussion at 11 o'clock. So I'm waiting for Dr. Kaushik to join. He would be moderating this session. So just wait for 5 minutes.
Pankaj, while we are waiting for Kaushik to join, quick question. Where do you see the difficulties in health data collection in India? Because I'm sure you thought about it more than I have.
So, Dr. Agarwal, I think I wouldn't profess myself to be an expert in any way. I would just call myself as a student. But let me just share a few experiences and then give a more generic thing. I think about 5 years back, I was working along with AIMS Community Medicine. It was more as an individual initiative, primarily to support them in terms of digitization of the data coming in from villages, as the support teams kind of goes from village to village to get this, and we were working on saying that how can we build a tablet out and really have a symptom checker to execute on. But as we dwell deeper into this particular exercise, we realized that the entire set of standards and the compliances and be able to collect a simple information was extremely difficult. The data, as it gets used to get entered and was entered 2 or 3 times, and didn't comply from a single area. There was no consistency across the board. So if we have to look at that kind of data quality and be able to use any of our algorithms, it won't really kind of help us to move forward. When we look into the West specifically, and now let me draw this comparison out to what we have as International Code of Diagnosis, ICDs, and say that can we use that as a standard mechanism? And if we do that, it would really help. It would help both the country on the rural side as well as on the urban front. Is it possible for us to do it? Absolutely. And in terms of the execution, I think with what has happened in the pandemic, as you stated in your talk also, it's going to accelerate really fast.
That's what I think as well, that only with a national mission that prioritizes cross-functional collection of data and making it available in an ethical way, run by the government at some level to de-risk participation by the private sector, creating the shell of data that is useful. That's the only way forward. One particular area I'm worried about is the one that I mentioned, the fact that the genomic data, etc., is so underrepresented from this part of the world. So again, I think these will be the high value services, especially to the upper section of the society right now, but all sections of society in the future. So I think that's going to be another very important. There will be another mission from the government on that as well, I think.
Right. I think it's if we get a data story, the data standards right, I think it's something which we can take, which obviously will be a huge value to us in India, but across the world, this will be a fairly big value. Genomics, yes, I think there is no doubt the personalized medicines and the personalized care is going to help probably come in different status of the society upper initially and then move forward to others. But I think it's probably a more longer term.
Absolutely. Absolutely.
If we go back to, if I just draw the parallel, I think to what you're talking about, the National Health Mission, I think in the US, the CMS and HHS, Department of Health and Human Services, they have opened up a lot of anonymized health data. And I remember the secretary talking about it a few years back in the US, and as part of the launch of it, they said that when we opened the weather data, there are so many companies which kind of came about and be able to do it. And now you of course have weather derivatives to every single thing which kind of gets impacted by it. And the expectation is that the same thing will happen in healthcare also. It's about providing a vast repository of data and be able to utilize that as you move forward.
In fact, the WHO is about to say, well, if my committee gets its articulation right, that data in itself is the biggest digital public good. So let's see if that gets articulated.
Absolutely. Absolutely.
Okay, I'll stop here.
Thank you for your comments.
Good morning, everyone, and thank you for joining us today. So we'll start up with this, our first panel discussion, and I will just introduce Dr. Kaushik Munali. He is the President, Medical Administration, Quality and Education, Sankara Hive Foundation. Good morning, sir. So
good morning, Amit.
Good morning. So Sankara Hive Foundation, which is among the largest structured community eye center hospital in the country, and having providing over 2.3 million free eye surgeries to underprivileged fellow Indians. So this is a great work that you are doing, and I will, we'll start this session, sir. We request you to take the session forward.
Thank you so much for inviting me to be part of this wonderful panel here to kickstart this carnival of AI that CII is hosting. And I think we are at a crossroad as a country today. I would first like to express my gratitude to Mr. Rajan Navani, who's been a past chair of CII Young Indians and has been somebody we at Young Indians have always gone back to. So apart from my role at Shankara, I'm also part of the national management team at YI. And that has been something that has kept us very close to CII and multiple other activities. Again, I would like to express my thanks to Rajesh, a fellow member of YI, who also was instrumental in putting together this panel here today. So the Indian healthcare system is one of the biggest in the world, considering that we need to take care of a population of almost about 1.4 billion. And using AI definitely enables access to healthcare across geography. So you don't have the constraints of time and space. And it also increases significantly efficiency, because you can push mundane tasks like tracking, registering, and a lot of it into a field of automation where it is where you can get away with it and save up the time for the specialists. So we at Shankara have been using AI quite a lot. Again, we've had a variety of experience in working with various specialists in AI, right from corporates like IBM and Microsoft to working with specialized AI specialists in looking at diabetic retinopathy detection using AI, to the most exciting part where I'm actually working with two students from my alma mater in Bangalore from National Public School, where they've developed an app to detect childhood blindness using a simple smartphone photograph. And today we're looking at multiple other tools. So we have seen an impact of AI in clinical applications. So it's not just theory that we are trying to talk here, but in healthcare, AI is definitely here to stay. Health systems definitely need a huge workforce. So when you look at general clinical care itself, we don't have enough people. When you look at something more specialized, there is a much bigger shortfall. So the projection is that we will be short of near about 10 million physicians by the year 2030 globally. And that is a huge gap that is required. And this includes our allied health staff, of nursing staff, midwives who are required. And this is not data that we have put out, but this is something that WHO is projecting. For us at India, this is very exciting times. We are looking ahead. We are very positive about all around growth that we are seeing. And we are slowly seeing the transition into the knowledge economy. We are no longer happy being the BPO to the world, but largely we want to become solution providers to the world. And that has been a flip that we are seeing. And I think the philosophy in India is not just to be at the commercial top of the pyramid, but rather to look at sustainable socio-economic growth. So if you look at the policy documents or the strategic visioning documents that are written, that is something which is very, very different and is probably also innate to the cultural ethos of India. With Skill India, the new national education policy, AI has assumed a very pivotal role on this front. And the Niti Aayog has looked at India becoming the AI garage or the solution provider as a strategy for leadership in AI for India. To kind of make sense out of this, we have a superstar panel here today. My honor and privilege to welcome and also introduce them. To start off, we have Mr. Jagdish Moorjani, who's a co-founder and promoter at Citius Tech. Currently serves as the CEO of the company, which is a global technology firm which has a team of over 4,000 tech professionals. A silver medalist from the IIT Mumbai for graduating first in class. He did study towards his Master of Science at MIT in USA on a MIT fellowship. Not only a critical leader in the corporate world, but he is also associated with multiple not-for-profit initiatives in both education and healthcare. My second co-panelist here is Dr. Raul Rodriguez, who's currently the Dean of the School of Business at Watson University. He's a PhD in Artificial Intelligence and Robotic Process Automation Applications in Human Resources, a Forbes 30 Under 30 2020 nominee, a Europe India 40 Under 40 leader. He's a former CEO and HR manager at Arian's Research Institute that has looked at multiple facets of AI, including looking at behavioral change using artificial intelligence and machine learning. He has co-authored 2 reference books, 70 plus publications, so really top of his game when you look at academia in this field. So it's wonderful to have you with us, Professor. Rounding off our panel is Kavin. Kavin Kandasamy is a graduate from Monash University, a Master of Science and Global Management from the Rowan Business School. part of a family-run business that operates in diverse sectors, from retail to microfinance to education. Currently also serves as a director of a premier residential school, provides educational services, and with the COVID, I think he's seen an opportunity where he's now pivoted to look at providing new age protective gear that prevents another pandemic breakdown. To kind of cover in one sentence, he has developed multiple sustainable ventures that are spread across diverse verticals. So I couldn't find a better way of kind of figuring out what all he does. In the interest of time, I will cut short my introduction of these panelists, but what I will do subsequently is I will try and share their LinkedIn profiles on the chat window so that the audience could feel free to reach out to them and connect with them to kind of make sense of education, healthcare, and AI, and how we can actually, as an ecosystem, drive this forward. So the question that we have today morning sitting in this workshop is to say whether India genuinely aspires to have a leadership role, or are we just trying to join into the bandwagon? So we have these niche terms that become the flavor of every season. I personally believe that India should build a workforce for healthcare and AI. And to kind of unravel this session so that we are at the top of the game, I would invite each one of our panelists, probably in the order in which I introduced you, to give preliminary thoughts in terms of how do you think that India can actually build its workforce specific to healthcare, specific to application of AI in healthcare through the university and other educational systems.
Sure. Thank you very much, Dr. Kaushik. It's a pleasure to be on this panel, and it's wonderful to be able to kind of participate here along with yourself and along with all of my co-panelists. At Citius Tech, right, we are purely a healthcare technology focused company. And there's a reasonable amount of work that we do in healthcare AI as well. And if you look at where India stands in the domain of healthcare AI today, or in AI in general, even if one were to kind of just broaden that, larger question, then software has pretty much become a household word in India today. And everybody recognizes the value that India adds to the world, the value that India adds to itself, because of all the capabilities that we have essentially developed in the area of software development and technology services that India provides to the world. When we look at the possibility of building a global workforce for healthcare AI in India, I think the first point that I want to make is that there is, maybe I'm stating the obvious, but there is a phenomenal opportunity to actually become the hub for healthcare AI globally. And that's simply because India has this huge wealth of talent, not only on the math and on the technology side, but also on the life sciences side. And if you look at healthcare AI, the type of human effort that you require to solve even one problem, it is fairly intense. And when you extrapolate that to the number of problems which are related to health pertaining to every single part of the body, which could be solved better by using healthcare AI to assist physicians, in some ways there is just so much which can be done in the world. And therefore, logically, India becomes a phenomenal place to be a hub for all of that activity. So when I look at what are some of the specific things that we can do and that we ought to do, I think creating a lot more awareness about opportunities for AI and healthcare AI in schools, creating a lot of awareness for these opportunities in colleges. So India has the regular colleges and we have universities, and we have lots of really smart graduates who may not be in universities, they may be studying in colleges. And while all of us on this panel are kind of, aware about the opportunity, just creating that greater awareness, either through government or through forums such as CII or NASSCOM, or through educational forums, I think that's the second thing that we must kind of, evaluate very closely as a community, as a society, and as a country. I think, making a lot of data sets available, which was again covered by Pankaj in his keynote address, which allows people to kind of play with the data. I think having standardized aptitude tests, which enables people to realize whether they have the ability to kind of be successful in this space or not, clearing some of the misconceptions. So for example, if I'm in a college, right, I don't have to be someone who might be as qualified as, Dr. Raul to be successful when I'm working in healthcare AI, because there again, there is a kind of totem pole, and depending on the skills I have, there are different levels to which I can play at. So there might be people who are just super smart when it comes to math, who will be able to kind of operate at the highest level, which is really, developing all the algorithms. And then there are people who need to work with data, combine that with knowledge of life sciences, and, just focus really on how to analyze, do a lot of the prep work so that the people who are more qualified can take over from there, people who know how to use the algorithms. So I think talking about all these opportunities, creating awareness, and helping our graduates, our students figure out about where they kind of fit into that entire ecosystem would be, some of my suggestions. So with that, I can actually hand it over to the next panelist.
Dr. Rao?
Yes, well, I agree with most of the points which have been already highlighted, since of course these are generic points and pretty much all of us will agree to that. There are two key differences which I want to highlight. One is, we are talking about healthcare as only physiological healthcare, or are we also considering psychological healthcare? If that's the case, then we are, especially not just India, but most of the countries are way behind in that spectrum, because embedding this kind of psychological contracts, cognitive abilities into algorithms is really tough, and it will originate further bias in the algorithm and the data consequently. As you know, as humans, we have psychological contracts, cognitive biases, unconscious biases. Monitoring all these into algorithms to develop healthcare as a whole industry, not just in the physiological spectrum, but also on the psychological side, can really take years, and not just years. You also need private partnerships. Relying only on government or various associations for funding won't be enough. You need private corporations to also invest, because there is large investments in the picture. It's not just the hardware or software or the algorithmic development. It's also the psychological development, which has to be done on research basis. A lot of research is due on this subject, and universities alone won't be able to do it simply because there are a lot of restrictions from multiple sources, and be it governments, be it associations, be it even international organizations such as the UN, and all these concept of ethics and privacy, which comes also in the picture, is what creates these limitations. So India has a lot of potential. I completely agree on that. It's a full pool of talent and of course manpower on that regard. And certainly you do not need to have a doctorate to develop these tools. But obviously, if you work on the area of research in depth, not just for the sake of obtaining a doctorate, but to be able to develop research and grow within it, then it will certainly help to obtain more accurate and high quality results that I am quite certain on. So this is the potential, and this is where the focus should be lying on at the moment.
Kevin, please go ahead.
No, thanks a lot to both the learned, wise gentlemen, because I'd like to take it down to the basics. We run 7 schools. Now, these schools are spread across as alternatives to government schooling, to an elite private residential school like the one that you mentioned, Uti, right? So the learning can I say, the gap between infrastructure availability at one of my schools in the villages is vastly different to one of the schools in the residential schools where, most of the elite crowd come into. That sums up the narrative for India. We have the means to really get the best of the best within a certain pool, and we have a whole lot of people who do not have access to this kind of skill or infrastructure to gain that skill. Now, why I went down to the basics is a lot of school education has not been transformed in over 20 to 25 years. And anybody who's involved in the education space would know the government has been battling to get the NEP. That's the National Educational Policy, which is, the larger curriculum framework that we're used to. And it's taken about 5-6 years for them to get it to an acceptance level for the larger population, right? And now with that rolling out, it's going to have a spiral effect from schools to colleges to universities. And then you have, but I see a great role for skill development companies, significantly, because you have a tremendous workforce that is already in the market out there that have the prerequisites of the, the mathematical skill sets, then you have all, the algorithms, you have the whole, technical background, but they do not know how to further progress into an AI reliant industry. So that said, so the skill companies have a huge role to play in upskilling all these people already there. But with the national education policy coming in, you'll see that entire effect taking place over the next 3 to 5 years. So I think that is a good step for us as to where we are.
So I think wonderful preliminary insights from Mr. Jagdish talking about the need for increasing awareness at all levels of the spectrum and kind of putting things into perspective, saying that everybody has a role. We don't need to be as qualified as Professor Raul, but each one of us may have a skill set that could contribute, and we need to be open to probably that idea to understand that. And I think Dr. Raul was spot on in saying that partnerships are critical, because it's very easy for somebody in a lab to work on a solution, and we've seen that happen. You write an algorithm, you test it on the system, it shows 98, 99% of sensitivity, specificity. You go out to the field and it is a mess. We've had simple stuff where the algorithm gets fooled by the gray hair on your head, and it assumes that everybody with a gray hair has a particular eye problem, especially when you're taking facial photographs. So these partnerships become very critical, and we are seeing a lot of role play of the mind also in healthcare. So even at our eye hospital, we have a psychologist who's part of our team, and we are looking at behavioral. And I think the behavior also has a role play in that although there is AI and we're looking at AI increasing access, we're looking at AI making healthcare available, the patient finally wants one human being to connect with him and tell him saying, okay, this is it and this is what you have to do. So again, when we did a small little survey here based on AI solutions, most patients were okay saying that I'm okay for my problem to be screened, but I finally want somebody to tell me what the problem is happening. So I think Professor Raul is spot on in saying that we need to look at behavioral changes and how the AI algorithm looks at biases, because sometimes these biases are good, not necessarily that all biases are bad. So maybe we need to filter that out. And Kavin, thanks for putting things into perspective that India is an elephant. Whatever said and done, we have 1.4 billion population. So one session here cannot probably be prescriptive in terms of what needs to be done. But we need to look at the entire ecosystem. But I think the urgency that is there, and again, the urgency that is being shown by an organization as old as CII, which is a 125-year-old organization, is can we wait for this a number of years for the momentum to build, for the NEP to kick in, slowly schools raise awareness. But if you look at the documents that are available today, there is no clear actionable plan in terms of how AI, especially AI for healthcare, should become a part of university programs. So do you, among the three of you, have any thoughts in terms of how that can happen, say, starting today? You also mentioned about people in the workforce probably upgrading themselves. So is there a play that universities, like the one Professor Raul is associated with, is looking at this in a structured way and something other universities can take on?
Yeah, so so maybe I'll just kind of chime in here, and as of now, at least I'm certainly aware of various universities or many private institutions also offering courses in AI, but I've really not heard of any universities which are offering courses which are focused on healthcare in AI. And healthcare is a very unique field with its own ontologies, its own workflows, its own standards, its own vocabulary. And for someone to really be effective in healthcare in AI, I think it would be wonderful if we kind of have universities who start to pay attention to this. And if I look at India, the number of graduates that we would produce with backgrounds in life sciences, with backgrounds in biology, with backgrounds in chemistry, all of them in some ways would become absolutely prime candidates to combine that knowledge which they have along with the mathematical and AI knowledge which the university can provide to really develop differentiated capabilities when it comes to healthcare AI. So I think it's an immediate opportunity. Every university is competing for students. Every university is looking to build novel courses to attract students. And on the other hand, you would have global companies which would, really benefit from having talent of with that training and that background available. So in some ways, I think, that opportunity is absolutely, imminent. And to even go back to a wonderful point, which, Kavan made when he spoke about how in some ways as a society, right, we have people who in some ways have access to a lot of exposure to opportunity to education. And then there are vast parts of our population which don't have access to that. And sometimes the barrier there could also be linguistic. Today, all of the content, all of the knowledge, all of the textbooks, when you look at AI, when you look at healthcare AI, all of them would be in English. And in a country as large as ours, with the number of graduates that we have, I wish that there were courses which were available in regional languages where people who were smart but who did not have that, opportunity to have kind of done their undergraduate education or grown up in an environment where they had natural familiarity with English. We might find a lot of hidden talent just in our student population who's not had the privilege of learning in English. So yeah, so those are just some of my comments. Yeah.
So Dr. Raul, I'll just take up on what Ms. Jagdish was saying. So today we see these multiple advertisements that are thrown at us. We have all kinds of campaigns running about 10-year-olds winning awards, getting jobs in various multinational corporates. So there's a whole lot of peer pressure. So I have a 12-year-old daughter at home, and say I want her to be equipped with the 21st century skills. Now, whether she wins a coding award or not, I may not care about it. But when you talk of 21st century skills, it's very different from the skills that probably we procured as a part of our education. So how would the current education universe actually enable this?
Well, we have to understand one thing. These degree programs for 4 to 5 years are pretty much obsolete at the moment, simply because the market changes really quickly over 5 years. At the moment, doing degrees which are so long in length will not have any productive or quality-driven output at the end of that particular degree. So that is one thing we need to actually eradicate, make it shorter degrees, more sharp, more concise, and maybe more quality-driven rather than lengthy, which is what has been going on since many years. When it comes to skill set, I know what kind of case you're referring to what particular company you're talking about when it comes to coding. I think that there's a complete atrocity to ask 10-year-olds to program on Python and try to make them some sort of AI engineers just because it's the trend of the hour, which will not be any longer after 1 year or 2 years. And basically, you're killing their childhood and eradicating the time that they're supposed to enjoy rather than work that hard. That there is time in life for that later, that we all know. So in terms of skill sets, I believe what is very critical, which is missing nowadays, it's something which I think is pretty obvious, which is being a good human being for once, rather than being just a good professional. We are forgetting a lot about ethics and etiquette, basic soft skills, and we are focusing too much on the hard skills only. And that is missing from multiple school as well as university dimensions. And if we talk about this national education policy, despite of the good doings of the policy, we have to understand that the policy comes in the picture 20 years late. Is not some revolutionary light bulb which has just come in 2021. These multiple countries have been implementing it for many decades, and it has come very late, and it will take years to implement. It's not going to be overnight. So that overdevelopment of multidisciplinary education, teaching psychology, sociology, anthropology in maybe computer science or mathematics or biology or MBBS degrees, it is what is going to give that essence of understanding how the world really runs. And well, roughly, to put it very briefly, this is how more or less the skills should be structured at the moment.
So I think Kavan, Dr. Raul spoke about the mindset. So as an employer who's worked in multiple domains, assuming there is a set of people that the education system now throws out who are employable in an AI healthcare domain, what skills would you specifically look for? So do you give priority to the hard skills, or how does it actually work?
For me, the whole thing has come down to relevance. And if I say this, I say relevance in terms of your education and relevance in terms of using the skill set in the right place. Right? And I'm going to use very simple terms as that's exactly what I look for in a person who has the skill set to deliver what I'm looking for. So my PPE is a company that is looking at preventing another pandemic from happening again. And when I say this, I believe lifestyle is the root cause of what led us to the situation. The microorganism world is evolving quicker than we and our habits are evolving. Now, I can't ask you to change your lifestyle overnight. It's not going to work. You've sort of accumulated these habits over years, right? I can't ask you to do it. But can I really get to a point where predictive becomes preemptive? You know, where all the data that is available, can I sort of link it back to your lifestyle and see if it can sort of pop up certain cues to say, hey, don't do this now. You know, maybe that can prevent you from having a breakdown, you know, or a pandemic. So those are the small, simple solutions we're looking for. And when we do this, and when we try and hire a team, we have an entire research team that is based out of Chennai and Hyderabad. And Dr., you know, kudos to the work you've done. And I've been following Manipal very closely. I mean, kudos to the work. You know, they've been using Watson and everything. They've been using this computer prowess to really help people like you, people who are in the field, make calculated decisions, right? So we have a virologist who's been calculating all the different genomes in different places, right? And mapping it as to which place it spotted and took off from and all that. And we're calculating the whole trajectory as to where it is going and all that. Now, we are hoping to tell people with a trajectory, hey, if you're going to go to this place, there's a 30% risk. Maybe you would avoid going to the place, you know, and if you're going there, go with these tools, go with these things. So when I ask for all these people to work, there are two things I ask for: relevance, and I see knowledge bridging, because the virologist is not an AI person. He understands his subject very well. An epidemiologist is not an AI person. He understands his subject or her subject very well. But getting these two people to sort of have this alliance over this period and understand each other's capabilities and sort of bring it down to a platform that everybody can use is a different, you know, thesis altogether. So we've been working with all the specialists in the industries and all the technical prowess we can find. So when I look for it, I look for relevance. I see if that skill set works in this place, and we sincerely look for application. If they can't really drive these two things together, where the knowledge and the technical ability sort of bind, then it doesn't work for me as a business. It doesn't work for me as an opportunity, and I can't take it to the market. So these are the two simple things, you know, at the end of the day. I'm not a technical person. So over to you.
Lovely that you're so candid about it. And I think Mr. Jagdish kind of put it into place, saying that everybody has a role. So I think we both are okay not having technical knowledge of AI, or not being, at least I'm nowhere close to engineering, or I can't code for nuts and Python for anything. So I'm definitely not going to get an award or a call from one of the large tech companies like some of our other 10-year-olds did. But having said that, on a more serious note, so as we look today as a part of this seminar or symposium, where we are trying to inspire people to work on a path that can help build a workforce for healthcare AI, I would be curious to hear from three of you who've been in the ecosystem, so to speak, of can you elaborate on any one best practice that you've seen, either in terms of upgrading existing workforce, or anything that you've seen in terms of your alma mater or educational institutions, either in India or elsewhere in the world, that we could look to adopt, or we could look to do the Indian jugaad around it and make it a reality quickly and shorten this entire curve that we are talking of?
Sure. So, you know, if I kind of look at some of the best practices that, if I look at what we have followed, right? So I'll just speak a little bit from my own personal experience. And in my own experience, there are just two quick practices that I will speak about. So as a company, we were predominantly a tech services focused company operating only in healthcare. And the entire area of machine learning, artificial intelligence, and data science in healthcare was a relatively newer area for us. We have some superb leadership, which kind of heads that group, you know, within our company, really smart, qualified, experienced people. And as we are hiring talent from the outside, there is a huge dearth of talent, which kind of comes with that knowledge that we require to meet the expectations which our global customer base have. And what we have really done is to create a lot of awareness within our own ecosystem of 4,000 employees of the opportunities in healthcare AI. And we found that there are several people who were pursuing other types of work. We had people who were more into coding. We have people who were more into software testing. We have people who were more in other areas of technology. That was what their main focus was. We had domain consultants who had domain knowledge, but they did not have mathematical or programming knowledge. And we've essentially put together a really robust training plan. So we created awareness. We spoke about the opportunity. We had several volunteers who were interested. We subjected them, or we gave them aptitude tests to kind of see their fitment in terms of the skills that would be required. Some of them had very, very strong mathematical skills. Some of them came with kind of mathematical and degrees in statistics. And they could kind of actually focus on parts where one is building algorithms. There were others who may not have had such deep mathematical skills, but they had all of the intellect which was required to actually use algorithms which were out there in the world, use all of the tooling which all of the large tech companies in the world are kind of building and making so accessible, through the cloud. So we were able to form groups of people. We were able to train them extensively. We were able to find real project opportunities for them to work on and get smart with in the labs that we had set up. And now they've actually made a transition and they've become full-fledged, healthcare AI professionals. So that's a practice that we followed. And honestly, if you look at the amount of effort or training that it takes, going back to the point that Dr. Raul made, which I think is a terrific point, that today often you don't need 4 years of intense education to kind of develop a skill which is really relevant, in the real world. And there are much smarter and shorter ways to do that if that's been if it's been thoughtfully the learning path has been thoughtfully put together. So that's one of the kind of practices that I would like to talk about. In the interest of time, I won't speak about any more because I'm sure the other panelists would also have their perspectives.
So, if I may, yeah, what we've been finding as a challenge most often is in terms of AI adoption, the fundamental comes down to data and the availability of data. And this goes back to my fundamental issue of infrastructure. So we were trying to set up, using, as my PP is trying to set up with, IoT devices to check the safety of a place by measuring airborne pathogens. Now, airborne pathogen is something that is not new, but, having that kind of tool put up everywhere and to collect that kind of data, we were having tremendous challenges, even in Tier 1 cities. Some of the systems are outdated. So that sort of is limiting us from using that constant upgradation of the entire system, is limiting us from getting the kind of data we need to build, apply our entire capabilities on top of it. And that is something, so data collection, and even with hospitals, when we talk to them, some of them in remote areas, the whole market being this big, don't have the best practices for data collection that we could not even, we just could not work with them. So we have to go down to the basics of setting up the whole data collection mechanism. And from there, we're trying to build, further on. So that's something, data collection is very, very important. And that is something is a crucible to all that we're doing.
Professor Rao?
I believe most of the points have been covered, but just to add maybe a complementary of what the points that have been shared. On the one hand, you need, of course, multidisciplinary approach. That means not having one individual that is the solution for everything, because one solution won't fit all. So you need to have, obviously, healthcare professionals on the one hand, and on the other hand, AI programmers and developers who can work side by side. Needless to say, the AI developers need to have the knowledge on the healthcare field in order to, of course, understand what they're actually programming. So this is very required. In fact, I can tell you from our students' body, we have a particular program on AI focused on management, and we make sure that the students have the adequate knowledge of management, the general trends of marketing, finance, and so on. But the main focus is on artificial intelligence. So they apply this to multiple dimensions of their scenario, professional scenario, and see how you work around. The second best practice will obviously be infrastructure. Now, again, this comes to the point of partnerships. You need investments. And AI, I believe this is not a new statement to anybody. AI is quite expensive because AI comes at a quite high cost. You're talking about not just hardware or software, but you're talking about the developers also, their salaries, and of course the time investment. And even though on the news we can see new applications coming up every day, developing data and cleaning this data and making it useful takes years and is not an overnight step. Being in healthcare, you have to collect millions of data points and run it over the years in order to make it accurate. So that investment, universities as well as industry has to be more than willing to make it. This is, I believe, two key areas which we need to work on.
I'll just kind of follow up on what you said, Dr. Rao. So when you're talking of necessarily having to look at scale, when you're looking at India specifically, like I said, we're a 1.4 billion elephant. So if we wanted AI in healthcare to achieve the maximum impact, what do you think needs to change in universities today?
Pretty much everything. Universities need to become purpose-driven and not transaction-driven. This is very critical, simply because, as you know very well, in the Indian education system, the mindset is do a degree so you can get a job. So the ultimate goal is the job, which is incorrect. If the job should not be the goal, the process should be the goal. The job is as a collateral, and that will always come if you're good at what you're doing. And ultimately, if your focus is only to get a high-end CTC in a particular company or in a particular job role, then no development will take place because your focus will only be on a paycheck. So that purpose has to be very well defined from day one in the degree when you roll, that you're here to learn, develop your skills, and develop your research, not to get a job. Job will come in due time, not the other way around.
I really, really wish everyone who worked in every one of our organizations had that ethos. But I think today we are seeing a change where a number of people are purpose-driven rather than looking at impact rather than looking at the monetary incentive per se. So I think there is a significant change, but we really wish it could happen at a college level, that students are indoctrinated to this concept, and that would make life much easier. So, Ms. Jagdish, having discussed all of this, we're talking of partnerships, we're talking of having a more broad base, not working in silos. I do expect, and you work in a technology company very closely with end users across the world. So I'm assuming that there are multiple roles that may eventually emerge out of this. We're not just looking at programmers, not just looking at healthcare professionals. So my question is, what are these possible new roles that you think will emerge in the next 2 to 3 years?
Sure. So if I look at the roles, right? If you look at the entire, just a typical AI life cycle, in many ways, the starting point before one can address any question which one is trying to, find an answer to through AI, you need data. And again, maybe I'm stating the obvious over here, but just looking at data, filling gaps in data, analyzing data, standardizing data, cleaning up data, and making data available in a form where it can really be used for downstream processing, that requires a certain set of skills. The other set of skills which kind of come into play are domain skills. So again, we have Kavin who spoke about how there is a virologist who's kind of, doing a certain analysis in his company. And that virologist just brings very strong domain skills. And if you look at healthcare, right, there are so many aspects of healthcare, from the life sciences aspects to the biological aspects. So just the need to kind of have people who have a very good domain understanding of healthcare, that becomes a second set of skills, which becomes very, very relevant. And those skills may not necessarily be the skills which a physician has. So if today I'm a doctor, I am a surgeon, I have probably the most advanced, medical skills which are out there. And it may not be necessary to have that degree of expertise for the purposes of playing a kind of meaningful role. Again, the beauty is that there is a space for everybody, people who have moderate degrees of expertise to people who have very high degrees of expertise. The third type of kind of skill which comes into the picture is a skill which is available in abundance in India, but it is still always in short supply, which is just plain technical skills. So how do you kind of put together the entire technical software infrastructure to be able to actually carry out machine learning and data science by leveraging, for example, like I mentioned earlier, all of the just absolutely phenomenal tools which various tech companies have made available, and so easy to access through cloud-based, platforms. So there are the entire operationalization skills that now that you kind of have this information which is available, how do you actually operationalize it and put it to use, in the real world? There are skills associated with just getting people to be comfortable, because as human beings, we need to be comfortable with the fact that we are operating in a machine-assisted environment where a machine is really making many, many key calls in terms of what ought to happen to me and how I ought to be treated and how my care has to be handled, which is really machine-assisted medicine. So there are so many of these different roles, just training physicians on how they need to get comfortable with the entire domain of healthcare-assisted AI. There is the entire area of insurance, where as the National Digital Health Mission starts to get adopted, we will have a lot of data which is coming in. And how do we kind of analyze that data wearing a more of a forensic hat to essentially look at fraud, to look at waste, to look at abuse. There may be more, process-oriented jobs about using information which is not codified and just carrying out the mechanical task of codifying information so that it can be used, by a machine. So there is such a plethora. There are teaching jobs. So there is such a plethora of interesting, jobs that might end up emerging. And as we start to become the hub, and as the world starts to come to, India to look at us for our healthcare AI expertise, then very often when you have commercial ventures at work and you have profit incentives at work, they are accompanied with a lot of investments in tooling, in best practices, in training. And then this phenomenal ecosystem kind of starts to, get built up, exactly like what we have seen maybe in the area of computer software.
Wonderful. I think cognizant of the time that we have, I'm going to request each one of you to kind of give a one-sentence takeaway that you think the industry or the UGC or the powers to be should consider when we're looking at building an entire workforce for healthcare and AI in healthcare rather. So again, Kavin, you want to start off? You need to unmute yourself, please.
Oh, sorry. You said one sentence.
One takeaway that you see for the sector, or a suggestion.
I'm just going to stick with relevance. Make education relevant, right? Don't keep us in the past. Make education relevant, and that means not only AI, everything else will be taken care of. All right. So that is something I'd like to tell.
Lovely. Professor Rao?
I'll stick to the previous point. Ultimately, becoming purpose-driven rather than transaction-based is one of the keys.
And Mr. Jagdish?
Yeah, I think, if you look at, for example, a body such as UGC, in some ways just really, really encouraging universities to invest in courses around AI and specifically healthcare in AI, maybe making it easier for universities to kind of invest, in curriculums around that, I think can be a terrific kind of way for us to, start to find this entire field of knowledge become more prevalent. And as we will start to build that workforce, which is a trained workforce, then I'm sure many good things will naturally happen.
Okay. Yes, Kavin, you wanted to say something?
No, I mean, since we're talking about the UGC, and with all due respect, I think there's significant capital expenditure expected of the promoters to set up any course. And sometimes going light is the only way that they can adapt and be agile. So if you bog them down with too much of, do's and don'ts, they have infrastructure they haven't touched in 7-8 years, which was mandated by the norms. So please make that lighter,
Okay. Lovely. I think a wonderful morning as we kind of meander down to the last bit of the session. I'm waiting to see if there are any other questions that are coming in. Because I'm not able to see them on my chat window. So hoping Amit will be able to help us. While we wait for that, I think we have another couple of minutes. What I would like to again ask all three of you is, we spoke a lot about the soft skill or the human part of the entire aspect. But what other technologies do you think need to be adopted for us to look at AI application in healthcare?
At least my thinking is that today adopting many of the modern technologies that we have is very, very expensive. And it takes today's software skills, advanced software skills have become, again, very costly because there is just this huge international demand which is being catered to by companies based out of India. So I think just having solutions which standardize, which are kind of standardized solutions which make it easy for healthcare organizations to, take their data, cleanse their data, store their data, and start to do interesting things with that data. I think that will be a big help. So if I take, for example, the, Sankara, where Dr. Kaushik comes from, if they have to make a huge investment in trying to, carry out machine learning and use data science in healthcare, then that becomes an impediment. But if there were standardized solutions, plug and play solutions, which made it easy for the data scientists that they might want to invest in, to kind of start to use this incredible amount of data that they are collecting for analysis, for the larger human good, I think that is, an interesting, again, area of kind of focus for this industry as a whole. Yeah.
Professor Rahul, come in. Any quick comments before we wrap up on the technologies that you think that needs to be adopted for AI?
At the moment, I think we are on the right path. There's no any additional technological development which we require. It's more of a focus rather than technological driven development.
Lovely. So thanks a ton. I think we've had a wonderful morning unraveling this entire idea of bridging AI, healthcare, education. For me, the biggest kind of learnings were, one, whether there can be an advocacy in terms of looking at how we can have a light infrastructure to enable colleges and universities to look at empowering their students with skills and research areas rather than looking at the size of the classroom or how many rooms the faculty has. Probably we need to relook at that. Making education relevant is a very, very critical point that came out, I think, multiple times. We are looking to leapfrog into the future. And I think Professor Rahul kept us grounded with saying that it is important that in all of this, where we're trying to look at cutting edge technology and solutions, we remember that we are trying to solve a problem that is innate to human beings. And creating professionals is great, but are we creating good human beings who are clear about their purpose in life rather than just looking at what is the paycheck I get or how am I being recognized in the world? I think it's been phenomenal in terms of.
Yeah, Dr. Kaushik, just before we end, right, on behalf of all the panelists, I want to take a minute to thank you. I think you've done a fabulous job as the moderator. So you've kept us on time, you've kept the discussion focused. And if I look at how well you summarized what everybody said for the benefit of all of the other people who are listening, and about how you kind of, came up with really engaging questions and topics that followed up from where a panelist may have signed off. I think it was just wonderful to see you in action. So on behalf of all of us, thank you.
Thank you so much, sir. Very kind words from you. Amit, back to you, please.
Yeah, so I would like to thank all our panelists and especially Dr. Kaushik for this excellent coverage of the topic. So indeed, this was a very informative session, and thank you once again. And then now we move to the next panel discussion, which basically I will invite Mr. Kevin Kumar to take this forward. And Mr. Kumar, who is the founder and CEO of MyPay. So Mr. Kumar, we would like you to tell me more about your this venture before you take up the session.
So after a wonderful session with Doctor, now the benchmark has been set high. I only hope to live up to his expertise of moderating. So I am the founder and CEO of MyPPE. So MyPPE, or My Brand as we're calling it, is the world's first safety lifestyle company. Our intention is to create lifestyle products that people can use on a daily basis, so that enables them to sort of adventure into anything that they want to adventure into, irrespective of the evolution of the microorganism world around them. Because with the advent of the pandemic, one thing we've come to know is most of whatever we're doing is not equipped to endure the pandemic-like situation that was created. And we live in an ever more connected world at this point. So our products and services intend to keep educational institutions open, corporates open, businesses open, so you don't have to endure a breakdown again. And we do this through products that people can use on a daily basis, and through services that measure the safety and ensure that you can continue to keep your business open under all circumstances. So that is what we do. And to check us out, you can check us out on myprotection.in, because it is a complex concept, but we're trying to just go in as a lifestyle company. And that's why we're calling ourselves the world's first safety lifestyle company, because we're focusing on your lifestyle being safe.
Thanks, sir. Sir, please, so we have all the panelists right now available with us. We'll request you to start the discussion.
Absolutely, absolutely. Good morning, ladies and gentlemen, and thank you to Dr. for the previous session and all the wonderful panelists. So I'm coming in from that panel to this one as the moderator. So I do lesser talking, and I hope I will hear from the learned gentlemen who are going to be on the panel here with us. All right, so first topic for this session would be how to build a global healthcare AI business from India. And to talk about this, to debate about this, and to converse about this, we have three wonderful gentlemen who have, between them, more than 60 to 70 years of experience in this discipline. So first, I'd like to introduce Mr. Vikas Jha, the country head for Real Networks India Private Limited. He's got more than about, if I can say, as I look at his profile once again, that's about 25 years of working experience that ranges from sales to brand, and then over to AI in the last 13 years. Now, Mr. Vikas Jha and I did connect yesterday very briefly, but I haven't had the opportunity to say hello to him. So hello to you, sir, and welcome to the panel here. Mr. Vikas, are you there with us? Okay, so let Mr. Jha get on the line.
Hi, Kevin.
Yes, you're a little feeble, but if you can just get your audio up, it would be nice.
I think I have my video also switched on.
So it's good. We can see you now, and we're just trying to hear you better. So, Mr. Vikas Jha, welcome. And next, I'm going to introduce Mr. Rizwan Koita, the CEO of Citius Tech. And you've heard from the previous gentleman about the wonderful work Citius Tech is doing in the field of healthcare and technology. Mr. Rizwan, I believe it is only fair that a person of your stature, I should introduce yourself for the kind of experience you have in this discipline. Would you mind just telling us more about what you do and the wonderful work your company does in this space?
Sure. Thank you very much. Kevin, able to hear me clearly?
Loud and clear, sir, yes.
Okay, so my quick background, I'm the chief executive of Citius Tech. We are probably the largest pure play healthcare technology company out of India today. About $250 million from a revenue perspective. I've been running the company for the past 16 years. My prior background is started my career as a consultant at McKinsey and Company for many years, and then I have had the opportunity to co-lead the BPO firm before starting Citius. So over to you.
All right, thanks a lot for that, sir. And we have with us the third panel member. And once Mr. Vikas's line is cleared up, so he will introduce himself as well. Mr. Vaibhav Tiwari is the co-founder and CEO of Portia Medical. And again, as I said, between these three gentlemen, there's about 60 to 70 years of work experience in these various fields. Mr. Vaibhav, would you very kindly introduce yourself to the audience, please?
Yeah, thank you. Thanks, Kevin. Thanks, Kevin, and thanks, Rizwan, for inviting me for this. So I am the co-founder and chief operating officer at Portia for last 7.5 years now. We started Portia in 2013, and the whole idea behind the company was to look at outside the hospital healthcare services in India. So we are the largest outside the hospital healthcare services company. And that basically means that we work with patients post-discharge, patients with chronic disease, patients for elderly care, and so on and so forth. And of course, go to their home, support them for all their medical needs across the board, from setting up ICUs at home to basically providing them physiotherapy and so on and so forth. And that's what Portia Medical has been doing. We are present across the country and fairly sizable, largest in this space, probably in Asia now. And I've been an entrepreneur before that. I also had my first venture in BPO space. I think same time when Rizwan had, I think TransWorks, we had iSeva. So that's what I did for first 7 years of my life. Had another venture, and then here I am. Hello, Kavin, you can hear me?
Yes, I'm sorry. I went on a blip. My apologies there. This is what I was talking about. So if everybody can hear me, thank you, Mr. Vaibu. Can anybody else hear me?
Yes, we can.
Loud and clear. So I have a bit of the issue with the videos loading up. So Mr. Vikas, would you be kind enough to introduce yourself, please? Because we had a bit of a blip in our connection earlier.
Yeah, again, and it's wonderful to be on this panel with yourself. As you said, Real Networks is a US company, and I am the country head for Real Networks India, and which also looks after the South Asia business. And we are actually since last 4 or 5 years, we have been working on artificial intelligence, developed one facial recognition solution. But personally, I have a lot of interest in artificial intelligence, and I keep on learning. One of the areas which really attracts me is healthcare, and that was one of the reasons that I selected to be part of this panel, so that I can share my thought process in all these discussions. And I'm seeing a lot of dynamism happening in artificial intelligence being used in healthcare sector. So hope to have a wonderful discussion.
Thanks for that. So with the three panel members, introducing themselves, allow me to just go into set the premise and say, we're talking about healthcare business in India, which is about $372 billion big, and by estimates, it's only set to grow. Now, the hospital industry accounts for about 80% of the entire healthcare business. Now, there are other numbers that I'd like to bring to the light here. The Indian medical tourism business is about $8 billion big as of 2020. And the diagnostic industry is about $4 billion big. The primary care business is about $13 billion. But all of this said and done, as these are large numbers, the recommended doctor to population ratio is about 1:1,000. But in India, we have about 4.8 doctors for 10,000 people. And the estimate is by 2030, as per the Government of India reports, it will be about 6.9 doctors, which is still nowhere close to the ratio that is recommended for the developed world out there. Now, having put this into focus, there's something else that I'd like to bring to the table here to set the premise right. Healthcare as a concept is not about just medical healthcare alone anymore. There is a lot more other, factors that are coming into play. Apple is in the healthcare business, and there are many other wellness concepts that have come into play. Fitness is part of the whole healthcare business right now, and like Mr. Vaibu was saying that there is also, if I can say, there is also old age care in a certain sense, that is preventing. So that is also healthcare. So this preventive measures also coming into the whole healthcare business. Now, having said this, I would like to take an opening statement from all of you as to how involved is AI already in the healthcare business in India. Because the topic is to see how we can build a global healthcare AI business for India. But how is it already in the Indian ecosystem? And I would request Mr. Vikas, if you could start off and then go with Mr. Rizwan and Mr. Vaibu.
So thanks. So AI in healthcare has huge and wide impact. Because I can we put somebody in? Yeah, it's fine now. So artificial intelligence at the backbone, it is same, whether you use for healthcare or use for surveillance or use for any other agri. Okay. But healthcare becomes very, very relevant because in India, because we have a very large population. So, and we have very limited healthcare system that we have seen, evolving in recent times. So use of AI is imminent. If we don't do it right now, I mean, global impact is already building up on AI, and we are doing fantastic work happening across the globe. Whether it is, studying the human genome or studying, there is one hub map program where every cell is being studied, and what are the implications one cell is giving to other cell. Those kind of studies are going on. uh, we have already seen that breast cancer detection or lung cancer, post treatment survival detection, these kind of things are already happened in last few years, and now we are seeing the accuracy being built up. So in India, I think we can't escape it. If we don't take a lead, somebody else will take a lead and create the ecosystem for us, and we'll just be following on them. So this is the right time that this is very, very important, and we have to take a lead and build the ecosystem wherein we invite multiple private public partnership and create new use cases, create new use cases can be actually brought into applications. We create a partnership between the technologists and the AI experts and the doctors to create new entire new solutions which can help the not only the Indians but also across the globe. So these are my initial thoughts. Over to Kavin to take us to the next panelist.
Thanks for that. Thanks for that, Mr. Vikas. Now, Mr. Rizwan, how involved is the AI component in the healthcare business in India at this point? If you could also shed some light, it would be nice.
So, as I was preparing for the session today, there were a couple of thoughts I wanted to share with you. One at a global level, and then we'll kind of come to India specifically, right? So, if you look at globally, healthcare AI is about estimated at about $5 billion already, and in the next 5 years, it is expected to grow 9 times. So, it will hit almost $50 billion of business opportunity can get created in the area of healthcare AI, which is quite massive, and like with many other things, it's quite likely that it may even overshoot that. And the key drivers of that, if we see, one of the core requirements for healthcare AI is the availability of data in healthcare, and especially worldwide, clinical data has started to become a lot more available. We're seeing a tremendous, penetration of, mobile devices across the world, which is creating opportunity to capture consumer and consumer health data of various kinds. Whether it could be just, blood pressure or some, health fitness to all the way to ECG type of devices. So that is creating a huge opportunity to collect, data across. And there's also a massive innovation that is happening in the world of AI technologies, right? Whether it is with some of these large guys like Google and AWS and Microsoft on what kind of stuff they allow on their platforms, but also by specialist AI tool vendors which have deep expertise in healthcare, right? So that the technology part along with the data is actually evolving very rapidly. Now, having said that, for India to scale, right, there are a few challenges that India will need to, sort of overcome. So first of all, the presence of strong skills in AI. I think the previous session kind of covered that, and especially in India, it's not just about AI skills, but it's about the skills related with clinical expertise and healthcare AI. Interestingly, if you want to do really deep work, you need to marry the math and the AI skills along with clinical expertise. So this is something that India will need to solve for, because it's such a massive opportunity for India. And the other thing that India will need to solve for is just access to high quality healthcare data, which is really important for one to do work in artificial intelligence. So solving the interoperability problem, I think, is going to become extremely important. Some of the new regulations by the government of India as part of the National Digital Health Mission, which got announced in this, late last year by the Prime Minister, is going to play a very important role in creating data sets which will be required And while the data will start to become more available, I think we need to have very strong security and privacy rules so that we are able to protect information of individual users while creating enough information in an anonymized manner required for us to do high quality analyses. So for India to solve for both these, the availability of data and then having strong privacy and security rules and regulations are going to become very important for India to truly capture this opportunity. And once we do, then it will really open up a tap of a huge opportunity for serving not only customers around the world, but also impacting what can be done within India itself. Right? So whether it's looking at infectious diseases and infectious diseases better, it could be COVID, it could be so many other malaria, dengue, so many other diseases we have. A better information of tracking population and being able to manage both at a population level, individual level can be significantly enhanced by using AI. Managing chronic diseases and India in various areas, whether it's heart disease, diabetes, and others, is sort of the global has maximum number of globally patients with these acute problems. India has the largest population, so managing some of these things, I think. Especially in an environment, which Gavin mentioned, where you don't have as many qualified healthcare professionals, a lot of these clinical interventions can start to get more automated with using better tools. And even areas like elderly care, which I think Vaibhav mentioned, would be amazingly augmented with the better use of AI. So I think AI in healthcare is an amazing opportunity for India to improve the quality of healthcare in India. But it also is an amazing opportunity for us to actually provide tools which may be globally relevant and maybe a very significant business opportunity for India at a country level, supporting global development of healthcare AI. So I'll just pause here and we'll get into more details as we go along. Yeah. Thank you very much. So Kevin, back to you.
Thanks for that. I would summarize in a bit. So Mr. Vaibhav, over to you, please.
Yeah, thanks, Kevin. So, basis our experience of working in, say, India market for last 7 years or so, I would say India, as you were saying in the beginning, I think has more fundamental problems to solve. So we have, of course, medical infrastructure, which has to build to the next level, whether it's doctors ratio, whether it is awareness about healthcare, awareness about preventive healthcare, and so on and so forth. I think that's something which India has to work on a lot more to start with. So I would say use of technology, use of analytics, and use of AI in that order are important in India. And of course, given that how we have always worked from a technology perspective, we always probably leap over some developments which happen in developed countries and go from stage 1 to stage 3, where probably a developed country would have gone from 1 to 2 to 3. So I think that's something which is there in India. So at this stage, India probably has to invest in a lot more technology and a lot more in analytics to make sure that we are getting the value of all the data which we are collecting or can collect. So I mean, India's government's initiative of doing the NDHM and putting all the data together is something which can start helping us is with that. Another context from Indian perspective is that India is still probably every state is like a country in itself. Okay, even from people's habits perspective, people's health perspective, and even what issues they face. If you see just COVID spread, if you see COVID spread in US, for example, it has been fairly uniform in many ways. If you look at the COVID spread in India, many of the states have behaved very differently actually from each other. So what kind of resistance we have, what kind of comorbidities we have, what kind of problems we face are very, very state specific, very, very region specific. So even if you look at AI, look at other segments in India, you'll probably have to look at the target population also in a very, very different manner. So that, to my mind, is a very critical point to keep in mind. So ideally, you cannot look at data from Maharashtra and apply that for, say, Tamil Nadu or for UP or Bihar. And that's, at least in our experience, we have seen across the board. And that's what has come across in COVID as well. Second point, which is important, I would believe, is that in India, is that there are things which we solve the problems which we face today. So like I was saying, elder care is something which will become very big in India. India has close to 12 crore people who are 60 plus now. So India is, of course, known as a young country, but India also is an old country, right? In that sense, India is a diabetic capital of the world, right? We get, I think, 70 lakh diabetics every year. So those kind of things which are there, which have to be looked at. And also, I think after COVID, the combination of different diseases, and the comorbidity is probably the most known word in the last 1 year in India, other than COVID, is that what kind of problems are there, and how each of the problem which I'm carrying, chronic disease which I'm carrying, will impact me from any of the new healthcare threat which may come up, like COVID. I mean, that's something which is infection management, which is there now. So I would say that from Indian context, there are 3 or 4 things which have to looked at. One is that how do we collect data, how different states behave from a healthcare perspective, and what are the big needs for us to apply AI actually, or apply analytics. So I would say in that order, the more widespread disease like a chronic disease like diabetes, elder care, probably are the bigger problems to solve today if I were to use AI, than look at like a cancer care or something which probably is quite big in the US if you look at. So a lot of the AI which is coming to India, like IBM Watson and things like that, which are getting piloted in various hospitals for cancer care, I think it still is very, very nascent from a need perspective in India. So I think those are things which we need to look at. And if we can solve these problems, then of course AI can be a significant enabler in India from spreading the awareness about healthcare and of course solving the problems.
So thanks to you three. So what I can gauge from this is AI in terms of applications, irrespective of the industry. As long as there is domain understanding, we can apply it in every industry that we think we should apply it to. But having said that, India's got its own portfolio of issues, and for us to sort of really look deep in and solve those issues is going to be dealing with about so many other countries together at the same time. So with what Vaibhav and Mr. Vaibhav and Mr. Rizwan said, can I just pick on something that you said? You said the entire market for AI is about $5 billion big, and you expect it to grow by Can you hear me? Am I with you?
Kevin, you're actually fading out. Yeah.
Sorry. So I don't know. So I was just about asking, how big is India's pie in the right $5 billion market right now? How big a role are we playing?
So Kevin, you are asking.
Gentlemen, can I ask? Can you all hear me now? Hello.
Yeah. Your video is.
As long as you all can hear me, I think if it'll be okay if we can continue. So I was asking more specifically to Rizwan and Vaibhav, very specifically, because you're always saying that the market is about, Rizwan was saying that it's about $5 billion big. So Mr. Rizwan, how big is India's share in this market right now?
Honestly, I would not be able to answer the question. I would assume that it would be very small. Probably Vaibhav has a better, perspective in terms of how prevalent is the use of healthcare AI in India today.
From an India market perspective, are we using AI in India? I think it's minuscule. It's not, I think it won't even come from 0.001% actually. So what you could be offering, creating AI solutions for worldwide market, I think that could still be, so India's IT industry could be doing enough on doing AI for healthcare worldwide. It could be there. I mean, I'm not aware of that from a number perspective. Use of AI in India is still at pilot stage in some of the large hospitals, especially around cancer care. I don't have other instances where AI is getting used in India as of now.
Yeah.
Very well. So if just for India to have a look at, and this is open to all of you, which country do you think is that example for us to build an entire ecosystem of AI in healthcare? Which country is out there showing us the way to do it well?
So, Kevin, if you are asking me, I think UK, United Kingdom is doing a lot in AI in healthcare, and same is with United States, where Eastern Europe becomes the hub for the data scientists and artificial intelligence experts. But the creating the overall ecosystem, I think these two countries we are doing really good in terms of healthcare in AI.
Okay, I can actually. I'm sorry. Yeah, because why didn't you finish?
Yes. One more thing which I want to touch base probably after you speak, Rizwan, that is the creating the ecosystem for data. Okay, so that's an approach which I want to discuss, but probably I'll do it after you speak.
So Kevin, because we only work in healthcare technology and we work with global customers, I do have a point of view on this. And the example I often give is, if you look at what happened to the mobile industry in the last 20, 25 years, right? So if you go back 20 years, and if you looked at the mobile industry, you found that a lot of the innovation that was happening in mobile industry was happening in parts of Europe and in parts of Asia. So, you had companies like Ericsson, you had companies like Nokia, and there were a bunch of others. And obviously in Asia, you had companies like Sony and a couple of, Taiwan guys. And it almost looked like 20 years back that US was sort of, in a sense, either behind or had lost that race for innovation in mobile, And at some point, as things flipped, and you can debate whether it was a launch of the iPhone by Apple or then the corresponding, sort of emergence of the Android platform by Google. But if you see what has happened in the last 15 years, the entire sort of innovation of mobile and associated technologies have gravitated, not even in the US, but I would say in the Bay Area. So today, a lot of the cutting edge stuff that is happening in the world is actually happening sort of on the west coast of the United States. Depending on your preference, you could look at companies like AWS or Facebook or Apple or 20 other companies, but they have in some ways been able to create almost a dominant position in the mobile world. Now, my hypothesis is that the way healthcare is working today, and especially in the last 5-7 years, there are lots of articles about how US is lagging behind healthcare compared to other markets. Very similar to the way it was perceived on the mobile side. I want to stick my neck out and say that 10 years from today, we are going to be looking at US for driving and being the thought leader of a lot of innovation that is happening in the world of healthcare. Because I think finally the entrepreneurial spirit and a lot of the sort of changes that have happened from a regulatory perspective are really opening up a massive amount of capital, a massive amount of thought leadership, entrepreneurial energy. And it doesn't matter what disease condition you're looking at, whether it could be diabetes or cardiac or cancer or what have you, right? There is a tremendous amount of money going into healthcare AI, and they're going to be sort of taking a very dominant role. Now, it doesn't mean that companies in India or other parts of the world, China and others, cannot. But I do feel that there is the pace of evolution of AI in healthcare is today much, much faster in US than any other part of the world. I couldn't speak of China because, one doesn't really know what's going on. But other than that, I would say US is clearly in the front seat at this point. Yeah.
I was just saying, Mr. Viber, do you have anything to add to that?
No, I'm not much aware about what's happening in so much other countries. Though we understand US, of course, is leading some of this quite well, and we. Of course, we continuously look at interest from the companies, especially from US, in terms of what kind of new technologies, what kind of basically, especially around point of care devices, those kind of things. I think there's a lot of innovation happening in the US that I totally agree with. We see enough and more interest coming around those things. How they can work that, how they can launch that in India market, because everybody believes Indian numbers are very large. So everybody, the moment they look at the numbers, is okay. Moment I have say whatever 1,000 people using ECG device in the US, then if you want to multiply population by population, saying India, you can sell 5,000 devices, and everybody comes to India and looks at how they can move that in the Indian market context. So tremendous interest from US companies. That's correct.
So just taking cues from what all of you have said, the sheer market size of India is always a very attractive factor for everybody. But having said that, it is well aware that the European healthcare system is far more evolved than that of the world. And I lived in France for about 2 years, and I've been a personal recipient of that system. And the American system is catching up with us. Is it fair to assume that the healthcare system in a country and the evolution of healthcare system in a country plays a vital role for AI in healthcare, or for India to be a leader in AI in healthcare, or to build a global business? We should first look at our healthcare business. And I would open that question specifically to Mr. Rizwan first, and then over to Vikas and Vaibhav.
So the way I would look at it is every country starts focusing on problems where there is maximum money involved, right? I mean, it doesn't matter whether you're in the healthcare business or you're in you're an e-commerce portal. Capital and people will gravitate to solving problems where there is more money, and what you'll find is that consequently there are certain class of diseases that get a lot of funding. They drive a lot of research, cancer being one of them, because such a large problem in the Western world. I think where India will need to really look at is there are many disease patterns in India, and in fact, I would say developing countries, which tend to be very distinct compared to what it is in the Western world there. So I'm almost taking a cue from what Vaibhav said earlier, that if you're looking at doing innovation in cancer, then you may almost assume that somebody in the US or some teams in the US are working on it, because for a lot of those problems, there is a massive demand in. But if you're going to look at problems like malaria and dengue and so many other different types of diseases that plague poorer countries, there is nobody doing research on that, and I think India has a very unique opportunity to complement a lot of the research that is happening in the Western world and truly drive, because if you look at mortality rates, right, then today, I don't have the exact data, but some of these chronic diseases in India are big killers. There are millions of people who die of malaria. So, or just because it is not covered by the Western world doesn't make the problem any less. And there are other factors, which impact healthcare. It could be immunization. It could be sort of quality of sanitation and other things which can get picked up using healthcare AI very well. So I think India has a very unique opportunity to drive and complement healthcare AI to what is happening in the Western world there.
So just before I pass it on to Vikas here, Vikas, can I just tweak taking inspiration from Mr. Rizwan's statement? Do you think there is enough domain knowledge in India in this space of healthcare for it to act as a leader in healthcare and AI in the world? Do you think we have enough domain knowledge? This is over to you, Vikas and Vaibhav, both of you, please.
Yeah, so I think domain knowledge is developing. Okay, so there are a lot of training institutes, providing individual courses on artificial intelligence. It is developing, but use of AI in healthcare is something which is still to be merged. And the basic requirement for artificial intelligence growth is requirement is data. Now, I've been hearing since morning in this conference that data is something very critical. It is sensitive in nature, AI, and you can't just have a hand on data very easily from the hospital. So how do we work? So one of the approach which why India has potential, that is, let me put it first, why India has potential, because we have huge population and we have a healthcare system. In whatever way, we definitely store the data. May not be digital, it may be in physical form. So one of the approach which is being which I recently studied and is developing in healthcare is federated approach. So in data for AI healthcare. So federated approach is something which is already being tried for last one and a half years by Google in developing their own Google keyboard. Okay, so the same thing is being adopted in Britain by one of the companies which is trying to develop a algorithm, artificial intelligence algorithm based on federated. How federated approach works is that instead of having the data at centralized location, you have it distributed in multiple clients. So for example, you have 100 hospitals, have all the hospitals retain that data in their own, and it doesn't come to the people who are working, and then run the algorithm in those respective hospital, get just the parameters like weight, bias, and rest of the hyper parameters to the central location. Now you work on those hyper parameters and improve on, send it back to the client at different hospitals. So the data doesn't leave the hospital. So if this federated approach is done in India, how we what we can do is we can get large population based data across the India. So for example, we can get data from south of India, east of India, north of India. So the solution which will develop will definitely be very accurate, and it will not be biased, which we find in the current system, because something is being developed in the United States, for example, as Rizwan said, for cancer detection. They are mostly using data of patients out in US. So those kind of solution is not going to work in India, and it will definitely be biased. So for India to have our own solution, I think federated approach is something which companies should look at. That will protect the data. That will create a new ecosystem where, without fearing that data will be misused, the workers, I mean scientists of artificial intelligence, can develop on them and create new solution which will not be biased. I think that is something which we that is my thoughts on this.
Thanks for that. And so over to you, Mr. Vaibhav.
So I have a little bit contrarian view on this. The way I look at it is that if we are looking at solving the AI problem for the world market, I think then we should look at things like cancer care, orthopedic care, things like that. Actually, I would say because those are the big problems worldwide. Actually, if you look at for an Indian market and say, and as you are asking about data, I think India has, if you see even the healthcare startup ecosystem of Indian healthcare in last few years, a lot of work is happening on the fitness side, on the preventive healthcare side. And India probably has a tremendous opportunity. And even if you see data collection, I think a lot of data is getting collected on that side. So if India, we believe that there's something which we can do with AI perspective or from analytics perspective, I think a lot of work can happen on the preventive healthcare side, on the chronic disease management side, on the wellness side, because that's something which India is a very unique story about. And given that we have such large young population also who is more focused on wellness today and fitness today, which we never saw in India earlier, correct? So I think from Indian market perspective, if we look at solving that problem, if people remain more fit, okay, then you don't, I mean, of course, it's about more of not getting into like a surgery and things like that. But that's what I would put from an opportunity perspective, including data access, data collection, and AI. I would say preventive healthcare, wellness, chronic disease management could be much larger opportunities in India. That I think is one way to look at it.
So just to sum up something that I was looking from all of you as I was hearing here. So I was hoping to understand if the Indian health system should evolve for Indian health system in AI, or AI in Indian health system to evolve, right? And because when you see at developed economies where Mr. Rizwan spoke about Europe, the healthcare system is so evolved at this point, and everybody, I think Estonia has a digital passport, health passport at this point. And rightly, where Mr. Rizwan is talking about the national digital health system, right? And I think that is on the similar lines, if I'm not wrong. So what I was hoping to understand is, do you think more people should invest into the improvement of Indian healthcare for us to be better players for AI in healthcare? Can I just sort of pick on Rizwan specifically for this one, please?
The core of the data problem is so there are obviously multiple layers of sort of healthcare. So one is, as Vaibhav mentioned, targeting young folks who are not admitted in hospitals or don't see a doctor, but they are just looking at wellness, right? Where you can extract a lot of data even today from an Android phone or an Apple phone and do a lot of work. So there you're not data constrained because there's a lot of data already starting to become available. Then you look at stuff like elder care, which is the other end of the spectrum, which is, again, you're really taking care of the wellness of the old people who may or may not have a disease condition. And then a lot of when you talk about the classic sort of healthcare in AI, you're really talking about improving lives of people who are sick, right? Who are either sick because they're diabetic and you need to manage them, or they are an acute case where you are actually admitting them in a hospital, right? So that's sort of more sort of, if I exclude the wellness part and the elder care part, then the stuff in the middle is the people who are actually sick, who need to get either chronic disease or whatever. The problem there is, and what we've seen, and the reason I was talking about US is, one of the core requirements to collect high quality clinical data is the availability of an electronic medical record system in a hospital or a physician office, right? So that is the core application that you need to capture clinical information when somebody gets admitted into a hospital, or the clinical notes that get written when a person visits a physician office, right? And the reality today is that, maybe with some very, very few exceptions, most hospitals and most doctor clinics in India don't capture clinical information of a patient which they treat, so who they treat. So the information clinical may be in kind of handwritten notes, or they could be prescription from a physician, etc. But that's not digitally available to do any analysis. So fundamentally, how do you change that? And how do you evolve from a country where healthcare, I'm not talking about a billing system which will bill you when you get discharged from a hospital. That is already automated in most hospitals. I'm talking about actually capturing clinical information, the lab information in a searchable manner, in a manner that data can be analyzed. For the most part, that entire layer of technology in India is missing. 15 years back, even in the US, it was missing, right? And it took a lot of changes in government regulations, lot of government incentives, lots of government penalties in a 15-year period for them to transform their entire healthcare ecosystem, with almost sub 10% deployment of electronic medical records in the US in hospital systems, to today close to 90% deployment of electronic medical records across the entire US. And it was a 15-year journey for a country like US with all its resources to do it. My guess is that it will take a significant amount more. Whether India will take 5 years or 15 years is something we can debate, but it's not something that's going to happen quickly, right? So, and it will only happen with a very, very determined effort. So some of these factors are really important to collect a rich healthcare data. Now, I'm not saying the whole country has to, sort of transform before you can get healthcare data, but some of those underlying technology platforms are required before you can capture data at scale of high quality across the country. So I'll just pause here.
So taking from what you said, just over to Vikas on this one, and you spoke about the whole federated approach for data collection. Yeah. And, for India to be a leader in AI in healthcare, with the current regulation system in place, do you think we are at the right place, or do you think there's a lot more evolution that is necessary?
I think we have to build up this.
Yeah. Sorry, I lost that. Yes, please.
We have to build up the system, and somebody has to take a lead, whether government or a chain of hospitals, that how do we store the data? And that is the reason I suggested a federated approach, because it is GDPR compliant. You don't take the data out of the hospital. The people working on those data, the data scientists, they don't know actually they don't even need to anonymize the data, but they just work on that. The only thing is we'll have to create a system wherein this data is properly used for relevant use cases. We have to create the required fields, how the data is stored, and if we can bring some kind of commonality across India, then I don't see a problem in solving many problems which we are facing in terms of healthcare. So basic backbone is required to be built, and someone has to take a lead. I mean, government obviously is doing something, but they should take the right path to create an ecosystem, and probably large hospital chains can also start building on their own. I'm sure they are doing it, but something which is still not known to the people who are working in this area. And those data should be presented to, if it is anonymized, then it can be presented to the people who are working in this field, and they are encouraged to create some use cases and solution for them. So that is the way forward which I can see. I think there is a lot of potential, but we just have to build the backbone. I just like to quote here that I was reading one article. There is one doctor. She's of Indian origin, but she's Fiji born, and she is a doctorate in clinical cognitive science, wherein she studies the minds of the doctor, how they make decisions in the hospitals. And that's a very interesting area, because doctors, for similar disease, the doctors will make different decisions at different times. And if you can apply artificial intelligence, probably non-trained doctors or new doctors can decide on certain disease. So those kind of level we have to reach, and we have potential to reach. I think we just have to create the backbone.
Just gonna hold on to you a little longer on this topic itself. There is the whole issue of data privacy when service is provided in one country and the data is stored in another country, right? And we see that happening so often right now that every country is requesting for data to be held within their geographic limits. How comfortable is the world dealing with India at this point? And considering we're talking about AI, which is heavily reliant on data, how comfortable a country dealing with Indian companies and people who choose to keep data in India maybe?
I think they have to comply to that, and I think the new technology is emerging wherein you don't have to take out the data out of the country, and you just have to. This is all. It has changed in the last few years, because we have seen tremendous amount of processing power which has evolved with GPUs. So earlier, for example, they need to have a centralized data warehousing in the US for a company like Facebook or Google. But now you can have same amount of data inside the country with less investment, with the coming of GPUs in last, and it is evolving. The processing power is evolving day by day. I think data storage in India for Indian usage will not be a problem, and data storage for respective country in those respective countries will not be a problem anymore, because the only thing is, in fact, the edge solutions these days are coming, have tremendous capacity to store the data, and that is the reason why I spoke about federated approach, because in the small device also you can run algorithm with the localized data and just pass on the parameters to the centralized server to create a more robust system. So those kind of things I am seeing in coming months, years. Definitely, this is very exciting decade in terms of artificial intelligence and the infrastructure. I think it will not be a problem for the countries to store data in India, and a lot of things are coming on edge now, at the edge processing.
Thanks for that. Now, just over to Vaibhav, because we have just about 7 minutes, and I have an interesting question that you spoke about earlier. Now, from our conversation over the last 40 minutes, something that we've understood is AI can be used at various levels of deployment. One is in advanced, medical care, and then you're looking at preventive, and then you're looking at overall wellness. For India to be a leader in AI healthcare, which sort of the section of the whole chunk of AI in healthcare should India focus on, do you think?
So India is looking at, from an Indian market perspective, from an Indian consumer perspective, I would say we'll be better off in preventive care, primary care, chronic disease management, those kind of areas. Because I think because India is still is a fairly large country from a young population perspective. If we solve problems for them today from wellness perspective, I think it also is stopping many of them from becoming sick actually. So I think if India has to look at investing in AI, I think we'll be much better off, and from a market reach size perspective also, we'll be much better off working on these three areas. So we look at wellness, we look at preventive, we look at chronic disease. I think that's something which is very important for India. And I think COVID has underlined that. If you ask the same question 2 years back, we all go by how Western world has been looking at it. But if you look at today, post-COVID, India has behaved very differently. India's problems are very different from a healthcare perspective, and so are the segments. So my suggestion is to look at these segments if you are to invest for India market perspective.
So one statement open to all, but I'd like to wrap up that question in a minute. Do you think India should sort of look at, there's look east and look west policy, but then there's also look Africa policy, right? So with India in this place, which sort of international market do you think Indian ecosystem should go after? Open to all. Anybody's, please. Mr. Rizwan, if I can start with you, if that's okay.
I think we should do two things. We should focus on the Western world, US, Europe, to make a lot of money. Okay. Because there is a massive amount of money to be made. And then we should look at India to solve India's problems, because India is very large and we have enough of our own problems to solve before we can attempt to solve other people's problems. So those are the two things I would do. Yeah.
Yeah, so I will add to that, Rizwan, you make a lot of money from US and Europe market. Please give it to us for CSR. We'll use that to do for Indian market.
I think I'll agree with Rizwan and Vaibhav. Both. We have to make some money, okay, and so we have to create some use cases for Western market and create some money so that we can, invest back in India and poorer world. So that I agree with us.
All right. So one closing statement from all of you. We're going to have a few seconds for all of you. And I'd like you to say whatever you'd like to say about the AI in healthcare business for India to be a global healthcare leader. Please. We'll start with Mr. Rizwan again.
I just think we have to excite new graduates who are graduating in the fields of maths and sciences and engineering and medicine to start investing more of their time in some of these areas, which are less exciting and sexy compared to starting a new portal or a gaming company, because that's some of the real problems of the world. And if we can do that, I think many of the things will take care of themselves.
Over to you, Mr. Vikas. Thank you there.
Yeah, so I think the interest is there, and the right curriculum, because it's that very, very dynamic and changing very, very. So right kind of curriculum should be designed so that a short-term course can lead us to generating experts. Also, right type of use cases which can be sold. Which can make money, because only research will not help us. We'll have to create solutions which can be researched and then sold to the local and global market. That is the way forward for us in this field.
Thanks for that. Over to you, Mr. Vaibhav. You're on mute. If you could unmute yourself, please. Thanks.
Yeah, I think from my perspective, what Rizwan was saying is that we look at the developed countries market, we look at how they use AI and how they're benefiting their population at large, leveraging AI. I think there's tremendous learning. Of course, to create business, we can create business, supporting them doing that for next X number of years, and we also learn as a country on how AI can help. So basically the SOPs of how to leverage AI, I think a lot to learn in next 3 to 5 years. And then we take those learnings in parallel and of course sequentially and see which all areas they will fit well, which are our problems to solve as a country, which I think will play out quite neatly, maybe next 3 to 5 to maybe 10 years. I think that's probably the way to look at going forward from an AI implementation and usage perspective.
Thanks a lot for that. And thanks to you three wonderful gentlemen. Thank you to Mr. Rizwan, Mr. Vikas, and Mr. Vaibhav. Just to close up, we've heard about the market possibilities with a $50 billion opportunity for AI in healthcare. India has problems of its own, and I think India should look at problems of its own to fulfill the needs of AI in healthcare in India and make healthcare available to more people. But having said that, taking it from all these gentlemen, it is good to get out there and use our skill sets and monetize the opportunity that is out there. So thanks to you three wonderful gentlemen, and I should say thank you to Mr. Rajesh and thank you to CII for organizing this wonderful platform for us. And over to you, gentlemen. Thank you.
Kevin, yeah, thank you very much for being an amazing host and for coordinating this very interesting topic among all of us. So I appreciate all your sort of inputs and coordination.
Thanks a lot for that.
Listen,
Thank you.
Thank you.
Thank you. Thanks a lot. Thank you. Thanks, Kevin.
Yeah. Thanks our panelists, and thank you, Mr. Kevin, for this wonderful session, and encouraging everybody to talk about how we can become a global leader in AI. And it's great to hear that we can sell use cases and make money, and then money can be used in our own country. So thanks once again everybody for this wonderful session. And then we move to the other. Now we have a small TikTok sessions. So we'll move to the another session, which will start another 2 minutes time.
Amit, Mr. Santosh is, Dr. Santosh is there, please.
Dr. Santosh, good afternoon.
Good afternoon. Good afternoon. How do I present?
Sir, your presentation is already, we have activated. Pratik, have you given the right?
No, no need to give right, sir. You have to clear the share option and you can show your presentation.
Share. Okay, I have to click the share in the above. No?
Share, and you have to browse from your system and just yeah, it's visible, sir. It's you have share screen, I think.
Is it visible now?
1 minute, sir. It's coming. There is a 4-second lag will come. So 1 minute. No, sir, it's not visible. Sir, you can do one thing. Click the share option. Otherwise, you can go to the below. There is an option is share file.
Sure. Share my meeting window. That is coming. And
Then
after
you have
that,
to
when
click
I
that.
open,
You have to click your PPT. Open
yeah, I
your
have
PPT.
clicked my PPT. Are you able to see?
No, not yet, sir.
But my PPT is coming on full screen.
But we are not able to see you.
Oh, 1 minute. Okay.
So there is another one option. If you do the stop sharing, or if you click the share option in the screen of the Cisco WebEx, if you go to the below portion, there is an option of share file. From there also you can share. Browse it and you can do that.
More options, reactions to this is.
Not more option. In share you will be able to see, sir.
This is. So my window is
Your
you're able
window
to
is yes. Where window
but
we are
why
able
my
to see.
PowerPoint is not coming? Why the PowerPoint is not coming? I don't.
Sir, otherwise you can do one thing. If you want, you can share PPT to us. We can share from outside. That is also possible.
Okay, how do I do that?
You can send me email right now.
Okay, just tell me your email ID.
Pratik, Pratik. Dot Mukherjee, Mukherjee, sir.
Okay.
@CII.in. Sir, I have texted you. If you can see your mobile.
You texted me, okay.
You can see, you can cross check, sir, please.
I'm just sending you that.
Yes, sir, please send me.
You have messaged me or you send me in WhatsApp? Oh, okay, I got it. All small letters, no?
Small only, sir. All small, sir.
Okay, sure. I have sent it.
I'm not yet received. Just give me 2 minutes. Might be it's on the queue.
Have you received it?
No, not yet, sir. Yes, sir. It has come. 2 minutes.
Okay.
We are sharing from our side. Just
Yeah, okay.
it's uploading, sir. 2 minutes. Huh? You will be
Okay.
able to see your slides. 1 minute.
Sure, sir.
So it's up now.
Yeah, I can start.
Sir, if
Yeah.
you just tell us the next slide, then we will do the next. Okay, sir, please.
Yeah, sure.
Okay, fine.
So good afternoon, everyone, and thank you for joining us on conference on AI in healthcare. So we'll start our small, talk session with Dr. Satish, who's a professor of cardiologist, Jawaharlal Nehru Institute of Postgraduate Medical Education and Research. Sir, this session is all about AI for early detection and control of heart disease, especially for rural areas. So we take it to you and then we'll start the presentation, sir.
Thank you so much. I thank the organizers of this particular program of CII for giving me the opportunity to give this talk to you. And we start with this. I just made a little bit modification of the title because I'll just explain in the next few slides why it is cardiovascular disease instead of heart disease. So it is heart pertains to only the organ in the chest, but the cardiovascular system includes the heart as well as the whole blood vessels from the head to feet. That is why I just changed the title a little bit. So that is how we define that the technical term for the heart disease is that, because for example hypertension and other conditions, all these things are together grouped together to call it as cardiovascular disease instead of heart disease. So next slide please. So the next few minutes I would like to brief you about these 6 major points. Why cardiovascular disease is important, what are the subsets of cardiovascular disease, and what causes cardiovascular disease, and what is the traditional approach to early detection, prevention, and control, and what is wrong with the existing systems, and how disruptive technology with AI-enabled systems is the need of the hour, and how to take it forward. I mean, the roadmap, how to do it. So this I will try to do it. It's a quite a exhaustive topic, and I am not very well versed in talking to non-medical audiences. So kindly excuse me and please stop me in between if you do not understand anything, or if I am using too many medical jargons. So next slide, please. So this is just a slide to put things in perspective. Means all of us are worried about COVID-19, and this is the total number of people who died because of COVID-19 till December 2020. It is approximately 2 million. Next. And if you see in 2020, the number of people who died because of cardiovascular disease is 19 million. So that means it is such a huge numbers. We shut down countries, we shatter economies, and we bring in militaries and police to swap fines on people to change. That is, if you don't wear a mask, you get a fine. If you step out of the house, you get beaten up for a disease which has killed 2 million people. But what are we doing for the disease which has killed 19 million people in the world in 2020? So with this brief set induction, I go into my presentation. It's a huge disease. And next. This is the leading causes of death in 2016 and 2020, and predicted in 2040 in the world in global burden of disease. In leading causes in 2016 across the globe was ischemic heart disease and stroke. And leading causes in 2040 is going to be ischemic heart disease and stroke. Even I don't have the graph. Even in 2080, that is ischemic heart disease and stroke. Ischemic heart disease means heart attack, and it's all other conditions which causes heart disease because of block in a blood vessel in the heart. And stroke means a block in blood vessel that goes to the brain, which causes paralysis, that is stroke. So you can see in the world, this is the global data. This is information is from the global burden of disease data from 2017. Next. And this is looking at the India. India, what is the status? In 1990, cardiovascular diseases was not the most common cause of death in 1990. But if you see in 2019, cardiovascular diseases have come top. So these cardiovascular diseases include heart attack, stroke, as well as hypertension. All these things put together is cardiovascular diseases. So that is the most common cause of death in India now. And it is going to be the most common cause of death for all of us who is there in this meeting, as well as our children and our grandchildren, if we do not do something drastic. Next, please. So this is WHO in 2017 has told that we have cardiovascular disease is the most common cause of death in the world, and it amounts to 31% of all deaths, 17.7 million. And more than 75% of the CVD deaths occur in low income and middle income countries. And of all CVD deaths, 80% are due to heart attacks and strokes. Next, please. And this is just to put things in perspective. What you're seeing is the blood vessel. In a blood vessel is a cross-sectional image of the blood vessel that is going to the heart. And the first one is a normal blood vessel, and the last one is a blood vessel in which a person who is having a heart attack. Please remember, just because any one of us in this audience or any of the people whom you know haven't had a heart attack does not mean that your blood vessels are like the first one. All our blood vessels are either like the second, third, or the fourth one, and not like the fifth one. So we do not know when we are going to get the fifth one. But remember, our blood vessels are not like the first one. Our blood vessels are like the second, third, or the fourth image. So this coronary disease is because of buildup of plaques, deposits, plaques. The plaque means it's a swelling inside the blood vessel, which decreases the diameter of the blood vessel, so that the amount of blood that is flowing through this blood vessels will keep decreasing. So most commonly, all of us know that this is causing a problem in the heart, but also it can cause problems in other organs, including brain. So most common is heart, second most common is brain, then other organs like kidney and other organs in the abdomen, as well as the lower limb. All these vessels can get affected by this condition called atherosclerosis. Atherosclerosis is what ultimately causes ischemic heart disease and stroke. This starts in the fetus. It doesn't start at the age of 20 years or 30 years as everybody thinks. It starts even before we are born. And based on our genetic factors as well as how we live our lives, the rate of progression and when we get a myocardial infarction or a heart attack or a stroke, that is what decides. Next, please. So if you see what has happened to the cardiovascular disease death rates across the globe between 2010 and 2019, it is heartening to see that very large areas of the world, even though cardiovascular disease and heart attacks are the most common cause of death, the percent change, if you see, there are large areas of the world it is negative. That means there is decreasing the number of people who are dying because of heart disease, cardiovascular diseases. But sadly, if you look at the map of India, you can see those are the many parts of India. Many parts of India means any area where the map is absolutely wide, there is no data. And many parts of India, if you look closely, you can see that it is increasing, and some areas are alarmingly increasing. If you see that more than 15% increase is seen only in areas of India and some parts of Africa. So that is very alarming. Next, please. And the countries with the highest number of cardiovascular deaths are China and India. And if you see in 2010, between 2010 and 2019, the jump from in China and India is slightly different. In India, it is the jump is much more significant, even though our population is much less than India. Whereas in other countries like Russian Federation and other things, it is decreasing. United States of America, it is increasing because the age of the population is increasing. Next, please. Now, when you look at cardiovascular disease, what exactly this is a global data, what exactly that is around 50% of the deaths is due to ischemic heart disease. That is because of heart attacks. If you look at the other largest subset, 17.7%, the brown color is ischemic stroke. That's nothing called brain attack. And then other conditions, all the other conditions are there. So if at all we want to control heart disease or cardiovascular disease, we need to target these two major subsets of cardiovascular diseases. Next, please. So this global burden of disease study, they looked at different aspects of different conditions, and then they found out these are the highlights of that study published in 2020. The burden of cardiovascular disease and death continues to increase across the globe, and cardiovascular disease burden attributable to modifiable risk factors continues to increase globally, and countries should invest in existing cost-effective public health programs and clinical interventions to target modifiable risk, promote healthy aging across the lifespan, and reduce disability and premature death due to CVD. So this is the key solutions that they have provided. And now let us see how we can implement this in a resource poor country like India. Next, please. So we need to detect and manage modifiable risk factors. So I need to explain to you what is a risk factor. Risk factor is something which enhances the risk of developing a disease. For example, all the points that is shown here is this upper part is ischemic heart disease, lower part is stroke. Just ignore the stroke, just look at the ischemic heart disease. It is mentioned as dietary risk, high systolic blood pressure, air pollution, high total cholesterol, tobacco, high fasting plasma glucose, that is diabetes, and high body mass index. Body mass index is weight in kilograms divided by height in meters squared. So that is a indicator whether your body mass index is normal or not. So now what this means is there are risk factors called non-modifiable risk factors. For example, just because a person is a male, somebody is 50 years male, somebody is 50 years female, the male person has got double the risk of developing a heart attack just because that person is male. Then second is genetics. A person who is from India, whether he is in India or US or any part of the world, has got at least 3 times the risk of developing heart attack compared to a Indonesian or Chinese, or 5 times the risk of developing a heart attack compared to the French. So this is all because of genetics. And if you have a family history of heart attack, like if your dad or mom had a heart attack, the chance of you developing a heart attack is much higher than a person who does not have a family history of heart attack. So they're all genetic factors. This, we cannot change our genes as of now, and we cannot change our sex, of course, and we cannot change the country or the ethnicity and other things. But these things are actually what is shown in this graph are the modifiable risk factors. So now when you look at the modifiable risk factors, you can see the dietary risk is one of the largest risks, and then high systolic blood pressure. What it means is, the larger the graph, the higher the risk of developing a heart attack. So dietary risk means, among the dietary risks, there are two major conditions. One is amount of salt a person takes, and second is amount of fresh fruits and vegetables a person takes. If these two things are, that is, amount of salt has to be decreased and amount of fresh fruits and vegetables that a person eats has to be increased. Then second is high blood pressure. If somebody has blood pressure, will that person know? No, that's a problem. That's the problem with managing this, detecting the risk factors of the disease and managing that. Because the problem is, if I ask you how much salt you have taken today, you will not know. Because do we take the amount of salt that we put in our diet, do we measure it and take it? No. So that's a problem. But if I ask you how many servings of fruits and vegetables that you have taken today, that is slightly easier to detect, but how do you monitor that? Then second, blood pressure. If I look at a person, I'm a doctor, if I look at a person, can I tell his blood pressure? No, it cannot be. I have to take a blood pressure apparatus, tie it on his arm, and then measure the blood pressure. Again, that problem is, unless otherwise the person comes to a doctor, he is not going to check the blood pressure. Even if you go to a doctor, not all doctors will check the blood pressure. That's another problem. If you have blood pressure, 90% of people who have high blood pressure means it is anything above 120/80, and anything above 140/90 is called hypertension. And what percentage of people having a blood pressure of above 140/90 who does not know that they have hypertension have symptoms because of high blood pressure? Less than 10%. That is, a person will be detected to be having high blood pressure most probably when he goes to a hospital or some health checkup or something, or he has some other condition, or he develops a heart attack. That time only it is detected. He would have had high blood pressure for many years, but see, the risk of high blood pressure, the causing heart attack, is very high. And third is air pollution. So there are different maps of air pollution available across the world, which has they're correlated and found out highly polluted cities, the risk of heart attack is higher. High cholesterol. Can I look at a person and detect high cholesterol? No, you need to take out the blood of the person and evaluate how much the person's cholesterol is. Then only we can say this person has high cholesterol. Next is tobacco. This is very easy to do. This is actually the most easy and most cost-effective way to control. But the problem is, because this also involves behavioral change, strict legislation and increasing tax on tobacco, that is what that means. There is not much things for AI to do in tobacco. Well, there's some small things. Other majority, it is legislation and banning tobacco and things like that in schools, in public places. These are things that brings down the tobacco use. And then high fasting blood glucose, that is diabetes. Diabetes is a very high risk of developing coronary disease, but controlling the blood sugar improves the outcome of heart attacks. But if you see, the risk of high blood glucose is the modifiable risk is much less than dietary risk and blood pressure risk and high cholesterol. And the last but not the least is high body mass index. If your body mass index is higher, the risk of developing a heart attack is higher. Next, please. So this is just the effective intervention. If you control each of these factors, how effective it is, or how many deaths in thousands can be prevented. Means the previous one was the population-wide approaches. This is if you control the blood pressure, control the weight, if you increase in activity, smoking, all these things. If you can see this, controlling the blood pressure is the most satisfying and the most effective way of decreasing risk of heart attacks. You can see that it has got a chance of decreasing deaths in thousands by hundreds of thousands. So that is the meaning of this particular graph. Next, please. So what are the high priority areas? So the high priority areas, according to WHO, which was this particular guideline was given in 2016. WHO says that you have to focus on hypertension, diagnosis and treatment, early detection of hypertension, how to detect hypertension early in the population, how to treat the hypertension in the population. The problem is, in United States, only 60% of the people who have high blood pressure are detected. And among the people who are told to be having hypertension, only half of them are taking medicines in United States. And of the people who are taking medicines for hypertension, less than 40%, that is less than 40%, around 1/3 only, the blood pressure is well controlled. This data is not from India, this data is in United States. You can imagine how the situation is in India. In India, we have a unique, or rather, the bad thing about India is coronary disease has got bigger problem in India, because Indians are at a higher risk of developing coronary disease. And coronary disease, the mean age of developing coronary disease in most of the European countries and Americas are above 65 years. In India, the mean age is between 50 to 55 years. It happens much earlier, almost 10 years earlier in India. So that is very important point. Next, please. So this, if you, one of the targets of the WHO is that we need to reduce the prevalence of hypertension by 25%, reduce daily tobacco use by 30%, and provide more than 50% of eligible population with secondary prevention. Secondary prevention means if somebody is hypertensive, the risk of developing heart attack is high. And somebody who has had a heart attack, the person again developing heart attack is very high. So with meager resources in rural India, even in urban India, it is very difficult for us to reach out to all the people with hypertension and coronary disease and other conditions and ensure that secondary prevention. Secondary prevention is a person is already having the disease and we are trying to prevent further progression and further attacks. So the goal is to have global cardiovascular disease mortality should be reduced by 25% by 2025, that is 3 years from now. Next, please. So there are a lot of recommendations for implementation framework from WHO. Means if you look the lowermost column, so digital tools for behavioral change, this is where we come inside. If you look at the evidence is limited, this is in 2015 diagram, and the biggest advantage is if you look at the fiscal impact, it is relatively low cost. The last row, please. Last row and last first column to last column. Takes time to implement, unlikely to create dissent, and requires cooperation. This is where the artificial intelligence comes inside. Even though there is limited evidence, the more evidence is coming in that digital interventions can bring in change. Now it is relatively low cost, because if anybody having a smartphone, it can be delivered, and it can take time to implement because adaptability is there. But biggest advantage is political feasibility, because it is unlikely to cause major problem like tobacco lobbies and sugar lobbies and salt lobbies and other things. But it requires cooperation from multiple players. That is very important. Whereas all the other things are targets at controlling cardiovascular risk at different levels. Next, please. So now, what are the 10 proven steps to prevent heart attack? To put it across simply, if you do these 10 things, we can prevent heart attack for us as well as for our children. See, very important, as I told you, the risk of developing heart attack in India is, it happens, the average age of a person with heart attack is 45 to 55. Whereas our average age of developing heart attack in United States and Europe is 65 to 75. So it's 10 years earlier. So in United States, they say that anybody who crosses 18 years, they should undergo screening for risk factors, and they should start risk factor modification in adolescence and childhood. Please remember, if heart attack is happening 10 years earlier, that means we need to start this preventive therapies in India in much earlier age. So we need to start early. That is, at least by 15 years of age, all school children should be educated regarding the risk of heart attack and how to prevent it. That is not happening in India. And we need to stop tobacco in all forms. More and more youngsters are getting into smoking, and younger children are getting into smoking. That is another problem. Next, please. We need to start a national level checkup. This is available in US and many states of Europe and China. We need to check for everybody every year ensure fasting blood sugar is checked and ensure that it's less than 100. Cholesterol is checked and LDL should be less than 130 and blood pressure should be checked and it's less than 120/80. Next, please. And then we need to ask the people to reduce salt to less than 5 grams per day. And people should avoid as far as possible sweets and sugar. And weight control is very important. Increase exercise and decrease calorie intake to maintain body weight to achieve body mass index of less than 25 and waist of 80 centimeters in women and 90 centimeters in men. And increase exercise by brisk walking, minimum 30 minutes per day, that is more than 10,000 steps per day in a pedometer. Increase fresh uncooked fruits and vegetables of more than 5 servings per day. Sleep more. 9 hours is ideal, at least 7 hours is minimum. Manage stress in whichever way you want. Now the issue is like this. How do you start early? 15 years. Is it possible to target all school children through the school teachers and parents? No. What does a typical 15-year-old do? Typical 15-year-old do not read newspapers. They hardly watch movies in theaters. Most of them are stuck to the internet. They play games. So we need to have innovative strategies, AI-enabled strategies to target this population very early. This is where the AI comes inside. Google has this Google AdSense in which whatever you are seeing, whatever is your profile from your emails and whatever you're searching, you have the ads coming. Similar, Google is the largest search engine and that's the most widely used search engine. So if Google can provide information regarding cardiovascular disease based on the map that I showed you, the map says that these are the areas with high prevalence. These are the areas where we need the earliest interventions of risk of. So the problem is, all of you know that we go to a film theater or at the beginning of the film, they will say, and we have seen Amitabh Bachchan coming and telling us about the risk of tobacco smoking. Amitabh Bachchan, Amir Khan coming and telling about the risk of tuberculosis and everything. Has anybody told you that you need to eat 5 servings of fruits and vegetables per day? Nobody has told you, because that is one of the most common risk factors in Indians compared to the West. Because in India, even vegetarians destroy the vegetables and eat. This is the problem. Then stop tobacco and all forms of smoking, not much role for AI. Check up from 20 years, because if once somebody, because every person who is using a smartphone, there is technology to know the age of the person, right? When we register. So based on that, it is important to push such notifications to them. Of course, we need permission from government. Of course, we need to have, because the problem is most of the restrictions about data in the public domain about personal is skewed towards privacy. Of course, there are threats towards privacy, misuse of data, all these things, but this is the time has come that, like COVID, we need to have drastic steps, especially in a country like India, to use digital interventions to target the people and give them the information and start monitoring the information. Maybe even automatically, we may have to convince the government that this is the only way forward. It will take another 60 or 70 years for India to enhance our health infrastructure to something similar to Europe or US. By then, millions of Indians will die because of coronary disease and heart attack. And reducing salt 5 grams per day, again, it is difficult to use AI in this reducing salt, unless otherwise we have some image-based recognition, which is possible, because there was this Google Lens, and if Google Lens or something similar can take a photograph of the diet that you are taking, and that photograph can assess the amount of salt in that particular diet, then it's great. Then sweets and sugar. Please remember, the biggest addictions in this world that is killing millions of people are not tobacco, alcohol, heroin, marijuana, and things like that. The biggest addictions that happen in this world for you and me and all pervasive addictions is sweet and sugar. That is sugar and salt. So this is a major problem. The less salt you eat, the less sugar you eat, it is better. And weight control. It is estimated in 2 studies done in Kerala and Chandigarh that 40% of the school children in these 2 states, the studies they found that are obese. That is, their they're having excess body weight. Just now I told you that BMI of more than 25, there is a risk of developing heart attack. At the age of 15 years, if they're 40% of them are obese, what is going to happen when they are 25 years, 35 years, 45 years? That's a problem. And increasing exercise. Anybody who is having a smartphone has got a steps counter and accelerometer, which can count the number of steps. And more and more people are using wearables, and this wearables and this mobile phone based step counts are available in the phone, and this can be accessible by the maybe the service providers or the software developers, which can be used by government to target people for positive behavior. Means one example I can suggest is many of the things that I say maybe may not be palatable to even many of the administrators initially, but my belief is that we may be able to convince people that it is possible to do such things. If somebody is not walking 10,000 steps per day, maybe the person may have to versus a person who is walking more than 10,000 steps per day. We can give we can give tax rebates for people who walk daily more than 10,000 steps per day, and the insurance premium for a person who is walking 10,000 steps per day is automatically reduced. This is very complex. I know it has got a lot of ethical issues and everything, but it is important. Unless otherwise we take some drastic steps like this, where we have pervasive technology and pervasive positive feedback and negative feedback for behavioral change, is going to be a problem. Another problem is these 10 things. It is easy for me to tell you to do that, or tell I am not talking about patients. Please remember, this 1 to 10 has to be done by all the people in the population. That is where the problem lies. When does a person come to a doctor? The person comes to a doctor once a person becomes a patient. Please remember, as a cardiologist, the number of heart attack patients whom I treat every day is, before COVID, it was around 10 per day. During COVID, okay, everybody was not coming to JIPMA. So it fell down to almost from 2 to 3 per day. Now again, it has come back to 10 per day. So of the 10 people who come to me for treatment of heart attack in my department, hardly 1 or 2 of them would have ever gone to a hospital for maybe diabetes or hypertension. Remaining 8 of them would have never gone anywhere near a hospital, would have never checked their blood pressure, never checked their blood sugar, never checked their cholesterol, nothing. And then they'll end up with heart attack. This is where the problem lies. How do we reach out to these people? This is where the utility of AI comes inside. I cannot catch a person who is walking on the street and tell him, no, you come, you do this, is not possible. Neither it is not possible for me, it is not possible for government of India, it is not possible for any government anywhere in the world. But remember, all of them are walking around with a smartphone, and it is most of them are hooked onto their, so the first thing that a person wakes up to and looks at is not their child's face or a wife's face, spouse's face or something. The first thing that most of us look at is the face of our mobile phone. The last thing that we look at on everyday basis before we sleep is also a mobile phone. So I think we should use AI enabled technologies through mobile phones, which has become the primary mode of access for accessing information, including data as well as communication between people. Primary mode has become, if you ask me how do I communicate with most of my peers in my institution, it is through WhatsApp. It's not through phone calls anymore. And if I have to make a phone call, I always use WhatsApp. That is what I think that is what most of us do. Means WhatsApp got better connectivity than Vodafone, Idea, or Airtel, or BSNL. All of us know that. So next, please. So next, just keep on clicking till everything opens up. So these are the things that we need to decrease. All the red things we need to stop. We need to decrease salt, sugars, decrease fried snacks, and decrease stress. Increase stress, exercise, fruits, raw vegetables, regular medicines, and monitor blood sugar, blood pressure, and serum cholesterol. So now there is one small issue regarding this. All the things, including, so for example, I have included medicines also here. Now medicines is a major problem. We did an analysis 2 years back in my outpatient department. Most of the patients who are coming to the cardiology OPD are the number of medicines, number of different types of medicines that a person takes is 5. And we asked them how many times they forget to take the medicines, at least how many times, how many of you forget to take the medicines at least for at least 5 days a month. So the answer was very shocking. 40% of them forget to take their medicines at least for 5 days a month. Just imagine. It happens to all of us. If somebody gives me a medicine for, I develop a cold and I start taking antibiotics, I know antibiotics has to be taken twice a day for 5 days. After 2 weeks, I look at the strip, I realize there are 2 missing. There are 2 left. There is 10 tablets I bought, and remaining 8 tablets are there. Then I realize, oh, I forgot to take 2. So if you have to take for a common cold or some condition for 1 week tablet, we forget that many. If somebody has to eat these medicines lifelong, if somebody is diabetic, that person is going to take the medicines lifelong. And somebody is hypertensive, that person has to eat the medicines lifelong. So is it possible for so how to avoid that? So normally what we do is, if somebody is 75 years or 80 years, we tell the children, okay, please tell your dad or mom to make sure that they take the medicines regularly. So now, is it possible for the son or daughter to stay at home and tell the parents that you should take the medicines every day? 3 times a day, is it possible? Morning may be possible, night may be possible. If you love your parents so much, you may do that. But is it possible to do it during lunchtime? You'll be at your workplace, parents will be at home. It's not possible. So during the most common time that a person above 70 years who misses the medicines is in the afternoon. They forget to take in the afternoon, and sometimes they forget to take in the night. In United States, they found out people who are living alone, the chance of them taking medicines regularly is only 30% of them take medicines regularly because they are staying alone. So these are the issues. But remember, even when somebody is staying alone, they will be having the probability of them having a smartphone with them is very high. And smartphone enabled AI technologies can be used for medication reminders and other things. Next, please. Next slide. Next, yeah. Next, yes. So what do we know what is to be done. We know that once you control all these things, we can drastically reduce the heart attacks. The population does not know the risks. So we need to educate the public. Is it possible to educate only when they are watching movies? No, we need to have innovative technologies whenever they are doing whatever they are doing, whenever they are interacting, whether they are on Instagram, Twitter, or Google or Facebook or whatever it is. We need to have a compulsory health dashboard somewhere on left screen or right screen. This has to come through legislation. I'm trying my level best to get it through the Ministry of Health and Family Welfare. There are some initial small movements are happening. I hope that I may be able to do that in maybe 1 or 2 years. Not easy to monitor by the system, because currently the healthcare delivery system of India is focused on disease management, not on health promotion. That's a major problem. So is it possible for Government of India to move away from disease management to health promotion? No, because with the amount of money, percentage of GDP that we are spending, it is extremely difficult for us to move away from health, that is disease management, to disease prevention. If you see now, we have that Aatmanirbhar Bharat scheme, crores of rupees are being spent on it. It's excellent scheme, but that is targeted primarily, not targeted primarily, 99.99% of the money spent on Aatmanirbhar Bharat is for disease management, not for prevention. And we do not have enough doctors and nurses to monitor all these things. And risk factor modification is behavioral change, which is the most difficult thing to do. Next, please. This is a very important map which shows the per capita healthcare spend. You can see India is way below, near the Nigeria, Indonesia, Malaysia, Kenya, and Ethiopia. And next, please. Next, please. Next slide, please. Yeah, this is the number of hospital beds and the number of doctors and nurses. Number of hospital beds, you can see that's very less. So with this less number of hospital beds, it is very important that every strategy that is delivered through AI, if we are able to reach out to the population and control the risk factors, we will have a drastic effect. Now the problem is, in my hospital, if a person comes with heart attack, ideally, as per textbook, that person has to stay in the hospital for 7 days. But because the number of people who are coming in with heart attack is so high, I told you 10 per day, and the number of beds that we have around 2,000 beds in JIPMA. But in spite of that, we are unable to keep a patient with heart attack for more than 4 days, sometimes even third day. If somebody is relatively stable, we send them home on third day, because unless otherwise we send the person home, how do we push the next person inside? That's a problem. So hospital beds is a huge problem. So unless otherwise we stem the flow of the patients and from the community into the hospitals, it is extremely difficult to manage appropriate. So if you ask me, am I giving appropriate and adequate care? I'm not. I'm definitely not giving appropriate and adequate care, because the number of patients seen by, for example, my outpatient department, on Mondays, Tuesdays, we have more than 400 patients seen by around 10 doctors. You can just imagine the pandemonium that happens. My outpatient department is designed for maximum 100 patients per day, but we see 400 patients instead of 100 patients. So that itself is a huge load. And number of patients who are coming inside and going out is also at a much more rapid speed. So the amount of care that we can give to the patients is also less. So unless we stem the inflow, we will not be able to manage. So if you are able to do that, then we can deliver it better. Then same thing with doctors and nurses. Can we drastically improve the number of doctors and nurses? No. And any person who has a heart attack or a stroke, the biggest problem is they develop again heart attack and stroke. Using technology, using AI to prevent further recurrences for these patients by ensuring that they take their medicines correctly, they check their blood pressures regularly, and they control their risk factors correctly, it will be the biggest advantage of AI in decreasing all these risk factors. It has been proven beyond doubt in Western countries that nurse-based clinics, in which the nurse will talk to the patients over phone or send messages to the patients over the phone after discharges, can drastically decrease the number of complications these patients develop, as well as number of people dying because of complications, and people who are coming back to the hospital can be drastically reduced by that. But is it possible for doctors and nurses, forget doctors, nurses in India, to call all the patients, because the numbers are so huge and our number of patients are so huge and number of hospitals and nurses are so less. So that is where we need to have AI-enabled systems. We can have chatbots, voice bots, all of them talking to patients who get discharged from the hospital. There is a huge potential for that. It's an opportunity that is waiting to be tapped. Next, please. So this is just a simple graph to show that where we stand. We are very bad. This is a 2012 data. Now it has slightly improved. We are reaching something like slightly better than South Africa in 2019. Next, please. What is the solution? So we need to have what is called as pervasive healthcare. So I would call this concept of pervasive healthcare means it is a healthcare to anyone, anytime, anywhere, without locational, monetary, and other restraints, with high quality and precision. This is the need of the hour. You don't need doctors anywhere to deliver healthcare. You don't need nurses anywhere to deliver healthcare. Healthcare in its most basic form can be delivered. Can it be delivered through a smartphone? The answer is yes. It is possible to deliver healthcare. It is possible to diagnose patients. It is possible to treat patients. See, for example, if somebody has got a digital BP apparatus, that person can diagnose hypertension. If that person is able to communicate to a doctor or a nurse through a phone, then we can manage the blood pressure directly through phone. We don't need to for the patient to come to the doctor each time. Means most of the patients whom I manage, my friends, my relatives, so many of them in India as well as abroad, from the time they started COVID, they basic thing is like psychologically they want to meet the doctor, but I tell them no, because of COVID don't come. But now if you ask me, I am much more satisfied. They are also much more satisfied, because most of the management of the hypertension is happening over WhatsApp and over video calls. So only when they have a problem, any worsening of symptoms or anything, they need to come to the hospital. This is only one small part of it, but pervasive healthcare has got much more wider dimensions. I'll come to that. Next, please. So pervasive healthcare needs pervasive technology. The problem is, are we there or is it there? Next, please. So this is a very interesting graph. It shows that mobile penetration in India, as well as many of the countries, third world countries, are actually better than access to sanitation. Okay, we have what is it, Swachh Bharat and all these things happening, so things may be becoming better. But please remember, this is information in 2014, and in 2014 the in India, the access to improved sanitation facilities was less than 1/3 of access to mobile phones. So this is a very heartening thing. That means there are more and more people with mobile phone. Many people feel that you need a smartphone to deliver AI-based technologies. I don't think so, because even simple mobile-based messaging to people and replying of messages by the people using a normal phone, not a smartphone, back to a number can be integrated with AI-enabled systems for managing patients. This has been tried out in some experiments in Vietnam, China, and in United States. Without a smartphone also they have tried, and it actually works. Only thing that instead of a chatbot or a something that is sitting on the patient's mobile phone, it gets a little bit more cumbersome. It can be done. Next, please. So what are mobile health functionalities that have shown clinical evidence for patient care? Mobile health functionalities has been shown that it can support clinical diagnosis and decision making. It can improve clinical outcomes from established treatment pathways through behavior change and enhancement of patient adherence and compliance with treatment, act as standalone digital therapeutics primarily to deliver disease-related education. This is very important. But with the advent of AI, much more can be done. These are all the proven things, but with AI, much more things can be done. Next, please. So if you look at this, it's like a web, very confusing slide, but just see this. Just see any of the things that is written in this thing. Please remember, all the things are interconnected actually, because if you see the one in the center, it's the chronic disorders are high cholesterol, high blood pressure, diabetes, and other things. All the risk factors are connected to each other. So we don't need AI to know that all of them are connected, but we need AI to ensure that the behavior modification happens in a comprehensive manner. Just take the box in the first box in the middle, that is obesity. Obesity means excess body weight. This excess body weight, if you do not walk enough, that is extent of physical inactivity, activity is less, you will develop obesity. If you eating unhealthy diet, you have obesity. You eat too much of, you drink too much of Coke and eat too many sweets and sugars, and stress increases obesity. And smoking also increases obesity. So I'm just telling an example of that. That is what I'm saying. All these things are interlinked. If you want to decrease the weight of a person, we cannot tell the person, go decrease the weight. That is what all the doctors will tell the patient, and that is what the patient will never do. We have to tell the patient how exactly to decrease the weight. We have to tell the person that means your body is one unit, and if your weight will not decrease unless otherwise you burn more calories and you eat less calories. That is one simple thing. But how do you do that? Thus, any doctor, even in a hospital like Apollo, where you end up spending 15 or 20 minutes with a patient, I think they spend that much time. My colleagues may be spending that much, unlike in JIPMA. Even there, I don't think the doctor will have that much time to talk to you, to explain to you all that. So this is where AI-enabled physician assistants come in. What a doctor should be doing, what a nurse should be doing. For example, my colleagues in the United States, the minimum amount of time a cardiologist spends supposed to spend with one patient in outpatient consultation is 30 minutes. And on an average, they spend 30 minutes and they spend another 15 minutes for typing in the information, because if you do not type the whole thing into the digital health record, they do not get paid for that patient, because insurance is very strict in US. In India, that doesn't happen. So now, unless otherwise, you have systems which can take over many of the jobs a nurse or a physician assistant or a dietitian does in the West. It is possible to do that using digital assistants, using AI, based on the patient's own inputs. We have the capability to do that. And once you bring in that systems in India, the efficacy can be huge. Next, please. So this is just a strategies to prevent cardiovascular disease. You have biological, behavioral, environmental, social, and healthcare. These are the major determinants, of which what biological we cannot touch with AI for the time being, but behavioral, huge potential for behavioral modification using AI, using smartphones and other technologies. And that is because already, see, one behavior is already there. That is, people are hooked onto mobile phones, that is smartphones. Use that behavior, that smartphone behavior itself will increase obesity. So use that behavior for positive health change, not negative health change. Environmental, difficult. Social context, yes, and healthcare delivery. So behavioral, social context, and healthcare can be done, and all these things can be all the interventions to decrease tobacco use, decrease alcohol, nutrition issues, obesity issues, physical activity, all these things can be monitored. At least physical activity can be monitored using mobile phones. There are a lot of AI enabled, for example, if I go to a weighing machine, if I have a weighing machine at home, then I can measure my weight. And if I measure the weight, I need to measure my height. Then somebody has to know the concept of BMI. Then only the person can decide, oh, I am overweight or I am obese. So many people do not realize, even my own colleagues, doctors who come to me for blood pressure or diabetes, I tell them, I think your body weight is, no, 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 I am perfectly all right. Then I will check their weight, then I check their height. Then I tell them, boss, your BMI is 29 and normal BMI is less than 25. Oh, I didn't realize I am so overweight. I did not know that. So there have been approaches from many researchers in which a selfie photograph itself can be used to identify whether you are overweight or obese. This is also coming up in a big way. So there are a lot of developments in AI field which can, if integrated together, can lead to approaches to change behavior. Ultimately, unless we end up in behavioral change, all these things doesn't work. Next, please. Yeah. Next, please. This is just a continuation of the previous one. Yeah, this is also a continuation of the previous one. Just, yeah. So now, do we have pervasive data and pervasive, are people connected? So the world population is 7.8 billion. Internet users is more than half of that people are using, the world are 4.5 billion use internet. Google users, this is from different places I got this information, not only from Google search. I think it's approximately 4 billion. Smartphone users are actually 3 billion. That is because many more people may be accessing Google through non-smartphone devices. Facebook is 2.5 billion and WhatsApp is around 2 to 2.5 billion. So we know that billions of people across the world are now connected, and that connection to each other as well as to potential government. I think during this COVID, we realized that how government can push things to us, other than through phone. When a phone ringtones and other things, we get a lot of messages to us, and then I don't think they utilize it to the maximum extent, maybe because of digital loss. Next, please. And India, what is the situation? We have a population of 1.3 billion, and we have Aadhaar cards for 1.2 billion. That's a huge thing, huge plus point. What do we have in the Aadhaar? We have the biometrics of fingerprint and iris scans. So what is the importance of that? I'll come to that. We have around 0.8 billion mobile phone users, and smartphone users constitute at least 70% of that. That is around 0.5 billion. What is the use of fingerprint and iris scans? As of now, there are no direct evidence saying that fingerprints and iris scans has got any relationship with cardiovascular disease. But if somebody allows me to access fingerprint, and if somebody from you, any one of you, is willing to give your artificial intelligence expertise, maybe Google, maybe Microsoft, maybe Amazon, maybe any of those big AI giants are willing to help, and Government of India permits, is it possible? This is just a wild thought, I'm just telling, because how AI can pick up things from complex situations is very, because many times you don't even know how it picks up. But one of the hypotheses, one mad idea I'm just proposing is, can we see the fingerprint of 1.2 billion people and find out among this 1.2 billion people, how many of them develop heart attack, and see whether there is any particular pattern of iris scan or fingerprint that can predict either that these people have heart attacks. I'm just telling a mad idea. It may be too childish, or it may be too mad an idea, but we need to think of some mad ideas to come up with solutions. And now the National Digital Health Mission has been launched by Government of India in 2019, and it was supposed to roll off in 2020. Because of COVID, it didn't take off. And now it's coming in a big way, but unlike Aadhaar, I do not think that it will reach this level of penetration in such a means. Aadhaar took around 7 years for it to reach this particular level of almost 95% of the Indians are now covered under Aadhaar. So same way of 95% penetration, I don't think we will be able to do that for National Digital Health Mission in the next 5 or 6 years. My estimate is more than 10 years, because that is much more stringent and much more complex to do that. I have been trying to register myself as a doctor in National Digital Health Mission for the past 2 months, because Pondicherry is one of the first union territories in India that was supposed to have all the doctors and all the patients registered under National Health Mission. I have talked to the helpline 3-4 times, nothing has worked. I don't know what is happening. So this is there is a huge potential for AI delivery through India, and with this Aadhaar and National Digital Health Mission coming into the picture, there is a lot of potential. Next, please. So what are the AI-assisted population-based approaches in cardiovascular prevention that is already available? So measurement of blood pressure is possible. So currently you need a blood pressure device and a cuff to tie on a person's hand to person's hand to measure the blood pressure. And that has got a lot of inaccuracies. All of us know the SpO2 probe that because of COVID, it became so widely used. You put on small probe on the fingertip, and that has got a small red laser light, and that measures the saturation of the person. And in some particular models, it also shows the one waveform of the blood flow. So now, can it measure the blood pressure? Okay, there are a lot of research hypothesis has been there. It has been going on, but till AI came into the picture, it was very difficult to analyze that and come up. But now a lot of studies and a lot of almost ready to use in the public areas have come, in which a fingertip plethysmograph may be able is a huge potential to measure the blood pressure. The second one is called a phase pulse plethysmography. One company called Bina AI in Israel and another 2 Chinese companies have brought in a app in which you use the mobile phone, you shoot your own video, and it will tell you what is your oxygen saturation, what is your pulse rate, what is your blood pressure, all these things from the alterations in the color of your face with each heartbeat that is not even touching the face. Just take a selfie video and upload it. It will tell you what is your blood pressure. I have also tried it out in Jipma, and we had issues regarding the lighting, and we had issues regarding the skin color and other things. So I think they have gone back to the drawing board to perfect that. As long as the person is not too dark and the lighting is reasonably well, this is working very good. I would say around 90% accuracy, but it should not be used for the time being. But there is a huge potential. If you do not need a BP apparatus, if you can use a blood pressure, ordinary smartphone to detect blood pressure, that I would say that will be the quantum jump in the detection of blood pressure across the world. Then non-invasive detection of dietary sodium. So the problem is, how do I know that I am eating more excess salt? Because in India, we tell people that please do not eat, people who are having hypertension, we tell them, please do not eat fried items, namkeen and samosas and street food and all these things contains a lot of salt, and pickles contain pickles, and dry meat and dry fish contains a lot of salt. So all these things are easy to say, but very difficult to implement. But how do you know that your wife or your cook at home is putting too much of salt? Only based on our taste buds. That becomes problematic. That's not correct. In Japan and China, many studies have come in which they use, you can attach a device to your toilet, and from the urine that you're passing, it actually measures the amount of dietary sodium. And if your urine contains too much of dietary sodium, it gives an alarm saying that your dietary sodium is way higher than normal. So these are the ways in which technology can help in analyzing such things and then giving solutions. And non-invasive imaging has come up in a big way. Google and had published this study based on retinal scans from a United Kingdom-based database. So it has been validated in Shankar Nethralaya and Aravind Hospital in India, in which the retinal scans can initially detect accurately diabetic retinopathy, which is a highly specialized field in which only some particular type of ophthalmologist can say this person has diabetic retinopathy, this person does not have. And based on the same data set, they have been able to identify that data sets using the machine learning algorithms have been able to identify the whether the person is hypertensive or not, approximate age of the patient, and whether the person is having high blood sugar, high blood cholesterol, all these parameters are being picked up from that thing. So retinal scan actually is part of many security systems. So if you suppose, let us say that we say that for entering any bus or any train or any government building, you need to have a retinal scan. Then it becomes easy. You do the retinal scan and then the person has got an Aadhaar card, the person has got a national digital health card, and the person will get a report in his mobile phone saying that as per your retinal scan done on 27 February, you have been diagnosed to be having hypertension, high cholesterol and diabetes. You please go to the nearest doctor, or you call this helpline number and then they will guide you what to do. And that is how we need to have pervasive healthcare in which we can integrate all the systems. Then smartphone based detection, monitoring and management of risk factors. I told you about smartphone based hypertension, blood pressure detection, smartphone based obesity detection, and of course smartphone based number of steps, because a person is not walking 10,000 steps, so smartphone can give alarm, please you are not walking 10,000 steps, you should walk 10,000 steps to prevent heart attack. Then of course if the smartphone can take a photograph and ideal would have been the Google lens, Google Glass. Google Glass was a beautiful concept, but I do not know why Google withdrew it. Manish is there in the audience. We can talk about it later. Means Google Glass, if you look down and at the end of the day, it will tell you, oh, you didn't eat 5 servings of fruits and vegetables today, and that actually increases risk of heart attack, because you can't expect somebody to take their mobile phone and shoot all the things that you eat. Okay, nowadays the kids do that. Whatever they eat, they keep shooting and putting it onto Facebook, but still, this would be much better if you have a Google Glass. Then smartphone-based early detection of heart attack. Actually, this is one of the projects that I'm working with some of my colleagues in IIT, in which if you use a mobile phone, the basic problem is, I'll just tell an example. In my hospital, where we have 5 cardiologists, including myself, and we have 12 residents, that is students who are doing their cardiology training. If the heart attack is detected in the emergency department, from the time from taking the ECG to diagnosis of the heart attack is less than 5 minutes. But if a patient that is admitted in any other part of the hospital, in JIPMA, for example, a patient is admitted in gynecology department, patient is admitted in surgery department, patient admitted in any other department other than medicine or cardiology, the average time to detect a heart attack after taking ECG is around 45 minutes to 1 hour, because first somebody will take the ECG, the doctor will look at it. That particular doctor who is looking at it, he does not have the expertise. Please remember, all doctors do not have the expertise to diagnose heart attack. Usually heart attack is diagnosed by a medicine, that is a general physician or an emergency department physician or a cardiologist. Even neurologists as well as gynecologists, ophthalmologists, they cannot, most of them cannot detect a heart attack. That's a problem. So in my own hospital, if this is the situation, and there is a 45 minutes delay from the time, so from the time somebody has a heart attack, means we consider it as a countdown. Every second counts. A person who comes with heart attack to the hospital, we need to take the ECG within first 5 minutes of arrival. A person with chest pain, we need to take a ECG within 5 minutes of arrival. This is international guidelines. And after taking the ECG, the diagnosis whether the person is having a heart attack or not has to be done within next 5 minutes. And the thrombolysis, that is giving an injection to open the clotted blood vessel, that has been done from the time the patient arrives within 15 minutes. So this is the guidelines internationally, but it is not possible. So that is why with some of my friends in IIT, we had started this using a mobile phone. Any doctor or a nurse or even a patient can take a photograph of the ECG, and this AI-enabled app in the smartphone will detect whether the person is having a heart attack or not, and then that will help in identifying that. Just go back once. Can you just go back to one slide? Yeah. And finally, that is the early detection of heart attack, which can be very important utility of AI. And of course, as I told you, AI-enabled behavioral modification also is important. Next, please. Next, please. Yeah. So these are the targets for AI-based disruptive methods for heart disease detection and management. See, these are the problems that happens from the time a patient is in the community to the patient dies in a supportive care home. The first one is, if you modify the risk factor, this is where the first step is the maximum benefit. If you see, the risk of developing heart attack can be reduced by 80%. You see all the percentages in the slide. The largest percentage is in the first. That is why I keep stressing that we should have AI-based strategies for primary prevention of cardiovascular disease, 80%. So that is very important. If you modify risk factors, that is where the earlier you catch, the better it becomes, and less risk to the person. Then the problem is, this is second one, okay, we'll leave it. And third one, 20 to 40% of heart attacks occur in undiagnosed CVD patients. Please understand this. This is what I was telling you just now. And 20% of the people, hypertension is not diagnosed. 30% of the people, this is all US data. In India, it will be much, much, much higher, maybe double or more. Undiagnosed hyperlipidemia, that means high cholesterol. Now, only 43 to 67% patients is they don't take the medicines that they are supposed to take at the end of 1 year after a heart attack. I'm just telling an example. This is US data. In India, it will be much higher. So over half of atrial fibrillation patients are not on therapeutic anticoagulants. That is, atrial fibrillation is a very high risk condition which can increase risk of stroke. Then half of them are not on correct dose of medicines, and then advanced treatments are not used, and supportive care is not used. Next, please. So all these things we can have AI enabled this thing. So what are the potential for AI in India for early detection CVD? Increasing penetration of smartphone in the population, 100% smartphone availability with healthcare workers. We did some analysis in different states. In Pondicherry, we have checked. In Tamil Nadu, we have checked. Delhi, we have checked. And this is a survey. Pondicherry, Tamil Nadu, Delhi, Kerala, Karnataka, and Bengal. These 6 states, we had done a survey in 2019, and we found that all the healthcare providers, that is, we did it, analysis for doctors and nurses, everybody had smartphone. We did not find, of course, there are some 1 or 2 oddballs which felt that they did not want to be monitored by Google and government and all that. Then wide availability of high-speed internet, manufacturing and software expertise, potential for standalone kiosks for early detection and warning, even for person without smartphones. In the rural India, we may not have too many people with smartphones. If we can integrate that Google's retinal scan based detection in kiosks as well as all government offices and all primary health centers, you don't need a doctor to diagnose all these things. The AI will diagnose all these conditions. That will be a great giant leap. And of course, Aadhaar is a huge database, which of course a lot of issues regarding using the data, and National Digital Health Mission has got huge potential. So currently, if somebody is trying to find out how many people have hypertension in India, how many people have heart attack in India, impossible. Everything is estimates based on some data from some 10, 15 hospitals in India. Once we have National Digital Health Mission, in which every patient that is going to any hospital, public or private, they get registered in a department, then all diagnosis is entered, all discharges and deaths are also entered. At least these 4 parameters, if you get, it's a huge leap in the data that we have for making early decisions and therapeutic approaches. Next, please. Next. So these are the take-home messages. Cardiovascular disease is the most common cause of death for the next 50 years. Coronary disease, stroke, and kill the most. Primary prevention to control risk factors of atherosclerosis is the most promising, and we need disruptive technologies to drive it. AI-enabled healthcare monitoring and management via mobile health can provide the pervasive healthcare, bridging the healthcare divide. And large quantum of software as well as hardware professionals are available in India, which can take this forward with the help of close association between these technocrats and healthcare providers. I think that is the need of the hour, in which we need to talk to each other more, interact each other more, and plan projects together. Then only we can bridge the divides and then get the solutions. Thank you. Next.
Thank you, Doctor, for this insightful presentation. And then, two questions, I would like to ask. you talk about AI and the gadgets and all, wearables are available in the market. So, a lot of wearable talk about giving you stress level, talk about, giving you, what do you call it, pulse rate, night, sleep monitoring and all this thing. How reliable they are in terms of, accuracy?
See, ultimately, there are two things. I think there are three parts to your question. One question is sleep monitoring. Second part is stress measurement, and third is pulse rate and steps and other things. Among all these things, if you ask me, the most reliable is number of steps.
Okay.
Number of steps is reasonably, I would say around 90% accuracy, because I use this Google Fit and Samsung Health in my mobile phone, and I also have a wearable which is made in China. And most of the time, there is a variation between these three things is only something like around less than 10%. But when you come to sleep data, so different manufacturers use different algorithms. But these also I find it to be reasonably accurate, because this is from my personal experience. So sleep also is because what happens is, if you are going to measure the sleep data from a mobile phone, the basic premise that that particular mobile phone, I think Samsung uses an algorithm in which the last if the mobile is not moving, then it is considering the person is sleeping. So normally they have a cutoff period of 1 hour. For 1 hour, the mobile is not moving. More than 1 hour, the mobile is not moving. Only it considers it as sleep. For example, if I sleep from 8 o'clock to 9 o'clock, wake up at 9 o'clock and work from 9 o'clock to 11 o'clock and then sleep at 11 o'clock, it doesn't count the 8 o'clock to 9 o'clock. No movement as sleep. This is my own personal observation. But coming to the stress. So now stress is usually measured. If you ask me how we measure stress in as a cardiologist. So if I have to measure stress, it is a slightly complex process. So what we do is we have to take the ECG of a patient, and using the ECG of the patient, we measure what is called that, because what I'm saying is, if somebody is having stress, that person's sympathetic activity is very high. So what happens is, when you see in ECG, you have this vertical spikes. Each spike is one heartbeat. The distance between two heartbeats, it keeps varying with respiration as well as stress. So there are algorithms that are used which are reasonably accurate, around 95 to 99% accurate, to show that if these variations are very severe, that means this is called heart rate variations. That means the person is having increased stress. The variations are very minimal, then the person is not having high stress. Ideally, the source of the data for measuring stress should be a ECG. So if the smartphone or wearable has a ECG detection, for example, Apple Watch has got ECG detection, but ECG detection will happen only if you touch the touch the watch or that particular device with your other finger. Normally, when you're wearing the watch, it doesn't measure the ECG. So how does Apple or any other people calculate the stress? They calculated based on the pulse plethysmography. That is what I was telling you. This pulse plethysmography is the technology that is used to find out the pulse rate. So it sends this infrared lights, and based on the number of heartbeats that is coming, the color of the skin underneath the watch or the wearable changes. And between two beats, there is a gap, and that gap is used to measure the heart rate variability. So it may not be as accurate as a ECG based heart rate variability, but it has been found that it's almost 75% accurate. For example, ECG base will have an accuracy of around 90%, and this has got an accuracy of around 75%. But still, very huge variations of stress are easily detected by even this condition. The only problem is, unless otherwise they validate it, because Apple has validated it. Because Apple has validated two things. One is stress, and second is atrial fibrillation detection, and both of them are atrial fibrillation detection is FDA approved, whereas stress is not as FDA approved. Apple Watch.
Thanks, sir. Thanks, sir. So, thanks a lot for this session, and then now we'll move to the next session.
Thank you.
Thanks, sir. I will. So we have Dr. Let me check. Yeah. So Dr. Vidur Mahajan. Good afternoon, sir.
Hi, good afternoon, Amit. How are you?
Good, sir. Sorry, the session is a little bit late, but anyways, it was so knowledgeable that I thought it should continue. It's
No,
talking
no,
the
it's
whole
perfect.
time.
My time was 2:15, so this is absolutely, and listening to Dr. Santosh is,
Yeah.
always a pleasure. So
It's more about our health. So I thought,
correct.
it should continue, and then we'll have more questions. Um, we have another 5 minutes. Dr. Santosh, one last question. When you talk about the Indian perceptive and the knowledgeable level, I personally believe, people in India, when you talk to them about the high BP and when you talk about taking medicine, they're very reluctant in taking medicine. They believe, once you start the medicine, it will continue for the lifelong, and they avoid going to especially the cardiologist.
Yes.
They believe, the cardiologist will ask you for for angiography, or ask something to do it. So how this is something, a myth which is there in the Indian market, or I don't know, it's a myth, or it's actually what they believe.
No, it's not a myth. What you're telling is absolutely right. And there is no doubt that that's a major problem. See, basic problem is like this. This is basically the problem in India. On one end, people are worried about going to a cardiologist. On the other end, cardiologists are worried that anybody who is having any pain below the neck and above the abdomen comes to them directly, which actually is not correct. Anybody who is having hypertension should not be going to a cardiologist. Means many cardiologists in private might try to bash me up, saying that you are
Yeah.
telling people decreasing our profit margins and everything. But it's not correct. Actually, cardiologists should be looking at treating patients with actual heart disease. This actually hypertension, because if you go to the system in UK, the if somebody is having hypertension, diabetes, they're always managed by a primary care physician. Only once you get into some complications of this. So the problem is in India, the primary care physicians, even though they are trained for doing all that, people don't we don't have that hierarchical system. For example, in my friend who is a pediatric cardiologist in uh, in UK, when he developed a hypertension, he cannot meet a cardiologist. He has to go to his primary care physician. Please understand. In India, it's not like that. You have a headache, you go and meet the neurologist. You have a just high BP, you first meet the cardiologist, which is actually waste of resources. So that's a problem in India. And as you said, most people have this wrong concept that once you have high blood pressure, both diabetics and hypertensives, once you are high blood pressure or once you're having high blood sugar, the treatment is usually lifelong, 90% of the time, unless otherwise somebody's. The basic problem is like this. The behavioral modification that is needed to control all these things is so stringent. Even you and me will not be able to do it, because if we know that we have to walk every day morning, but how many of us walk every day morning? And once you get hooked onto tobacco, it's very difficult to stop that. And once you get hooked onto alcohol, so same thing. People are worried that if they take BP medicines, their kidney will get damaged. And if they take, once they get hooked onto this, they are going to take it for the rest of their lifetime. But the problem is, this is again problem in education. They do not know that if you do not bring down the blood pressure below 140/90, how are their risks coming down? Because among all the conditions, if you ask me, one single condition where people should control is hypertension. In US itself, I told you, less than 1/3 of the hypertension in US, the BP is controlled. In Indian, small studies, including from JIPMA, we have less than 25% of the people are BP's blood pressure is controlled in the outpatient setting. That's a problem. So education is very important. So how to get this education? Again, use AI. Means push it to Instagram, push it into Twitter, push it into, so all these things should not be. See, for example, now we have bots sitting and managing elections, right? People want to win elections, they use bots. People want to market their products, there are bots. But there is nobody sitting and making bots to manage the blood pressure and detect blood pressure and educate people. Isn't it more important? Correct? Hello, can you hear me? I can't hear you.
So I said it's a good business. It's a big business opportunity for AI companies to get into this.
Only problem is use the word business. How to monetize all these things? That is where the difficult part comes. Means that is why I told you the pervasive healthcare, how to deliver. So basically, it's like this: if Government of India is planning to spend 1,000 crore to enhance the facilities in primary health center, And if they give me the money, I will tell them, no, you please don't give the money to the primary health center because of the 1,000 crore on the ground. What will be spent will be 500 crore. Remaining 500 crore will be going somewhere else. Instead of that, you set up a system in which anybody, for example, where you stay, Amit, you're in
Delhi.
You're in Delhi. Have you ever seen the primary health center which you are supposed to be connected to?
Government health sector you're talking about.
Primary health centers are only in government. There are no.
Yeah. I prefer to go to Delhi government dispensary as compared.
I'm not talking about Delhi government dispensary because according to Government of India, every 1 lakh population is covered under one primary health center. I have not seen mine. I don't think any one of us would have seen the primary health center because in India the system is not like that. But what I'm saying is, because we have the financial ability and ability to go and meet a doctor, we go and meet the doctor. And the system in the primary health center is not robust enough. So what I'm saying is, we need to have virtual primary health centers available for any Indian. For example, if I develop a headache, I should not be going and meeting one doctor. I should be able to go to this virtual primary health center anywhere in the India and then have a consultation with a virtual assistant, and the virtual assistant will decide whether I should go to the next level. This is what is happening in UK. This is what is happening in many counties of US. So we need to bring it in a big way in India. Means, for example, I think AAP had brought in a lot of Mohalla clinics, correct?
Yeah.
It actually has enhanced the quality of healthcare at the grassroots levels. But is it possible to do that across India? No, not possible. Means that around 1 in 3, around 30% of the primary health centers in India have no doctor. It's impossible. Now they are saying, putting one gun on the medical student's head and said, boss, you don't go to the primary health center and work, we will not give you a degree. So same problem.
So we'll hope AI will change the way. Then now, thanks, sir.
Thank you.
Thanks for your views. Now we'll go to Mr. Vidun Mahajan.
Yeah.
Sorry, sir, for keeping you wait.
No problem whatsoever.
So sir, Mr. Vidun Mahajan is head of research and development, aiding research, Sakartli.ai. Can you a little bit explain more about this?
Sure. So I will be doing that during my talk as well. But essentially, we are a chain of imaging centers in Delhi called Mahajan Imaging.
Okay.
And Caring is the R&D division of Mahajan Imaging. It's an acronym for and genomics. And we work with more than 35 global R&D groups on AI. And basically, we have our platform, which is called Carpal software platform, which is used by all of these AI developers and users to access, test, and then deploy AI solutions, which is why, I thought it will be relevant for me to talk about how to actually bring these solutions into the clinical realm.
Please, sir, please start. I would like you to start here.
I'll just share my screen quickly.
Yeah.
Great. Can you see my screen?
Yeah. We're able to see your screen. So please start.
Perfect. So thank you so much, Team CII, for inviting me. And, it's always a pleasure to share some of the work that we've been doing. I know we have about only 15 minutes, so I'll try to go through it very fast. But think of this more as, a set of thoughts or a set of concepts that you can, keep in your mind as you are either thinking about building or using AI, especially when it comes to clinical grade AI. So, this is, I think all of us agree that there is no doubt that AI is the future of medicine. It's a huge market. It's almost, supposed to be $118 billion healthcare AI by 2027. In 2019, there was about $4 billion invested in healthcare AI. I'm assuming this number has increased significantly in the last year, given the COVID situation. And then, there is also no denying that healthcare AI can reduce cost. And, it is said that there is about $200 billion of systemic waste in our system that can be addressed using healthcare AI. So there's a lot of potential for AI, and this entire conference is essentially about that. But still, if you go to any hospital around the world and you ask them, what AI are you using in the clinical realm? typically you will not get a very enthusiastic answer. And we believe that there are 3 hurdles that are to be crossed to deploy AI effectively, and these are the 3 reasons why AI is not getting into routine clinical deployment the way one would assume, right? Every hospital, everywhere in the world, why are they not using AI? So the first thing is that there are hundreds, if not thousands, of AI developers around the world. This is just a snapshot of some of the medical imaging radiology AI companies, but there are, thousands of researchers across the world. Every engineering college on the planet will have a group of either professors or students working on healthcare AI. So there are thousands of these solutions that are out there, and hospitals have a very hard time accessing these solutions, right? How do they even get in touch with these 50 companies that are mentioned on this particular slide? So that's a big reason and a hurdle why AI is not getting into hospitals. The second reason is all to do with trust, right? Here we are trying to build AI solutions that tell a doctor what to do, or that tell a patient what to do, or that make a diagnosis on behalf of the doctor. So how do you even know that the AI works? How can you trust it? How do you know there is no bias? We'll talk a little bit more about these things, but long story short, doctors do not have an effective way of interviewing an AI algorithm and trying to know how good or bad the AI is in particular specific domains. And let's say you've tested the AI also. The last and maybe most underappreciated aspect is the health IT integration, which I'm sure must have been discussed in the earlier sessions today. But apparently, just the health IT integration market is going to become close to $6 billion in 2025. This is not development of software. This is not setting up of hospitals. This is just connecting various software, right? Just that market is increasing. So just the idea behind this chart is just to show you how complex and how big just integrating one of these solutions into an existing fragmented analytics market with inherent trust issues and bias issues with complicated integration deployment systems is leading to a lack of AI adoption. So how do we address these things? How do we finally get the AI into clinical practice? It is not very easy. The first thing we suggest you think of are implications of AI, right? What happens if the AI goes wrong? You're screening for cancer, you miss a cancer. What's the problem? Or you overpick or you underpick. So something clinicians have to think about, something IT professionals have to think about. What are the implications of AI? There are some technical issues related to deployment of AI. There are issues of generalizability and bias, right? You build an AI on American data, you run it on Indian data, and it just cannot pick Indian diseases because it's not been trained on Indian people, or or the body structure is different. So there's a lot of different aspects to this whole generalizability and bias question, and a lot of research groups across the world are trying to address this in various forms and formats, but very, very, very important technical issue to be addressed. Then there are ethical issues. Who owns the data based on which these AI solutions are created? Who owns the algorithm? Very open question right now. If it's de-identified, is that okay? If it's open source, is that okay? So again, a lot of groups around the world working on these as well. I myself am privileged to be part of a group formulated by the ICMR to figure these things out, but not easy questions to answer. And the last and maybe the most difficult one is who takes the blame for the AI going wrong. The verdict right now is that it will have to be the clinician, it will have to be the doctor, the person who's signing off on the AI output. But maybe this evolves. So these are some of the reasons why trust is a problem and needs to be built, and the only way it can be done is by thinking through these issues. And the only way I believe this entire problem can be solved is by having an operating platform, something, some software, some solution that can connect healthcare providers, analytics providers, and the intermediary layer of health technology providers, and thereby create a single ecosystem where hospitals can access whatever AI they want, they can test it, EMR vendors have a very easy time taking analytics from here, put and a lot of these things. And that is essentially what we are building at Caring. We call our platform Carpal, the Caring Analytics platform. And we're thinking of it as a decentralized, uniform technology platform. Why decentralized? Because every hospital would like to have their own server. We are in no way trying to force hospitals or coerce hospitals to part with their data or to move their data from point A to point B, anything like that. No, we are setting up the entire thing as a decentralized architecture so that hospitals don't need to send any data out. And this is essentially a diagrammatic representation to show that we are trying to link these three ecosystems in one play. And we are built on 4 platform pillars. Like any platform, we offer development support, market access, enable user trust, and then get into deployment. So I'll move quickly to the deployment piece that we've been talking about. And yeah, this is just an example of our software. You can automatically run validation studies. This is just an example for chest X-rays. It'll just come. So you all sorts of sensitivities, specificities, different types of statistical metrics are measured automatically. Clinicians can play around with various types of tools and essentially create automated reports on the performance of specific AI algorithms. So again, the idea is to bridge that trust gap, because unless you bridge that gap, these solutions are not going to come into day-to-day clinical practice. And you need to think about deployment for each of these AI solutions in a different way. And this gets a little technical, but I'll try to simplify it. There are essentially 3 types of AI algorithms that are doing the rounds today. The first is called classification algorithms, where an AI says, okay, you give me an image, I will tell you whether that image has something or not, right? Or you give me a medicine, I will tell you whether you have to take it or not, or or the different kind of solutions. But the essential idea is that they will classify a particular patient into different buckets, right? So that is what is called a classification algorithm. Case in point is, let's say, diagnosing tuberculosis on a chest X-ray, right? Where you give an algorithm a chest X-ray and it will give you back a diagnosis of whether the X-ray has tuberculosis or not. Moving on from classification, we come to second type of algorithms, which are detection and segmentation algorithms. So these are basically algorithms where on a particular data set or on a particular image, the AI will perform a task that a human performs of making a box or identifying certain things, or like automatically extracting some features. So like that. So the AI is not necessarily making a diagnosis in this particular thing, but it is identifying specific regions on specific images that typically human beings do. So we have classification, we have detection and segmentation, and the last and most enigmatic application of AI, in my opinion, is super resolution, where you take a bad kind of data set or a bad image. You take a MRI scan that is done in 3 minutes as opposed to 15 minutes, and you apply these deep learning based systems, these AI systems, on those images, and you out pops an image that is as good as a much more advanced acquisition. So thinking monetarily, maybe we can achieve an image that looks like a 10 crore rupee MRI machine from an MRI machine that costs 5 crore rupees. So that in itself opens up plethora of opportunities in terms of optimally utilizing equipments, and especially from India's perspective, where we really want to run our equipments as fast and as efficiently as we can. But the point I'm trying to make is that for each of these different algorithms, you need to have different kinds of deployment systems because they are all performing different tasks. So you have to have IT systems in place that are different for each of these AI algorithms. So I'll give you an example. This is work with our friends over at Credible Health in Bangalore, where we integrated their software into our software, and we give the user the ability to change the AI results. We give the user the ability to change the text that the AI gives. We give the user the ability to accept and reject results. So this is an example of a detection algorithm where the algorithm has detected that there is a nodule in this CT scan. So Mr. or Miss Radiologist or doctor, feel free to modify it, feel free to add your own input so that we can go ahead. This is work we did with Q.ai, where literally all x-rays at one of our imaging centers were read by AI, and normal reports were automatically populated. So normal reports were automatically inserted, and if there was an abnormality that the AI detected, then the radiologist would report the scan. Even in this case, the radiologist would still approve the scan after looking at the image, but the problem became that there's an interesting behavioral aspect to it, where we had tweaked the AI to be absolutely correct whenever it gave a normal report. But when it said abnormality detected, there was always a probability that the AI may go wrong, that it might label a normal as an abnormal. So what started happening was that the AI was always correct in the normal instances, but many times wrong in the abnormal instances. So because the AI was always correct on the normal side of things, if a radiologist would see an image that is normal, but an abnormality was detected on it using AI, they would nudge the person at their left or right and say, hey, I think this is normal. Do you think this is normal? Because AI thinks this is abnormal. So that was an interesting behavioral aspect, that we addressed in a couple of ways, but very important to actually do the deployment and then see what comes of it. These are, just on closing examples of the super resolution aspect. So if you see the image on the left is a noisy image, a noisy CT scan that has been acquired using a very low dose X-ray, and this same image is reconstructed on the right hand side without all the artifacts using an algorithm by a company called Pixel Shine from the US. So it's very much real. This is FDA approved. People are using it all over the world. And to close, this is some work we did with our friends at Subtle Medical in California, where again you take a bad MRI image and try to make a good MRI image out of it. And again, these are results are almost staggering to radiologists who see these things for the first time. So in summary, clinical deployment of AI always has to follow accessing, validating, and integrating the AI into IT systems, right? You cannot directly jump to clinical deployment without actually testing it, without knowing whether it works or not, because you're bound to fail. Each AI algorithm is different. Always think about the best integration methodology based on the specific use case that you're thinking. There cannot be one size fits all because you're trying to perform different aspects of the specific value chain and affect those different points. So you have to integrate everything separately. A deep integration into IT systems is preferred, but should not always stop you from experimenting. Like you can very easily start building an opinion about some of these things. And pre-deployment clinical validation is key. Think of it as an interview for an algorithm. So with that, I thank you for your attention, and if there's any questions, I'd love to answer.
Thanks, Dr. Mahajan, for your presentation. Any question from the panelists? Or will
I'll ask a question.
Yeah,
so Dr. Mahajan, how important is explainability in some of this? Do you want the doctor? I mean, do you want the AI to be able to explain to the doctor why it came up with a certain prediction?
Yeah. So Manishji, we recently wrote a paper on clinical explainability failures. right? Where there's a mismatch between the reason an algorithm came up with an answer and the reason a human comes up with an answer, even when the answer is the same. So short answer is that at least during the initial periods of deployment, right, explainability is absolutely key, because if nothing, it helps the user provide relevant feedback to the developer, right? That, hey, your algorithm was correct, but in certain cases I've noticed that the explanation is actually outside of the region of actual interest, and there's a spurious correlation that pops up or something like that. So I think in the initial days, maybe first few years, explainability would be key. But as they start coming into mainstream, people may not be that much drawn towards getting into the why, because they'll simply trust it by default. Like I think case in point is these hematology auto analyzers, right? So in path labs, you put in blood and you get out your RBC count, your neutrophil count, and all of that. But when sorry, yeah, but in the early days, people would look at all the graphs and the charts and try to see, is the is the box actually giving out the right number or not? They would do a second review on a slide and all that. But now, if you think of it, I guess Dr. Lal Path Labs maybe does, God knows, 10,000 a day or something like that. And I'm certain, they trust their quality metrics, they trust their parameters, and figure out the 1% that actually need to be dive deep into.
Another quick question. I mean, how do you resolve this potential trade-off between false positives and false negatives, right? Because, I mean, you don't want to miss a serious condition. At the same time, if the algorithm is giving you too many false positives, I mean, there's a fatigue, right, that happens.
Oh, absolutely, sir. In fact, we've written a paper on that as well. we call it we call it dynamic thresholding, right? So if you think of it, in these, and false positives and negatives are only applicable in classification algorithms. Right. So for the viewers, like, you need to decide at what percentage point do you classify a finding to be present or absent. So so let's say you choose 50%. So if the AI says 51, you say present, and if it says 49, you say absent. Which is actually a very big penalty to give to the algorithm, right? Because just 2 percentage points and you're forcing it to do that. So what we suggest, Manish ji, on that front is to figure out what is the optimal positivity or negativity threshold based on specific clinical scenarios. So the way to do it would be that, let's say there is a chest X-ray algorithm, and it says whether an image has cancer or infection, right? The easiest way to tweak this threshold would be to ask, does the patient have fever, right? And if the answer to that is yes, then you make the cancer threshold really high and the infection threshold really low. And if it says no, the patient doesn't have fever, has weight loss for the last 3 months, then you invert the threshold. So that's the way we think about this. Very difficult, because you need to really get into each clinical entity and try to figure these things out. But certainly, like, someone has to do it.
Maybe one last quick question I would tempted to ask.
Please.
Does it help you when AI algorithm is also able to estimate its uncertainty? It's because again, I mean, when it's wrong, right? I mean, ideally you would like AI algorithm to also flag that, look, I'm not so sure. Just like a doctor, right, would say, oh, in this case, I want to seek a second opinion. But often deep learning algorithms are not able to estimate their uncertainty. So any
so we've been working on this. Like, I'm so glad that you're bringing out these things. Maybe this is not the right forum, but whenever we ask any deep learning engineer for confidence intervals on the probability estimate that is given by them, they get a little jittery and all that. But I think that is actually key. The ability of an AI to say, I don't know, is is absolutely key. And we are seeing this in bias. We do a lot of work on bias as well. If your algorithm has truly been trained only on North American data, then you ask for the ethnicity of the patient. And if it's Indian, then you just say, I don't know, right? You just filter it out at that extent. I think that the problem is we force AI algorithms to make decisions. And then we judge them on those forced decisions. So short answer is that certainly, like, having those confidence intervals or whatever of the probability outputs, and not just taking a max or a mean or a something would be very, very helpful. But then again, those things have to be done pre-deployment, and then only once you've tweaked those parameters, as we do with MRI machines all the time, you keep tweaking parameters to get the best possible image. You keep tweaking these parameters, and over time things settle down. I will certainly connect with you, Manishji, offline.
Sure.
Thanks, Dr. Mahajan. So we'll move to our next panel discussion.
Thank you.
Which is basically about software engineering opportunities and challenging in healthcare AI. So I will invite Dr. Manish Gupta from Google to take this forward.
Thanks, Amit. So again, it's a pleasure to welcome my fellow panelists to this very interesting topic. So I'm pleased to welcome Mr. Sridhar Turaga, who's the Vice President at CTS Tech, Healthcare Technology Company. Mr. Rajesh Balasubramaniam, who's CEO at Avohi, and Mr. David Zakem, who's again Vice President at Swiggy. So welcome. So I'll start with just a few maybe opening remarks from my side, and then turn it over to our panelists. So I think we have, again, as we have seen in many talks throughout today, including the last talk, last couple of talks from the doctors, Dr. Santosh and then Dr. Mahajan, to different areas, cardiovascular disease and various kinds of diseases like cancer and so on, that you try and detect through imaging. We've seen that potential. And one of the ways in which I like to think in terms of the overall opportunity of AI is that in healthcare, we often have this saying, prevention is better than cure, right? And you've seen that how COVID has really brought that come alive, right? That we want to ideally, right, prevent ourselves from getting COVID. But generalizing that, if through AI, you can take early action on a disease, right? So when we know very well that for various forms of cancer, be it breast cancer, lung cancer, and so on, if you're able to diagnose these conditions at an early stage, it leads to much better outcomes for people and lower cost. Dr. Santosh talked about, again, even in the context of cardiovascular disease, right? The key to really bringing down the number of deaths, bringing down the number of heart attacks, is really take proactive action, right? If we can encourage people to invest in their wellness and take early action when they have, let's say, hypertension, keep it under control, whether through lifestyle changes or, if necessary, blood pressure medication, you're able to achieve much better outcomes. And this is where we see AI can play an enormous role, right, in really helping you. And we've already seen many of these examples, right? We're beginning to see so many AI-based imaging solutions, which, looking at images of, let's say, mammography, are able to help doctors diagnose whether it's a case of breast cancer. In fact, there's been my, again, ex-colleague Geeta Manjunath, who's been doing this very interesting work in Niramai on even applying AI to thermal images to detect breast cancer. And again, there's been work done at, for instance, Google Research, applying these techniques to lung cancer, various forms of cancer, and achieving results which are comparable to the specialists. On the other hand, we also know about so many challenges that remain in this field, right? And often the challenge starts with even the data. How do you get access to the right kind of data? And often, even while collecting health data, there there have to be a lot of privacy related issues that need to be addressed, because health data is extremely sensitive. So you want to honor the privacy of the individual when you're analyzing their data. And even once you deal with all of these data issues, once you have clean data, there are so many outstanding challenges in terms of modeling. And we just, in the previous talk, I was just asking Dr. Mahajan some of these questions related to how do you have the AI algorithm also tell you how much confidence it has in its recommendation, right? Because often, unlike humans, AI systems don't know that they don't know. How do you explain the results of the AI algorithm to the human? And I mean, ultimately, how do you also generalize? Because a number of speakers have talked about this problem of if you have been built your algorithms based on analyzing data, let's say from the Western world, is it really safe to apply that algorithm on Indian patient data, where the algorithm may miss and come up with kind of bad predictions? So a lot of issues. So I'd like to now turn it over to our panelists to start throwing light on some of these issues. So as a first step, I'm going to ask each of them to maybe define kind of the scope, the problem scope that they or their organization are addressing, and tell us about their work in this space, and then we'll have follow-up discussion, right, on some specific success stories, challenges, and so on. So let me start with maybe you, Sridhar. Would you like to tell us about the work that you
Absolutely. Thank you, Manish. I hope you can hear me all right.
Yeah.
So I run our digital innovation and data science group at CTS Tech, which is a large healthcare technology innovation services company. And I'm actually new to healthcare, but I've dabbled in this analytics data science space for the last couple of years in my previous role running delivery and innovation at Mu Sigma. So my lens kind of is both healthcare centric and across industries in a sense. While I am quite immersed into some of this technology and innovation, I'm particularly focused on how do you derive value out of all of this for organizations, because how to scale and deliver value is a different problem than building the underlying technology itself. And I think both questions are slightly different. So I may tend to take that lens a little bit here. Specific to what me and my team are currently focused on, Sirius Tech, we are actually focused on a certain dimension of this AI in healthcare. First and foremost, we're focused on how do you enable decisions, both clinical and operational decisions in these organizations, and apply technology that is maybe available. We talked about a couple of interesting companies today that have already built the algorithm, but having the algorithm, having the technology is different than implementing it in real life and deriving value out of it. So that we kind of broadly call as how do you embed intelligence at the edges where people can make it part of their workflow and decision making. This is a human problem. There is a technology integration problem. The second area that we are focused on is the challenge of dealing with difficult data. I don't like the word big data. It is kind of in some ways misleading, but I like the word difficult data. Healthcare, for a variety of reasons, is a lot of difficult data. Difficult from a privacy perspective, difficult from a format perspective, whether it's text, imaging, genomics, and just interoperability problems. Particularly US healthcare is very localized and in some ways fragmented. It poses its own challenges. The third aspect is scaling AI. How do you then bring in AI into products, into systems, into workflows, what we call as AI engineering? So broadly, at least me and my team are focused on this aspect as much as we are focused on building the algorithms and building these solutions. We're more focused on how do you kind of enable deployment and application at scale. So my lens tends to be that. One last comment I want to make is I do tend to think of AI, machine learning, and analytics as a continuum. I think that sometimes disservice is done by just looking at AI in itself, and I think there's a continuum there. And in one of my favorite players, Sachin Tendulkar, who scored a lot of runs, scored 70% singles. So I think there's no shame in having low-hanging fruit and simple problems to solve, while you want an occasional sixer as well. So I tend to, also focus on running between wickets as a strategy as well. So that's kind of my quick lens of the world.
Thanks, Sridhar. So, so Rajesh, let me turn to you next. If you could tell us about the work you've been doing at Avohi.
Okay. Hi to all. Thanks, Manish. So we as Avohi is a 15 years old organization. We started with healthcare product engineering in the US market and continue to work in the healthcare and agri-tech in the most of our customer service deliveries. And together we serve more than 60% in this industry ecosystem. We are on 100 plus resources. Now, presently, we focus more in particularly to talking about the healthcare ecosystem. We work more on the wearable devices, bring the data, and also to the elderly care ecosystem to basically work collecting the data and working around the data to give the predictive data to the specific clinical research and also to the healthcare doctor ecosystem to provide the data for them to analyze before the treatment, also emergency care. And in the recent times, we worked in the other problem solving with the pediatrician ecosystem for the child care, which we work along with the leading baby diaper manufacturers, and which we work with a sensor-driven platform building. And top of that, we now we start collecting the data from last 1 year and bring up a lot of the clinical research to work on the data around the child care. So this particular product is yet to hit the market, but it is already in the trial from last 1.5 years. Basically, it's the device which is measure the wetness of the diaper, and which gives the data back in the cloud, and we analyze the data. We bring in the various parameters to the clinical data to the pediatrician as well as for the child care ecosystem for them to look at it, the various parameters on the age based and different conditions, different health condition based on the trialing it. So we are in the very initial stage in the AI on that. So now we have enough data to start analyzing it. Also, just we are in the study phase now. So it as a company, we see the challenge in the recent times, in particular healthcare, and also we focus more on the elderly care and more work on the device based, bringing the data and working around the data. And we see that the IoT is playing a role now on various parameters, capturing the parameters remotely. We see that now that it's getting improvising the IoT enablement, also the different wearable devices and platforms are coming together, and it's getting improved. And at the same time, the Indian context, our engineers are yet to get hands-on the real data, and so and getting educated and much better than previous years. So it's all we are on a learning. We are very early stage in our AI, but we are last 1-2 years we practicing in the AI space, and specifically into the healthcare. And so other industries, we work in the agri-tech. We are doing a lot in the lot of the space. Let us not bring up those topics here without make sense. But we are doing very interesting projects in the agri-tech space. Your voice is not audible.
So thanks, Rajesh. So David, let me turn it to you. So if you could tell us about again your interest in healthcare and some of the work that you're doing, which is relevant.
Thanks, Manish. Sridhar and Rajesh, very impressive hearing from you guys. I must say off the bat that I'm kind of the joker in the pack. Okay, in the sense that I currently head analytics for Swiggy. We deliver food. We have nothing to do with healthcare. I started off my career as a biotech engineer, by the way. First 3 years I actually spent in writing algorithms to discover drugs using computers, much ahead of its time. But then 14 years after that, I've primarily been in the AI analytics data science space. Last 2.5 years I've been at Swiggy. I think my involvement here is more to actually show to you that a digital native company like Swiggy company which has AI kind of embedded in everything we do, like Swiggy, the food delivery part of Swiggy, right? Is there any learnings that I can bring to the table from what a company like Swiggy does? That's what my involvement here is. I've also done about 11 years of analytics consulting. So I've seen my fair share of healthcare, but I won't definitely say that I'm a healthcare expert. I'm more of a food delivery Swiggy expert slash analytics expert than anything on healthcare.
Thanks. Do you want to? Okay, so I'd like to hear some success stories, right? So from each of you, from any of you who would like to speak, with the work that you've been doing, are there one or two success stories that you can share with the audience about where you've seen, again, technology being applied to really make a difference?
Sridhar, Rajesh, do you guys want to start, or I can start myself as well?
Yeah, go ahead, David.
Okay. See, one of the things that I actually feel very strongly about is many people think of AI as a thing to do. So I want to do AI. I feel very strongly that it needs to be helping businesses get the outcomes that they want. And then any AI, right, has to fit into the existing business processes. Okay. So let's just take the example of 6 or 7 years ago when you were ordering food, right? You would call up a restaurant and say, "Hey, restaurant, I need a biryani," for example. Okay. And after a few minutes, you call up the restaurant and say, "Bhaiya, where's my food?" And the guy will be like, "Ladka has left 5 minutes ago, Ladka has left 10 minutes ago," things like that. Okay. That, if you look at it, is the business process that was happening in that restaurant at that point of time. And now you want to put AI in the process. You can actually make a very fancy model which says the food is going to be ready in 15 minutes and it will take you 20 minutes for that food to be delivered. Okay. But that by itself is not very useful. What you need to do is there a way you can incorporate it into the business process that is currently running? So now if you have an app, you're doing the exact same thing as you would do in a normal world, which is telling the restaurant, "I want a biryani," for example. But what the app does now is kind of takes that AI of the food is going to take 15 minutes to prepare, the driver is going to take 20 minutes, and incorporates into the business process of how the food is delivered. So the point I want to make is it's very good. So I can talk to you at length about what it takes to deliver food, but then the important point I want to make is that once AI is embedded into the existing business process, that's when the real value add of that AI comes in. Many companies actually think of AI as a thing to do, as opposed to AI is one of the 20-30 tools that you have to change the way you do your business. The thing is, the business process has to be the same, and you're using the tools you have to actually make the business process a little better. So think of AI as a tool to make the process better, as opposed to an end in itself. Okay, that's the big point I want to make.
So quickly, I see a comment from Dr. Santosh in the chat window that food is one of the most important risk factors for cardiovascular diseases and cancer. So Swiggy has a role. Any comments?
We do realize that, and very consciously, there are consumers are telling us the same thing as well, by the way. So every January, you will see this post on social media saying, "I'm giving up Swiggy, I'm uninstalling the app," things like that. Ordering in food seems to have been synonymous with eating bad food for most of us, because we want to have that rich food when we order in. And I gave the biryani example and immediately saw this and regretted it. Okay. The thing is, we have a section of our app called Health Hub. Actually tells you protein content, carbohydrates, plus sodium content, any of the important nutritional facts. And we are working with restaurants to actually ensure that they actually curate healthy food items. So anyone looking for healthy items, it's just a tab. Many restaurants have a tab for menu, and there's a tab for healthy items. You just click on the healthy items tab, and you get a bunch of healthy items. So this thing about ordering in or eating outside food equals to eating the unhealthy, very rich food. Actually, we want to disassociate ourselves. You can order food in, and it can be healthy as well. And we are creating a whole section of the app dedicated to having that healthy food. Okay, so that's what I would say to Dr. Santosh.
That sounds great. I think it's great for consumers, and I think down the road would be great for everybody. So Sridhar, Rajesh, would you like to maybe Sridhar? Okay, do you want to go
can I go next, Rajesh? Yeah. So I want to actually share an interesting space where we are deploying AI machine learning to drive business impact. This is in the what we call as the payer space, the insurance space of healthcare. Because usually when people think of healthcare, they're either thinking about a provider or they are thinking about the life sciences company, but there is a big system in between of health insurance companies, and it actually creates a lot of interesting opportunities as well. In fact, if they don't pay, a lot of care never happens, particularly in the US market. So the problem that we are focused on is that US healthcare system, for a variety of reasons, could be legacy reasons, is very, very localized. So there's a lot of local hospital networks and associated state-specific regulations and state-specific providers. So there's a lot of insurance tends to be very local. While there are big national players, there is also a lot of local players. And what the US regulatory market and the government agencies do is that they put out these rating systems by which they rate the quality of the care, both for providers and payers, and they use that to incent behavior. You talked about prevention better than cure. How do you enable that as a system and kind of enable that? Yeah, it's not the most successful model that you want to learn from, but there's a lot of investment in time and effort. One of the interesting ratings is something called the STARS rating, which is used to drive behavior of payers and providers related to the government market, the Medicaid market. Now, the problem happens that you want to improve quality of care, then you have a whole bunch of metrics that you're focused on. For example, if you were to proactively get women of a certain age to take a osteoporosis test, that you are in a way reducing cost of care a couple of years down the line. Now, how do you incent that behavior? And more importantly, for an organization, how do you determine how to improve your rating? Because there's direct implication to your pricing power, acquisition of members, as well as direct rebates. And rebates are a great way to change behavior in a healthcare system. So what we've done is we've kind of developed this large AI-enabled workbench for the entire payer organization to focus on this goal of improving rating, because it's a very measurable rating. The government publishes it and has direct value attributed to it. And I think that is one of the reasons why we are seeing success in that. There's a clear ROI to improving that rating. Now, underneath that rating, we are helping them make decisions around where do you put your energies this year, because your resources are limited. You can't chase every lever out there to improve the quality of care, what is called as proactive care, which is an important lever to improve quality of care. And then after you kind of decide where you want to put your energies, how do you then kind of have individual actions that you want to take, which members to target, which disease conditions actually have exorbitant high cost to the system, taking you away from. I think Dr. Santosh talked about which situations go to primary care versus a specialist. Where does virtual care come in? Can you nudge behavior towards virtual care, which can reduce cost? And then when you run these individual actions, then how do you then use this learning loop to feedback? So this is, I think, we are seeing considerable traction. We've built a platform called the STARS Decision Engine, and we're able to impact behavior of not just the provider, the payer, and their ratings, but individual actions at a member level, and also actions at a provider system and an entire ecosystem of healthcare in a particular state to improve the quality and reduce the cost. I think that's an example that we're very proud of what we are doing, and it's actually a very clear ROI both for the organization and at an individual healthcare member level.
Kept on mute, Manish.
Oh, I'm sorry. Yeah. There's some background noise. So Rajesh, yeah.
Okay. This COVID time we done in the healthcare ecosystem to the industries and the educational space. We built the AI engine top of the existing cameras, which we use through the thermal cameras. We used to sensitize the and monitor the social distancing, also recognize the face and also the body temperature. We bring up the health data which is been push to the organization to give the alerts in the predictive alerts and alerts in the various parameters, to give the data back to them, telling that this has been cautious information to give the health department team to the organization as well as the institution to for the social distancing one. The second is also that looking at the kids' body temperature over the week, over the days, and keeping the both the data, not by the ID or by the face recognition through the camera, which we pick. On the thermal camera, pick the temperature of the body temperature of each of the the movement, and which is bring back that our engine works around the kind through the face as well as the temperature and the social distancing what they maintain it, and give the constant alert and predictive data to the team in that organization who are responsible for the health of the resource well-being department will take care of it, which has been successfully we implemented a couple of organizations, a couple of institutions to in a trial basis, and probably when this coming May or June onwards we can see this our platform around the most of the schools and institutions and in that the work environment to give the simple platform using the existing cameras in thermal cameras to predict to and give the much healthier environment for them. Short what we're doing is interesting in the space now.
Thanks. So Dr. Santosh posted this interesting comment directed to David. So he said that the last mile delivery, right, can have tremendous impact on, is often a big challenge in healthcare. So, and he makes this observation that for every ASHA worker of the government, there are 3 Swiggy, Zomato, or whatever people on the ground, right, with the additional advantage of all of these people are geotagged. Could companies like Swiggy play a role, right, in the last mile delivery of healthcare services?
Absolutely, Dr. Santosh. Excellent idea. So if you look at what food delivery is, right, it is food is perishable in the sense that if your pizza gets cold, it doesn't taste as good. If your ice cream melts, it loses its purpose. It is fragile, so you don't want your coffee getting spilled. You don't want your pani puri ka puri getting cracked on the way. It is real time. If you're hungry and you don't get your food in 30 minutes, you're going to be very, very angry about it. And it is hyper local in the sense that you want to order from nearby places. So if you look at this perishable, fragile, real time, hyper local, companies like Swiggy have kind of optimized this entire space of the logistics for it. So probably nobody in the world can actually do this kind of hyper local logistics. What we lack, we don't have any zero healthcare skills or healthcare abilities. But we do have like lakhs of people on the roads with the full training and the technology backing to actually do this last mile delivery. So great idea from Dr. Santosh. What we'll need to figure out is when you say delivery of healthcare, if it is like, hey, I'm delivering this vial of vaccine to somebody, right? That's fairly straightforward. We should be easily able to do it. It's no different from delivering a coffee or an ice cream. If that injection has to be put in somebody, that's a problem because our guys don't know how to do it. So now the question is, how can we use the skills that these companies have? If you remove the real-time component, then you have companies like Amazon, Flipkart, which are also very, very good in the logistics space coming in here. The question is, how do we get the healthcare components into these logistics systems? And then we just unlock the next level of value for healthcare coming from these companies. Okay. So, there is a joke, Manish, which is, why do we need so many days for the vaccine to be given out to people? So Amazon posted saying, hey, we'll deliver it the next day. And to which we were thinking of posting, hey, we'll give it in 30 minutes. Just a joke, okay? No offense meant.
So let me again, we talked a little bit earlier about the challenges. So let me again, because healthcare is a very complex area. It's a heavily regulated area. There are challenges in data. There are challenges in building models. There are challenges in validation. So maybe I'd like to hear about some of the challenges that some of you have faced, and what has been your approach to dealing with these challenges. And also, I mean, if you have any points to make about, okay, what could be done, right, at the government level or in terms of additional research to be done to meet these challenges, would love to hear your thoughts. So,
yeah, then I'll take a shot at it. As I'm being a keen student on healthcare, being new to this space, and in comparing with my journey in other industries in implementing and deploying AI ML analytics, there's a couple of things that absolutely stand out, and we just, I think, have to respect that if you want to really drive the impact that we all aspire to. I think firstly, this may be a characteristic of the US healthcare market, may not be true. I'm 100% sure it's not true for UK or India or other markets. I'll talk about the US healthcare market, which I'm immersed in. For a variety of reasons, it is very fragmented. Now, when most people, when they think of healthcare, they either think about the big medtech companies or the life sciences companies, but there is a huge long tail of providers and payers, and there's a lot more of that in healthcare than these two players alone. One of the problems with the fragmented market is that nobody has critical mass. You don't have critical mass of resources. If you're a CIO of a provider system, or you're a CIO of a system, chances are you don't have the resources, to build these underlying capabilities and deploy them at scale. And this is what I think a lot of service providers and technologies companies underestimate, that they are very, very resource constrained. Now, I don't mean resources from a financial perspective, but bandwidth, location, and an attention perspective. There's no critical mass. Now, the one fascinating question to think about, particularly for anybody selling into this space or trying to innovate in this space, is that, is there a different strategy if you take, if you realize that majority of the companies are actually mid-market companies? Would you take a slightly different approach versus selling into the large enterprise customers? And I think many of the technology providers, who want to make AI successful, actually use their mindset of large enterprise customers into this mid-market segment. And I think there's a slightly, one important implication of that is, I believe that a lot of pre-built models will be very, very successful. They may not be as accurate as custom bespoke models, but because there's no critical mass, their ability to have enough data and train and develop their own custom models is very, very limited. So I think this is a huge opportunity, particularly coming out of India, to have pre-built models. There's a lot of interesting work we are doing in NLP to interpret clinical notes and extract information out of it, and they are actually quite location neutral. They're not very population sensitive in some ways. So I think that's a big obstacle as a huge opportunity to think about. I think the second thing, I think the regulatory nature is just one of those things you just have to accept, that there's a lot of sensitivity, fear, and maybe valid regulation that prevents them from making decisions very quickly. Now, this is also poses a lot of problems for AI, because one of the assumptions you make whenever you build any AI machine learning algorithm is learning. You assume that it'll learn and improve over time, but in such a heavily regulated market, how do you deploy these algorithms when it is so difficult to refresh it? When you kind of literally shoot and forget, and it's like, it's like the Mars mission that's going on. You have these 20-minute cycle before you get a response back. How do you have a live conversation? I just fundamentally think that you have to reimagine the architectures and the approaches a little bit, for the fact that you don't have those rapid feedback cycles that you take for granted in many other industries. And I think that's very important. Last but not the least, there is a huge amount of legacy and closed systems out there, whether it is products or systems, or variety of reasons. Maybe it is because of the nature of the market. So everybody gets very excited about cloud and microservices architectures, but there is still so much Java, C++, C out there. And believe it or not, if you have an algorithm that works in C++, C, and Java, there's a tremendous market for that. On-premise, native, working on a legacy system. So I think that while the excitement about the new possibilities of the cloud, etc., are very, very important, those computation capabilities are very powerful. The reality is that 99% of the market will be on-premise, local, with legacy products and legacy systems. I think it will do a lot of good to be excited about that as well.
Thanks, Sridhar. So, so you brought out a number of important issues, right? Of this whole fragmented nature, some of the how to deal with legacy. I was very intrigued by the observation, right, that you also make about regulation implying, right, that you don't have that ability to refresh. So, could you talk a little bit about again? I mean, how you have dealt with those challenges in the context of
It's a problem. I don't know the answer to it. If I knew, I wouldn't be on this call. I would go and solve it. But having said that, I think that it goes back to one of the comments I said in the start, is to think about decision making as a continuum. I think once you forget about the hat of AI and just say decision systems, this could be statistics, this could be analytics, this could be AI, this could be machine learning, and for example, RPA. So one of the choices we made recently is actually merged our RPA and our data science teams together. Now, traditionally, people don't think that they go together because RPA is associated with automation and bots, and AI is like this cool algorithms team. You tend to kind of, so I think one way to get around this problem, I feel, is a little bit of, it's a human problem, which is to break these, roles that people have. Somebody is an AI engineer, somebody is a software engineer, somebody is a data engineer, somebody is an RPA engineer. If you actually break that silos and create multifunctional teams, I feel you tend to find a little bit more appropriate technology for the appropriate problem. Many of the problems don't need such heavy duty deep learning algorithms, which are not explainable, hard to refresh, data hungry, that we get excited about very easily. I think that is one angle to think about. I think that just maybe the structure of the way organizations are set up is forcing almost like a lens, colored lens into problem solving. So that is, it's not a technical solution to the problem you're talking about, but I think it's an organizational problem. I think technically, what we are seeing is that we are thinking about one of the area we are seeing progress to your question technically is federated models. I'm very, very excited by some of the work I'm seeing where multiple organizations are coming together in a consortium and using the concept of federated model. I think it is going to be that and synthetic data generation. I think these two technologies, of all the technologies, I think are going to transform healthcare, because synthetic data generation is solving the problem of access in very interesting ways, and in fact multiplying data, and federated models are allowing multiple organizations who don't have critical mass or are afraid of data privacy issues to come together and build algorithms. So I would really put my money on those two more than anything else.
Sure. And I'm going to convey some of your comments to my colleagues at Google Research who invented federated learning. They'll be pleased to hear about, again, we certainly have seen a lot of impact of that within Google, but it's great to see so many organizations using it. So Rajesh, if you could talk about some of the challenges that you have faced and how you have dealt with them.
Manish, most is Sridhar is covered in this what challenges we face. Now, as I see that regulations and the data standards is helping us to better way to manage the data. So also the algorithms, the engine, what we training it has been helping us a lot. And the challenges is the initial days challenges is the engineers who have the specific industry domain expertise or the data expertise. But now we see we also scaled up, and the standards and the regulations has also been helping us to be trained better in our engines and algorithms together. I think another year time we can able to solve most of the problems and most of specific data in the clinical areas. Also now NIDIA try to build and streamline the most of the data in India itself, like our US, like a HL7 standards, or in Europe and India to start working on it. Going forward, we can see that a lot of improvement in using technology in the Indian healthcare ecosystem.
Sounds good. So I think we are running out of time. So I'm going to just ask each of you to maybe make some closing remarks for the audience, and then let's bring this to a closure.
David, you want to go first?
David, do you want to start first?
I'll go last this time.
Okay.
Rajesh, I'll go next.
I think it's like now we are in the early stage in the health using a technology, in particular the AI in healthcare. Going forward, we can see the lot of change in the healthcare practice using technologies, and in particularly machine learning and AI, and as well as with IoT will play a bigger role in the next 3 years, and we can see the next 2 years there's a lot of improvement and ease of using technology in the healthcare ecosystem.
Thanks. Sridhar?
Yeah. So Manish, thank you for an interactive discussion. I was dreading making a PPT, 700 PPT for the week, so thank you very much. I was going to make one final comment that I think my favorite person is Feynman, and I always show people Feynman diagram in the background saying if quantum physics can be simplified into a diagram, so can AI be. I think I think one of the most exciting things to think about is what is a common language people can use to design and collaborate on AI. Like we had ER diagrams, there should be some equivalent of that. So I don't know what the answer is, I'm sure. I hope Google research picks that up as a cool problem to think about, but a common language I think would help a lot.
No, great thoughts, Peter, and a nice problem. I know Google research folks have been talking about like these. I'm forgetting the term, but basically a way to democratize the use of AI, allow automated AI models to be built. But you're talking about something even beyond that, right? I mean, a single language. So, David, any final thoughts from you?
One thought. I look at AI as a human problem. Okay, so I'll explain what that means. Most people think of AI as when they talk about it, right? They talk about it as this fancy secret sauce oil that I have, which is the cure to all your problems. While it might be, what is also needed is the decision makers, most of the senior executives, they are actually daunted by all the mathematics that we talk about, all this fancy technology that we talk about. So when I say it's a human problem, they actually need to understand the potential of this, how to actually make it real, what changes they have to do in the way they are doing their business to ensure that they get benefit from AI. So I think there's a lack of, like Sridhar said, there's a language, right? Not just the language for AI, we also need a language for translation, so to speak, which is there is the AI world and then there is the business, and they don't understand each other. There may be some people or things, whatever it is, that kind of sit in between and explain to the business decision makers that, hey, this is what AI actually means. Typically in conferences, right? People are like, hey, that person's talked so much about ML AI कि मलाई बेच दिया, ML AI मलाई, okay? मलाई बेच के आगे वो लोग. That's what people say. मलाई बेचना नहीं है. मलाई से we need to get the business to actually get benefit. So which means the maybe translation and ways for business people to work with the AI world is something that is that we are in dire need of, is what I would say.
No, very well put. And I'll add a few thoughts from my side as well. So again, at least for some of the young people in the audience, right? I mean, I'd like to just also provide a bit of a historical perspective, right? I mean, when I studied computer science, right, and I even graduated, so I used to work on this whole field of supercomputing, high performance computing. And again, I mean, in fact, I remember one of my friends asking me, why are you even doing this PhD in computer science? What's there to research in computer science, right? And what we have seen is, again, I mean, through these really exponential advances in computing, I mean, I remember being in that supercomputing area. I remember the time when India was denied the the permission to import a particular supercomputer built by Cray, because the US government said, oh, we might use it for nuclear simulation purposes. And today, the mobiles that we all carry, they have more computational power than that Cray supercomputer. So the point I am making is that we are at this really, really unique moment in history when computing has become so powerful, right? And I mean, today that same friend doesn't ask me, oh, what's the need to do research in computing? I mean, you've seen the impact of computing, right, on each and every industry, right? You have a person from Swiggy, right, food delivery world, right, talking about AI and how they embed AI into their operations. So really, computing has really gone into each and every aspect of how we run the world. So I feel, again, for especially the young people in the audience, we are at this amazing moment in history where you can apply computing, the power of computing, right, to make a real difference. And there are, again, all kinds of areas in which you can work and make a difference. But I would say nothing that comes close to the kind of that's as exciting and as meaningful and as hard as something like healthcare, right? As we have heard from some of the talks and so on, the problems are fascinating, but it's a very, very tough area. And still there's a huge long way for us to go, right, before we start to see the real impact of all of these AI ML solutions, right, on how decisions are being made in clinics, how hospitals and everybody is using all of this fancy malai, right? I mean, I like your term, David. But again, I mean, it's an amazing area, right, for people. I mean, if people are looking for, okay, what to do with the rest of my life, it's a fascinating area, right, to do further work in. So I would really encourage, at least, especially the younger people in the audience, right, to go and pursue some of the challenges that you see, especially in the healthcare area. So with that, let me thank all the panelists for all of their thoughts, for a wonderful discussion. And let me hand it back to Jagdish to provide the closing remarks for this session.
Thank you, Manish. Thank you, panelists. I think it's been an extremely enlightening day from the starting of the session to today, to now as we close today's session. I think the very fact that it's a fantastic day for discussion on the points that we talked on health tech. As Dr. Murali rightly said, India is an elephant, right? We have a population of 1 billion. One session can never be prescriptive. So, and if we have to follow that formula, we actually followed that formula, I think, in some way this year as we started in a CII to define AI India. We've actually got, I think we should have told Dr. Murali, we've got a month of AI. So from that perspective, we've actually lived up to the elephant's requirements. We all learned a lot today. The speed at scale methodology, which I talked about in the opening, I think that's an important part of what health tech can bring. And this year, like no other year, has it been proven. The focus on startups, the global business models like the Ireland model, an action-based, deregulated, relevant education system, the focus on building an ecosystem with the right frameworks, and then the sessions on lifestyle management, medical management, and new enablement techniques to even battle breast cancer was exhilarating. The future of AI in the workplace, again, is very interesting. It's interesting to see how from food industry to health industry and beyond, AI unites us in speaking one common language. So, if there's one thing that we were hoping for in India, that we could speak to each other, maybe AI will help us connect that multiple language setup. Special thanks to Dr. Anurag Agarwal for extrapolating on opportunities for AI in healthcare. He was the opening keynote speaker for us and was brilliant. Pankaj Kakkar from Tech Mahindra for talking on making India a global AI hub for healthcare, brilliantly articulated how we could leverage the skills, the talent, and the data. And then thanks to Dr. Kaushik Murali, Dr. Rao, Kaveen Kumar, Jagdish Muriani, Vikas Jha, Rizwan, Vaibhav Tiwari for the insights into seeding AI education. Thanks to Dr. Santosh Satish for the short talk on AI and heart disease, Dr. Geeta Manjunath for a talk on breast cancer and AI, and Dr. Vidur Mahajan for the conversation on deployment of AI in clinical settings. I think the last panel that you were just on, the rest of the guys, Dr. Manish Gupta, thanks to you, Sridhar Turaga, Rajesh Kumar, David Zakam, for all the software opportunities and challenges in health tech. Last but not the least, my folks from CII, Amit, Prateek, Siddharth from the CII team, brilliant job in helping this through. And welcome to the next stage of CII AgriTech. As we all know that, health tech, as we know that it's going to boost India's annual growth significantly. So here is an opportunity for us to participate. We have a complete festival of AI for the next 30 days. And there is a national conference on AI on the 18th and 19th of March, which primarily focuses on leveraging AI responsibly for inclusive growth and national strategy and AI partnership and investment in about 13 odd sectors. So I can only thank you all for bringing together such an elite panel of speakers. I hope our listeners had a great time. Again, I'll remind people that this is the start. We have a 30-day program in AI India, and let's celebrate the festival of AI and make it a part of India's business in everything. Thank you.
Thank you.
Thank you, Mr. Jagdish Mitra. I would like to express my appreciation to our all panelists and task force members, Mr. Jagdish Mitra, Dr. Manish Gupta, Mr. Vikas Jha, Mr. Jagdish Murjani, and Mr. Rajesh Kumar for their enthusiastic support and making this extraordinary conference session a possibility. Our heartfelt thanks to all delegates, not only for their active participation, but also sparing their valuable time with us today. With these warm words and a kind message, we move to the end of today's conference session. Thank you and wish you all healthy and safe weekend. Goodbye and stay blessed.
Thanks for that. Bye.